Hello, hello, hello. Check, check, hello, hello. Check.
गणाय गणदैवताय गणाध्यक्षाय धीमहि शरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणाधीनाय गुणाधीशाय गुणप्रविष्टाय धीमहि प्रदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि
Good morning. A very warm welcome to you all. This is the fourth Criticare Convention in which we had a critical care nutrition workshop yesterday. There were about 200 registrants, and today we are having ID Critical Care. We start our academic program right away with the blessings of God Almighty and our parents. And I'm happy to see my teachers, Dr. Tanuja ma'am, Dr. Hole ma'am here in this program. I welcome Dr. Soman sir from Pune, Dr. Geetu Jo, Dr. Parikshit Prayag, and our own ID consultants from Nagpur, Dr. Ashwini, Dr. Nitin, for this program as a faculty. Wish you all an engaging, enriching and academically stimulating scientific program all day ahead. Thank you. And let's begin, Monica and Shweta, with our academic program. Thank you.
Good morning, everyone. I am Dr. Monica. Welcome you all to the day 2 of
I hope everyone is feeling well nourished, and both literally from breakfast and figuratively from yesterday's deep dive into nutrition in ICU.
On behalf of the entire organization committee and Criticare Hospital, with immense pleasure and gratitude, we want to extend our warmest possible welcome to our distinguished faculty, speakers, and delegates. Your presence here is the positive pressure this convention needs to keep the saturations high.
We truly are delighted to have you with us. We hope you had a chance to metabolize yesterday's data on metabolic architecture. Though, judging by the energy of breakfast bar, I suspect the trophic feeding of caffeine was most successful intervention at the morning.
Indeed, Shweta, it's a fair trade. But as we transition into today, we face a sophisticated pivot. While yesterday was about nourishing the resilience of the patient, today we shift our lens towards identifying and neutralizing the infectious threats that target them.
And this is the beauty of our annual Criticare Convention. Every year we gather here, every year the challenges are new. We rotate our focus because ICU never stops moving and never we do.
Exactly, Shweta. This culture of constant evolution is something we owe to the primary architect of our growth, Dr. Deepak Jiswani. This annual gathering is a living tribute to his hard work, dedication to patient care, and belief in advancement of science. Sir, you have always taught us that the moment we think we have mastered the ICU is the moment we have stopped being effective clinicians.
Exactly. Deepak sir, you taught us that while the bugs we study are infectious, so is the pursuit of clinical perfection. It's thanks to your mentorship that we have this platform to learn, to challenge, and to evolve.
So as they say, महफिल सजती है जब मिलते हैं सब दिलदार, महफिल सजती है जब मिलते हैं सब दिलदार, सीखने का जज्बा हो तो हर मुश्किल है बेजार। क्रिटिकेयर के इस मंच पर आपका स्वागत है दोस्तों, यहाँ इल्म की बातें होंगी और दोस्ती बेशुमार। So, as we open this second day, let us channel the spirit of inquiry. Let's keep our questions rigorous and our collaboration active. Dr. Shweta, I believe it's time to move from theory to practice.
We often learn most of the patient from our patients who challenge our assumption and push the boundaries of protocols.
Yes, Shweta, they say that patients are our greatest teachers. Our next presenter has brought us a case that perfectly illustrates this in his case presentation.
For this session, we would like to invite our expert panel of real experts in the field, Dr. Rajiv Soman, Dr. Tanuja Manohar, and Dr. Geetu Jo. Dr. Rajiv Soman is Senior Consultant ID Specialist, Jupiter Hospital, Pune. Dr. Tanuja Manohar, ma'am, Professor and Head, Department of Medicine, NKP Science and LMH Nagpur. And Dr. Geetu Jo, Consultant Microbiologist at Jupiter Hospital, Pune.
It is now our distinct honor to introduce our first speaker, Dr. Rahul Baghel, who is a critical care specialist in Criticare Hospital, Nagpur.
Sir. Good morning. Chalo. Over to you, Rahul.
Over to you, Rahul.
Good morning, all respected teachers, seniors, and colleagues. I am Dr. Rahul Baghel, working at Criticare Hospital as a physician and intensivist. Today, I'm going to present a case that we encountered recently in our ICU. A 44-year-old male patient presented, salesman by profession, presented with complaints of fever, intermittent, high grade, with chills since 3 months. Associated with right knee and right elbow swelling and pain since last 15 days, and dry cough and difficulty breathing since last 10 days. He was a resident of Chandrapur and he was salesman by profession. Reviewing this past history, we found that he had, it all started in October 25 with left shoulder pain. Before that, he had fever, and that left shoulder pain was diagnosed as osteomyelitis of left humerus on MRI, and he was treated with an oral course of amoxicillin clavulanic acid 625 milligrams BD for 10 days. In December 2025, he had again a left leg redness, swelling and pain, which was treated as cellulitis. Local USG was done, which proved it to be cellulitis, and he was treated with IV piperacillin tazobactam 4.5 grams 8 hourly for 7 days. Looking at his personal history, he was a known case of diabetes mellitus since last 6 years, and he was not on any treatment. A1C with us was 8.1%. History of alcohol use disorder was there, 180 mils of liquor almost daily since last 10 to 12 years. He has ceased in November 2023. He was a non-smoker, non-hypertensive. There was no history of chronic lung disease, no history of cattle exposure, and he resided in an urban area. So looking at his timeline, it all started in October, fever, high grade, left shoulder pain, diagnosed as osteomyelitis, treated. November 25, his symptoms persisted. We had a few blood reports from him wherein the hemoglobin was 11.5, TLC were 9,200, platelets were 2.87 lakhs, but he had signs of systemic illness. Early December 2025, he developed high grade fever with chills, and along with that, swelling in left lower limb. So this is the MRI shoulder report of October 2025, which suggested of heterogeneous intraosseous lesions in proximal shaft of humerus and neck with peripheral enhancing intramuscular abscess and deltoid and subscapularis muscle. The clinical timeline in mid-December, he was diagnosed with left leg cellulitis. During that time, the labs were decline in hemoglobin 8.7, TLC count increased to 14,100, ESR was 82, CRP was 81, RA factor was negative. December to Jan, his fever persisted and he had systemic signs and progressive generalized weakness. Late December and early Jan 26, he had sudden onset right knee and elbow pain and swelling. So on his complaints were persistent fever, right elbow pain, left leg cellulitis with a background of diabetes and alcohol use disorder. He came to us on 14 January. On admission, he was ill-looking, conscious-oriented. There was no focal neurological deficit. Tachycardia was there. He was hypertensive, tachypneic. He was hypoxic as well with SpO2 of 90% on room air. Pallor was present, no icterus, clubbing, lymphadenopathy or no skin lesions were there. No ossular nodes, Janeway lesions. He had oral thrush though. There was no murmur or cardiovascular examination. Respiratory system had scattered inspiratory crypts all over the chest, and he had hepatosplenomegaly clinically. So we evaluated him and did the primary management. He was admitted in ICU, fluid resuscitation and vasopressor support was done. Blood pressure optimization was done. He was taken on NIV support since the hypoxia was refractory. Routine blood workup, including the retrovirus and inflammatory markers, were done. 3 sets of blood cultures were obtained from different venipuncture sites. 2 deco was done to rule out infective endocarditis. We did an ABG. Autoimmune workup was done because it was a chronic illness with joint involvement. So ANA, ANCA and anti-CCP were done. Imaging, chest X-ray, ultrasound, abdomen, soft tissue, abdomen as well as soft tissue was done to look for any joint effusions, and X-ray right elbow and knee were also done. He was started on broad spectrum antibiotic, meropenem, 2 gram stat and 1 gram 8 hourly. This was his chest X-ray from 15th of Jan, which is suggestive of multiple small nodular opacities in bilateral lung fields. When we reviewed his reports, second day he had anemia as well as thrombocytopenia. We have seen that his hemoglobin has declined from 11.7 to 8.2 and then now 7.3. His platelets are going down. Retrovirus status was negative. Peripheral smear examination showed ROLU formation. Blood urea was 80, creatinine was 1.3, ESR was more than 150, which was 82, and CRP has increased to 377, which was 81, and ferritin was 1089. His procalcitonin levels were 5.2. 2D echo, there was no clots or vegetations, no RWMA, LV function was normal. USG abdomen showed hepatosplenomegaly, there was no deep-seated abscess in liver or spleen. Soft tissue USG and joints, there were no effusion. X-ray, right elbow, knee, no abnormality. Anti-CCP was negative, and LFT, there was reversal of AG ratio. So with all this, we were stuck, and we formed a differential diagnosis. It was a long list considering his chronic illness. So first, in India, we always consider tuberculosis with disseminated COX. Secondly, looking at the lung lesions, we suspected disseminated fungal infection, probably histoplasmosis, candidiasis, or aspergillosis. Also, we had a suspicion of infective endocarditis with septic embolization, collagen vascular diseases, vasculitis. We also considered tropical infection like melioidosis and brucellosis, considering his long course of illness. Hematological malignancies and plasma cell disorder. PS had ROLU formation and he had reversal of AG ratio. Disseminated nocardiosis, though he did not have any skin lesions and he was retronegative. And a very rare possibility of chronic granulomatous disease, though they present very early in life, but we suspected this. So what next? HRCT chest, bone marrow study, bronchoscopy and BAL myeloma workup. We decided on this. So next day we did the CT. This is the CT picture suggestive of multiple bilateral pulmonary nodules with subcentimetric mediastinal lymph nodes. The differentials were infective, inflammatory and neoplastic. So we planned for a bronchoscopy and bronchoalveolar lavage with analysis and SOS, PET CT and CT guided biopsy to rule out any kind of malignancy. Patient was still on an IV support, but he was doing well. He was off vasopressors and continued on IV meropenem. Review of reports, ANA, ANCA negative, anti-CCP negative, HRCT chest we have seen. Serum protein electrophoresis and immunofixations reports were awaited and bone marrow study report was awaited. So we proceeded with BAL. On bronchoalveolar lavage analysis, the gram stain had few gram-negative bacilli, fungal stains were negative, ZN stain AFB was not detected, TB PCR was negative, galactomannan was strongly positive, bacterial and fungal cultures had no growth, and at this time we were stuck. We were suspecting melioidosis in this patient considering his background, his comorbidities like diabetes and alcohol use disorder, and his lung lesions. So our microbiologist, Dr. Shweta ma'am, she suggested we should go for an open RT-PCR. So we did an open RT-PCR because none of the other biofire panels, they do Burkholderia. They check for Burkholderia. So we did an open RT-PCR and we found it to be Burkholderia pseudomeli. This is the report that I have attached here. They've checked for multiple viruses, fungi, atypical organisms, MTB complexes, but Burkholderia pseudomeli was detected and it was positive. So we started the patient, we continued with IV meropenem. His galactomannan was positive, so we started him on IV voriconazole 6 milligrams per kg 12 hourly for 2 doses, followed by 4 milligrams per kilogram body weight 12 hourly. And we started him on Septran, double strength 160 by 800 milligrams, 2 tablets, 12 hourly, considering it was melioidosis. His respiratory distress reduced. He was off NIV support, required minimal supplemental oxygen. He was shifted to ward. Hemoglobin, platelets, and other biochemical parameters improved. Later on, his SPP reports, they showed no monoclonal bands, and his bone marrow study was normal. There was no evidence of mass or HLH. These are the serial blood reports. We can see he had anemia, bicytopenia, which gradually improved. His renal dysfunction, which is AKI, which that also improved. And before discharge, his hemoglobin was 9.3, TLC was normal, platelets were 1,61,000. This was the X-ray that we repeated on 25th of Jan, approximately 10 days after admission, and it is showing signs of recovery. This is the X-ray on follow-up. He came on 7th of March, and the X-ray has the nodules have almost resolved. He was discharged on oral voriconazole 200 milligrams BD for 2 weeks and oral Septran for continuation and follow-up. Chest X-ray was done on 7th of March. It was normal. Patient is doing well on oral Septran and is on regular follow-up. Thank you.
This was a really very interesting case. Melioidosis we usually do not consider in this area. Now the cases are increasing, but usually after rains and all, sometimes we consider. But it was really very interesting case. A 44 years old man with multifocal infection, osteomyelitis, skin and lungs. So we should definitely consider this diagnosis in our differential diagnosis. Very nicely managed case.
Thank you.
I am interested in knowing what was the dose of amoxiclav that was given for his some humorous osteomyelitis or something, and what was the duration?
So 10 days.
And also what was the response to treatment?
Sir, he received it for 10 days, 625 milligrams twice a day for 10 days. And as the old reports show, he recovered with that, not completely. His fever subsided, pain subsided, but he didn't recover completely out of that.
That can be a clue.
Yes, sir.
Some partial response, although not complete,
Sir.
can be a clue. I mean, 625 twice a day is not even homeopathy dose for osteomyelitis, and 10 days is also again homeopathy dose for osteomyelitis. But all the same, there was some response if we think that that response was due to the amoxiclav, coamoxiclav. So that can be a clue, because this is an organism which is somewhat susceptible to this drug. So always these things have to be kept in mind. What has the patient responded to, and can that help us? That was one of the things. And otherwise, blood cultures were all negative.
Negative, sir.
But while on treatment,
Yes.
what treatment was going on?
Sir, IV, before giving
Before the blood culture.
we had drawn cultures before giving meropenem, but before that he had received a course of IV piperacillin and tazobactam as well.
But that should not really work. So what is this RT-PCR do you read on the BAL? That is something interesting, because is it a home-grown RT-PCR? What is the primer? What is it?
Sir, we did RT-PCR using true PCR kit, which detects viral as well as the bacterial pathogen. And we did extraction by fully automated extractor.
Open PCR.
Open
It's a
RT-PCR.
multiplex.
Yes, it is like respiratory panel which is available.
Did it grow in culture also? Because you
No.
could see GNBs in the smear. It didn't grow in culture.
GNBs in the smear was seen?
Yeah.
Of the respiratory secretions?
Yes.
No bipolar staining.
No, sir.
Okay. So that could have been something else. But diabetes, alcoholism are two very, very important predisposing factors. And sometimes, the patients may say that, do you drink alcohol? So the answer is no. But they can have binge drinking. So this guy, of course, was drinking on a daily basis a huge amount. But sometimes even binge drinking, which the patient does not volunteer, because none of us would call ourselves as alcoholics, right? So that is something which we need to, but even binge drinking predisposes a person to melioidosis. That is an important thing. once I had a patient who was from Gujarat. No, he traveled to Goa and then he developed melioidosis. So a person from Gujarat is going to have a binge drink in Goa. Okay, and that predisposes him to that. And then all the season, like the early part of monsoon, then the region, certain parts of our country, but then that footprint is sort of expanding, and we are seeing cases from dry arid climates, including Rajasthan and now these parts of the country also. So I think region part of it, although more classically from coastal areas or southern India, that may not be there. So I think we should keep our eyes and ears open for melioidosis even when this particular region is not thought about. So these are some of the important points, but it can be a very bad septicemic disease also. So septicemic melioidosis carries a very high mortality, and these nodular lesions which you showed, I suspect they are hematogenous lesions. Because see, his history is long. It's not like it's a recent inhalational disease. See, an inhalational disease would be mostly something recent. So it you get it and then immediately you start getting either a septicemic form or disseminated with deep-seated, as you said. But he has had this kind of osteomyelitis which is coming again and again. So he has probably had old disease with frequent exacerbation. So that is also very well known because these are predominantly intracellular organisms. In fact, the reason why you need that long eradication phase with a drug which penetrates very well intracellularly, such as Bactrim, cotrimoxazole, is very essential for this particular reason. So a short course of a effective drug also will not give you a full eradication of the organism. So that is very important. So, and sometimes it may present much later. You have heard of the Vietnamese time bomb, as they call it, and so on. So it could present after many, many years. So that is also a comment, and otherwise nicely managed. Question is whether you would use ceftazidime or meropenem.
We use meropenem, sir.
I know, but any preference, any discussion on that? See, there are no valid breakpoints. So even if this were to grow in culture, there are no breakpoints. Right? Gitu, you want to add something to that about Burkholderia, not especially pseudomalley, not having breakpoints. So it's difficult to interpret whether ceftazidime is susceptible or resistant and so on. But you are right, in a seriously ill patient, probably meropenem is preferred over ceftazidime.
Sir, after the acute phase is over, how do you decide the long-term therapy? How much?
No. See, that is in fact one of the important reasons why it is essential to distinguish Burkholderia cepacia, for example, from pseudomalley. Cepacia is a hospital-acquired pathogen. So that will come from hospital water sources, nebulization, intravenous thing not maintained properly and all. That is Burkholderia cepacia. The syndrome that it produces mainly is catheter-related bloodstream infections and post-nebulization pneumonia or something. In cystic fibrosis, it can be something very bad called as cepacia syndrome. But there the treatment is short. Like for any bacteremia or any lung infection, you could treat it. But pseudomalley is intracellular. That is something very important, and therefore that eradication phase for minimum 6 months is absolutely essential.
Gita ma'am, you want to say something?
Yeah, tell us about the staining and all these other things.
Yeah, so the typical colonies that appear on culture, Dr. Shweta would have seen the carom coined colony. So once it grows in culture only, we already have a doubt that it is pseudomalley. But again, the laboratory professional should be extremely careful because by inhalation you can acquire. So it should be performed in biosafety cabinets, opening the plates, dealing with the cultures. And the colony smear made out of it also has a typical safety pin appearance, bipolar staining. And then we perform the 3-disc test. We use amoxiclav, which is susceptible, and colistin and amikacin, which are resistant. And sir, there is a mention in CLSI M45 document. not the main document, that has breakpoints.
Breakpoints.
One question, apart from this chronic course, are there any clinical pointers when we should think of this organism?
Yes, yes. See, this patient has the symptom. He has got osteomyelitis. An adult getting osteomyelitis is something odd. You know, there are only few causes why salmonella would be one of them, Burkholderia pseudomyelitis certainly. Otherwise, there are very few reasons why adults should get multifocal osteomyelitis in the absence of immunodeficiency and classic things. So that should definitely alert. And then this history that there was a partial response to amoxicillin. So these two things can be clues about this particular organism.
Sir, I have a question.
Chandrapur. And we are getting cases, most of the cases of Burkholderia pseudomyelitis from Chandrapur. Even AIMS Bhopal, they have recognized 19 villages for their project of Burkholderia pseudomyelitis.
Oh, wow.
Chandrapur is one of them. Okay. So that is why we have performed open RT-PCR. We have done respiratory panel and it was positive. CT value was 27.
Oh, fantastic.
Initially, we were getting cases from MP only, but now, like she said, I have one girl with nail bed abscess, paronychia, that is pseudomyelitis, inguinal lymph node, and one lady with breast abscess, both from Amravati, Akola.
Right.
So I guess
Sir, I have a
pseudomyelitis
question.
can stump you anytime.
Sir, in our case, the patient had in BAL, the galactomannan was very highly positive.
Yeah.
What was its significance? We treated with voriconazole.
I
obviously.
You know, it's sometimes it is difficult. What was the actual value?
I don't remember, sir.
OD
but
value?
It was.
It was
Must have been high.
It was 5.5.
5.5. And serum? Did you do serum
Serum
galactomannan?
not done, sir.
Not done. I mean, it was done by experienced pulmonologists, so I suppose there will not be any chance of contamination with plasma light or, you know, the vial being opened again and again for BAL and also. So I'm just, I mean, it may not have happened in this case, but these are some important things that it should be tested from the trap. And vial in which it is collected, that should never be opened again and again. So there should be a separate collection, if not from the trap, then for galactomannan itself, because this can easily be contaminated in the lab. I would have been also in, you know, actually I'll come to that about the value of PCR for aspergillus in this kind of diagnosis. Maybe that could have helped in some way. So it is a little odd, but I grant it. I mean, how can you not treat that patient? Certainly possible. Did that patient also have any preceding viral respiratory illness or anything?
No, sir.
No.
That was not.
Thank you.
Thank you, Dr. Rahul. It's brilliant example of why we must always expect the unexpected in the medicine and a powerful reminder of our clinical intuition and perhaps a bit of humility. It's so important in bedside. Thank you, Chairperson. Now I request.
Moving on to the next session, we would first like to humbly invite a team of expert panelists to chair the next two sessions, Dr. Imran Noor Mohammed, Dr. Shweta Kavalkar, and Dr. Kamal Bhutra. Dr. Imran is Director, Criticare Hospital, Nagpur, Criticare Physician and Anesthesiology. Dr. Shweta Kavalkar is Consultant Microbiologist at Criticare Hospital and Research Institute, Nagpur. Dr. Kamal Bhutra is Critical Care Consultant of Care Hospital, Nagpur. We all know that managing invasive fungal infections in ICU is often a tightrope walk between too little, too late, and too much and too toxic. They are like a game of chess where the opponent is often invisible until the end game. To help us stay several moves ahead, we have the ultimate grandmaster of infectious disease, Dr. Rajiv Soman, with us here today. To introduce him would be a fox pass on my part because everyone here either knows him or knows about him. Ladies and gentlemen, I give you Dr. Rajiv Soban.
Mouse अच्छा run होते हैं. Any plain paper. ठीक है. Good morning, friends. It's indeed a great pleasure to come to Nagpur. I don't know how many times I have come here and you all invite me, but I hope this is not the last time. Anyway, so managing IFI in the critically ill, and it is subtitled as do's and don'ts. Okay, and I have shown you some both red and green. Okay, but these are not really watertight compartments. If you actually look at it, most of the time the distinction between red and green is not there. And most of the time we are in some murky, dirty, brownish type of zone. Okay, so let's begin with certain principles. So we may start treatment even when no fungus has been found. And what I'm talking about is prophylactic, preemptive and empiric strategies before you actually identify and call it as a directed treatment. On the other hand, we may not start treatment even if it has been found, if it is thought to be a colonizer. Now, needless to say that we have to cast our diagnostic net very wide, not just for catching fungi, but also a large number of other organisms. Because the patient comes to you as a patient. He is not yet labeled as a fungal infection or anything else. We should try to detect for a direct detection of the fungal pathogen. And for that, we may need invasive procedures. And remember that they may be better perhaps than ineffective, toxic, empiric, expensive and meddlesome therapy. So try to get the organism. Then for managing fungal infections, try and use therapeutic drug monitoring. Although if you actually look at evidence and trials, there is no unequivocal benefit of using TDM, but I'll argue with you that definitely we should be using it as much as possible. Then use combination antifungals in some of the invasive fungal infections and follow an induction de-escalation strategy in some others. Now this is somewhat controversial. That's why I put both red and green asterisks there. Individualize the duration of treatment in most cases. That takes a clear green. No question about it. So let's take this first patient. So this is a patient with diabetes, asthma on steroids. There was a delayed exploration for acute abdomen and 2 jejunal perforations. So it's again, remember, a somewhat upper GI perforation. And the patient had this organism, Candida glabrata, which was growing from the peritoneal fluid. The question is, how do we treat this patient who is in the ICU? Are there any issues about which drug, what dose, and what combination? Okay, and for this we have the ECMM ISHAM guidelines from 2025. You might find my name there, but you'll need a magnifying glass to see that, but this is how it is. So intra-abdominal candidiasis, which is not related to peritoneal catheters. So the treatment of choice is probably an echinocandin, and at these doses which they have mentioned. And if there is intolerance to echinocandin or echinocandin resistance, I would say that is very unusual. Then you use a liposomal amphotericin B. The dose mentioned is 3 milligram per kilogram. And of course, source control whenever that is possible, and then step down treatment to either fluconazole or voriconazole. But let's examine some more evidence more closely. We also know that there is suboptimal peritoneal penetration of the echinocandins. Not only echinocandins, but even of the others. So you have echinocandins, the penetration ratio could only be about 30%, 33% as compared to the serum. For liposomal amphotericin B, these authors, and this is Jason Roberts there, so 5 milligram per kilogram for intra-abdominal infection is probably advisable. For fluconazole, we know it penetrates very well, so it have 85% penetration in the peritoneal fluid, but voriconazole is a little bit less at about 2/3 or 67%. Now you have other problems like these drugs may or may not have efficacy if it is a particular type of Candida species, and you have issues of toxicity and drug-drug interactions with some of the others. Now you are intensivists here, and therefore you need to know how you adjust your antifungals in ECMO and other modes of renal replacement. So this is something I've listed here. And this is also something which is instructive, that a multi-center study showed that 25% of patients in the ICU did not meet the predefined PK/PD target exposures. And this was particularly relevant to voriconazole, posaconazole, micafungin, and amphotericin B, all the drugs that we always use. There are other issues in intra-abdominal candidiasis which also should be kept in mind. So you have a high apparent volume of distribution. That means the drug is distributed because of capillary permeability changes and the ascites and the major body fluid excesses and so on. Plus there might be surgery which is also inflammatory, produces vasodilatation, and there is actual removal of the abdominal fluid. With that, the highly protein bound and other drugs which are there in the ascitic fluid are also getting removed. Hypoproteinemia. Now echinocandins, remember, are highly protein bound, and some of them are metabolized through the liver, especially caspofungin and micafungin. So if you have lower bound fraction, more free fraction, and that is amenable to metabolism by the liver. So I like to call it as a augmented hepatic clearance as against augmented renal clearance, which we talk about for other groups of drugs. Intra-abdominal gives you even more problems. So there are specific components of the peritoneal fluid which actually make Candida organisms more virulent. And also this patient, remember, was Candida glabrata. So there are additional microbiological features of this organism such as aneuploidy, genetic plasticity, efflux, and all this means that you need high doses, perhaps in combination, and also with TDM. So briefly, for candidiasis and candidemia, we use non-culture based tests, that is the biomarkers, but please remember that the diagnosis can't be solely on them. And the previous case we saw, we are struggling with the diagnosis of aspergillus only based on the galactomannan in that patient. Okay, so same way it is important here. Then always try and obtain by percutaneous aspiration an abdominal fluid, and not just take the drain fluid which is longer than 24 to 48 hours, the drain which is there. You can also use the negative predictive value of beta-D-glucan to avoid or stop empiric therapy. And as we discussed, perhaps we need to use certainly high doses, maybe in combination, especially for bugs like glabrata and Candida auris. Control of the source, control of the infection itself, as well as hunting for the metastatic sites and trying to treat them. All these are very important. They all get a green mark. And practicing meticulous infection control, especially for Candida auris, no question about it, green mark. Now let's take this patient who had a CS stomach and was on many of these drugs, including oxcarbazepine, and he had a post-viral infection. So he was readmitted to ICU afterwards with fever, dyspnea, hypoxia, and new infiltrates on X-ray chest, and was started on the welcome drink, as almost every patient receives. Okay, so the chest X-ray and LRTI multiplex PCR was done and referred for an ID opinion about escalating the antibiotics. So this was his infiltrate and on the scan. And you have 10⁴ mean values of E. coli, strep, Staph aureus, as well as strep A. galactiae. These are the mechanisms of resistance there, and the patient still has the influenza A over there. So the ID opinion is bacterial pneumonia appears less likely. The infiltrate is quite nodular. In fact, here you can think of a halo surrounding that dense nodule there. The mean values were very low for almost all these things, almost amounts to a negative culture from a BAL fluid. And therefore antibiotics especially for CR organisms, may completely be avoided. On the other hand, IAPA or influenza-associated pulmonary aspergillosis appears to be the likely diagnosis in view of some of these features. And this again brings up the question, like for example, in non-neutropenic patients, the serum galactomannan has low sensitivity, just about 30 to 40%. However, if you do the serum PCR, that has a fairly good sensitivity as well as specificity. So that is something which can perhaps be done to give you better evidence of invasion. In this particular patient, the PCR was a send out test with a TAT of roughly, TAT means turnaround time for about 3 to 4 days. So the question is, should treatment be started, and if so, what should be used? Okay, so here we have all of them. Now, interestingly, amphotericin B is thought to be inferior to the azoles based on this very landmark Herbeck trial, and voriconazole, isavuconazole, or posaconazole all are non-inferior to each other on the basis of these two studies. But interestingly here, the least interaction with oxcarbazepine is with posaconazole. So that was the drug which would be chosen here. So the message is mainly that we should look at interactions or potential drug interactions before choosing the particular azole. And the serum aspergillus PCR was positive. So here we have blot criteria for ICU related aspergillus. We have IAPI criteria, that is influenza associated pulmonary aspergillosis. I will encourage you to read all these criteria and try and apply them in practice. All these criteria require the biomarkers or the non-culture based tests. But remember that the performance of all these varies with the sample, means BAL or serum, the type of the patient, neutropenic versus non-neutropenic. And all these tests, including the beta-glucan, galactomannan, and PCR, may not point in the same direction, and it really produces a very big conundrum for the treating physician. Neither do they have the same diagnostic weight. Today, we don't give different weightage to PCR, galactomannan, or beta-glucan, but indeed it should have probably a different weight. So always obtain culture for both ID and AFST, and we cannot really assume azole susceptibility even in India. It used to be thought that less than 1% of aspergilli are resistant to voriconazole, but today the figure is closer to 6%, so that may keep on going up. Both isavuconazole and posaconazole may be better contemporary choices, and we may consider combination treatment, but this is somewhat controversial. That's why both green and red marks. And of course, consider drug-drug interactions. That's extremely important. Now here we have a patient with rheumatoid arthritis who's been taking a huge dose of methotrexate. He's taking it daily for 2 months. And he presented with fever, dyspnea, pancytopenia, LFT, derangement, and LDH, which was high. So there was a suspicion either of PCP, the radiologically it does look like it, but so does methotrexate toxicity, and sometimes even viral infections and congestive heart failure can also give you a similar type of appearance. As you notice here, he had fairly deep jaundice too. So can beta-glucan and PCR help us in this? And there are EORTC, MSGRC criteria, as well as this thing called as a leaf plot analysis. So that tells you how you can factor in all these factors before you do the beta-glucan, and then you get a post-test probability of there being PCP or not being PCP. So these are the various scoring factors which we use, but there are some issues, and we wrote a letter on this particular thing because assigning exact scores for these patients appears to be quite complex. So here you have only HIV and SOT. What about this high dose methotrexate? It's not figuring in that particular host factor, but certainly intuitively we think that is definitely an important host factor. Now both LDH as well as beta-glucan can have confounding factors. Like for example, you have this patient who has high jaundice, liver disease, so LDH can be abnormal because of that. And remember, hyperbilirubinemia may sometimes produce false negative beta-glucan. Okay, so there are confounding factors. If the patient receives blood products, then further confounding factors are there. So clearly everything is not captured by these scoring systems, and that's still a work in progress. So we could use these EORTC, MHGRC criteria and this kind of leaf plot analysis. I found it to be very useful in practice. But how do we use the PCR? So should we be using copies per ml or CT values, or do you have a qPCR for the quantitation of the CT values, and how do we interpret them? It's not very easy. Now, critically ill patients, especially who have cytopenic because of other reasons, will have problems, and you may need alternative treatment for managing the pneumocystis, and increasing steroids in such patients who might already be on steroids might be actually life-saving. Now here you have a patient who's uncontrolled diabetic and received steroids for suspected non-resolving pneumonia. Obviously that made matters worse. You have this reverse halo sign here, and you have this mold which looks like a mucorallian mold in the sputum. So right pneumonectomy was done for this patient, and in that you see the mediastinum as well as the intercostal muscles were found to be involved, indicating advanced disease and a very high organism burden. As expected, he succumbed despite surgery as well as the combination therapy. But surprisingly, blood as well as bowel fluid PCR for mucorales was negative in this patient, despite having high burden. And could immune checkpoint inhibitors have been useful in this particular patient? So these are some of the questions here. So this is a new retrospective review which tells you that the size of a lesion more than 6 centimeters, having a reverse halo sign and not having airway involvement are pointers in favor of mucormycosis versus aspergillosis. And this is the paper from Chandigarh which talks about the mucorales PCR both from blood as well as bowel fluid, and that did not perform as well as in certain European studies, and mainly because these patients were not neutropenic but they were diabetics. And to you and me in the ICU, the majority of the patients may not be neutropenic. So the use of this mucorgenius, as it is called as PCR, may not be that. And finally, in a patient who's got extensive disease and is really going downhill, there is a altered expression of the PD-1 and PD-L1 ligand, and therefore there is actually a patient is now gone into a phase of immunosuppression. By giving drugs like immune checkpoint inhibitors, like maybe nivolumab, you can actually enhance the patient's own immune system. So these might be emerging therapies there. So we know that there are no biomarkers so far. PCR has not lived up to the promise in the diagnosis of mucormycosis. I told you some features which may help you to distinguish aspergillus from mucor. Surgery obviously is pivotal, and adjunctive therapy including some others and this ICI may be used. Always obtain culture for both ID as well as AFST. Remember, mucor is not just one organism. You have a mucorales family, and there are so many genera and species among them, and they have different susceptibilities to different antifungal agents. So some mucorales are less susceptible to one or the other of the antifungal agents. There are many such examples. Maybe isavuconazole and posaconazole may be good contemporary choices for them, and even considering combination therapy, this guideline does not recommend, but increasingly combination therapy is being used. Therefore, I have given a red and green mark there. Immunosuppression, withdrawal, always a great difficulty, especially in a transplant patient. How do you sort of sacrifice the graft and withdraw the immunosuppression in the interest of saving the life of the patient? It's going to be a difficult dilemma. And whether you should use immune checkpoint inhibitors, these all get a red and green mark because this will depend on a case-to-case basis. So I close by saying that ICU patients do not offer the luxury of leisurely investigation. You do a test, wait for the biopsy, wait for the culture. Investigation and empiric therapy often need to proceed in parallel, but you can perhaps stop if there is lack of confirmation. Therapy choice is based on myriad different factors, and many of the strategies I've just outlined do not have a clear yes/no answer, but a clear understanding will definitely help us tailor both the tests for the particular patient as well as what therapy we choose for the particular patient. So I think that is the bottom line, that for that individual patient you have to think a lot and decide what would be the best approach both for investigations as well as for management. Thank you. Thank you, sir, for this lucid talk. Initially, when the MOCs were introducing you, so I thought that you don't need introduction not just to the Akrians but also the tigers of Inch and Tadoba. And even the fungus, it doesn't need your introduction because whenever you are there, they will not be there. So, any questions from the audience? Yeah. So it's interesting that, as soon as a major infection develops, the body does not want the immune system, teleologically, it does not want the immune system to become extremely destructive. And therefore, there is expression of this PD-1, which dampens our immune system. This is a natural process. Now, there are some patients where this might be even more so. They are actually gone into a immune exhaustion within 48 hours of developing an acute infection. In this situation, the therapy by boosting the immune system. So you remove that checkpoint by a drug such as nivolumab, and that can enhance the immune system. In fact, these immune checkpoint inhibitors have been used for fighting against tumor cells by our own immune system. By the same analogy, this is an emerging strategy. It is not yet fully established, but case reports do exist, especially for mucormycosis and aspergillosis, and also for fusarium. Now, that is another fungus which is difficult to manage. We don't have very good drugs for fusarium. So there we assist the body's own immune system to fight against the fungus. So it's an emerging sort of intervention.
So thank you so much, sir. I would like to give us some pearls about biomarkers like glucomannan and galactomannan assay, which we routinely use, along with when will you stop the empiric echinokines. So in a very few years. Thank you.
So, about the beta-glucan and galactomannan, these are biomarkers. By themselves, they don't indicate disease because they are biomarkers. But what will be their positive and negative predictive value is something which is based on what is the syndrome that a patient has. For example, I'll just give you one example of intra-abdominal candidiasis or esophageal perforation, where candida coming into the pleural fluid or mediastinitis or upper GI perforation is very, very high. Okay, in such a patient, the pre-test likelihood, pre-test means before I do the the beta-glucan is already very high. It is above the threshold which I use commonly, like about 30% for starting empirical echinocandin. So in such a patient, actually it is not even necessary to do beta-glucan because it is already above our threshold. You may do it, but not that necessary. On the other hand, if you have a very low likelihood, like a colonic or a lower colonic perforation, chances of candida coming in the fluid is very less. Okay, so in that patient, again, no sense in doing a beta-glucan because even if it is positive, its positive predictive value is still very low. On the other hand, if you have severe acute pancreatitis or a small intestinal perforation, here now it is going to be 50-50. The chances are of such a patient having intra-abdominal candidiasis is only 20%. But if such a patient has a positive beta-glucan, the chances go up much higher. So there it becomes very essential. So now if you have started empirically, means not actually found out that there is candida in the pleural, in the abdominal fluid and cultured and all that, then the duration of treatment is something like 2 weeks. So it is assumed that the first culture is negative, so you treat it for 2 weeks, similar to candidemia. Now, by the same token, if you are treating candidemia, again the treatment is 2 weeks after the first negative blood culture. Why do we want that? Because candida has a high chance of producing extravascular microscopic foci. They are macroscopic, you may not even see them, even if your eye is normal, even if there is no endocarditis and all that. Still microscopic foci in liver, spleen and other places and kidney and all that may be there. So in order to control them, you need a treatment for, not for 7 days as in say gram-negative rods or something, but for at least 14 days after having shown clearance of candidemia, means first negative blood culture. Additionally, now we are using the negative culture for its good negative predictive value, but this is also not very true in the sense candida positivity in culture is only 50%. So now you are saying it's negative means it's truly negative. Okay, so there is a problem. So you don't want to fall short in your treatment. So 2 weeks becomes a good safety margin, and therefore 2 weeks is that sort of magic figure. But you should rule out definitely other metastatic involvement, recovery of neutropenia, and improvement in the signs and symptoms. So all these, it's not just 14 days. When the patient is still bad and something else has developed, retina has got involved or something, then it's a longer treatment.
Thank you. Thank you.
Thank you.
Thank you, Dr. Soman. Sir, just a moment. Now I request Dr. Balanki to please present Dr. Soman with the token of our gratitude. Chairpersons, you. नेक्स्ट इसके लिए भी है. We would also like to acknowledge here the presence of senior doctors in medicine in Nagpur here, Dr. Suryavanshi sir, Dr. S.N. Deshmukh sir, and Dr. Kadamkar sir. Sir, we are truly humbled and honored by your presence. For decades, our defense against sepsis was built on snapshots, a fever here, a blood pressure drop there, or a late arriving lactate levels. We relied on scoring systems like SIRS and QSOFA, which were foundational, of course, but often they act as a rear view mirrors. But the times have changed. We are no longer limited by what a human can monitor at a single moment. We have entered the era of digital vital signs, where AI doesn't just watch the patient, it anticipates the storm before the first cloud appears. While our clinical judgment is paramount, AI offers us the ability to synthesize thousands of data points in real time. To walk us through the integration of these digital tools into our bedside practice, please welcome a leader in critical care medicine, Dr. Bharat Jigyasi. Jigyasi sir is Director of Critical Care Department at Kokilaben Dhirubhai Ambani Hospital, Mumbai. He is a renowned intensivist, over 18 years of experience in adult critical care and multi-specialty ICU management. Sir is an expert in ARDS, sepsis, ECMO, CRRT, and mechanical ventilation.
So, yeah. So when we talk of the AI in critical care, so what we need to look into is we also talk about the intelligent ICU. So just think about it, what this intelligent ICU means. As we go through it, in the end of it, this is the start slide, and in the end also there'll be an anecdote on what I'm going to go through. When you talk of the intelligent ICU, it means something. It's about having the intelligence all around the ICU. So as we move around, if we look around, so if you look into this, there are around, what we look into is there are 49 million sepsis cases every year, and 11 million deaths are because of the sepsis. No, just like. ठीक है, मैं ऐसे कर ठीक है. So in every so 49 million cases is what we look into, and there are so many deaths which comes in, and approximately 1 in 5 deaths what occurs globally are of the sepsis. So if you look into the septic deaths, the deaths which occurs because of the septic shock, they are much more than what we see through the cancer, but still there are no ribbons, there are no CSR activities, there are no charitable institutes involved in the invention, the resources of the sepsis. Cancer is doing so well because there's so much of the funding which has come from the charitable organizations, CSR resources, and things are improving over there. But in the sepsis, it still is not been recognized to that extent. Even the number of deaths are very high. And this is the trajectory what we look into. So when the patient walks in, if you look into this, the patient presents at 0 hours. So I'm not talking about the real ICU scenarios. Vitals are flagged at 2 hours in the routine A&E. This is the average. Maybe in the best of the corporate setup, you'll have the vitals available in next 10 minutes, but in the different peripheries, it takes 3 to 4 hours to check the vitals. At 5 hours, we draw the cultures. At 8 hours, the sepsis has been recognized, and somewhere around at the 10th hour, the antibiotic has been given. So we know this very strong study where we said every hour delay in the antibiotic will increase the mortality. So look, when the patient is arrived in A&E or the emergency department or in the hospital, and we take 10 hours to give the antibiotic, the mortality is gone up by almost 70%. This is where we need the AI, because it will really transform the real-time continuous surveillance will happen, and it will alert the patient. It's also triage the patient where we will intervene early and give the antibiotics altogether. So this is what we are looking into. Now when we talk of the AI, there's a various tools available. So I'll not go into the details of the AI, but I'll tell you what exactly everything does. When you speak about machine learning is like a forest plot, the random forest plot. So it takes very electronic health records, and all those are integrated. It can predict sepsis maybe 6 hours earlier. It's trained on the millions of the ICU records. And the area under curve is what they look into always, is somewhere around more than 0.85, which is considered to be very good in the validation data. Deep learning, they are the neural parameters which works on the various waveforms like the arterial waveforms, hemodynamic waveforms, ECG, ABB patterns. And according to those waveforms, they will pick up certain things, they will learn over it, and they'll pick up something. Then natural language processing. Natural language processing is they read your summaries, they read your death summary, they read your clinical summary, they read the transfer summary, they read the nursing notes. So it's a reading which goes on, and eventually it will give you the context depending on the data which is available. They'll read each and every document which is available with you. Reinforcement learning is what we are looking into. This is the most controversial thing, and this is what we want over here. So reinforcement learning is, it's looked into the machine learning, into the deep learning, into the neural language processing, and it gives the eventually prompt what needs to be done. So this is a clinician which is doing a job, and this is the most controversial point of the AI, what we're looking into, and the most interesting as well, reinforcement learning. So machine learning will look into the million data points. As per the data points and the previous experiences, it will give you the clue. Deep learning will look into the waveforms. Natural language processing will read your summaries and eventually pick up something from that. Supposedly the patient who had rigors 6 days back, maybe of all the documents you will miss that rigors, but it will eventually point to this patient at rigors, which will indicate maybe this patient might have a sepsis. So I have to look into this. And reinforcement learning is what we talk of the AI. We'll actually tell you what treatment, when, how much fluid, what vasopressor, what antibiotic needs to be given, and this is the most controversial tool what we are looking into. Now, when we talk of the AI and early sepsis, there are various tools available. So if you look into the epic sepsis model, this is TRUE's model, which is invented by John Hopkins. It looks into timing of the antibiotics, and it's covered in the RCT. So when the TRUE's was used, there was reduction in 1.87 hours of the antibiotic timing, and of course the mortality became better. Insight Sepsis Care works on the continuous real-time scoring. These are scoring system which tells you the trajectory of the patient, what moment patient came in, what was the score at that moment, and how the patient is whether improving or not. Subsibit is by the Philips. It's really an innovation. It integrates all the parameters which are there in the monitor and also the lab trajectories, and will tell you how the patient is behaving. And same is with the AI augmenter. But what it does is, it looks into the vital signs parameters, trajectory of the labs, medication context, what we are going, vasopressors, antibiotics, how the doses are being going on, and of course the free text NLP, that is language processing. Whatever the note comes in, whatever the summary is been in, the nursing notes, it will read into it, and eventually the comorbidity will be weights accordingly. So here what we looks into the AI guided antibiotic stewardship. So when the patient comes in, the phase 1 is always the empiric selection. So what AI does is, AI likely predicts the organism depending on the local antibiogram. As we always say, antibiotic cannot be the one size doesn't fit all. You have to look into the local antibiogram and decide what needs to be done. So as per the patient's comorbidities, patient risk factors, it will prompt, this is the antibiotic which should be given depending on the site specific pattern. And this reduces the antibiotic broad spectrum overuse almost by 23%. This has been shown by the Merlin trial. So when you use the AI prompt for the empiric antibiotic, Merlin trial has shown it will use the overuse of the antibiotics by 23%. Next step 2 is the culture guided de-escalation. The moment the culture comes in, it will tell you you need to de-escalate. We all know when to de-escalate, how to de-escalate, but there's always a time lag in between the culture report which comes in and the moment we take the decision. AI will prompt the decision, make your decision a little faster, and the de-escalation will happen timely. PKPD optimization. This is where the best of the intensives fails as well. So the Bayesian dosing models per patient per renal function is we don't calculate, and we also know it doesn't depends on it's not a simple formula which fits one patient. We also have to look into the trajectory of the patient, volume of distribution. Sepsis model has maybe have the augmented renal doses as well. So this is what AI calculates, and it will precisely tell you which antibiotic is to be used. And in certain cases, when the therapeutic drug monitoring sir also said is when available, it will take those readings and eventually it will guide you what dose should be used. Hemodynamic challenges. Hemodynamic challenges, AI works as a clinician. You look into the Comisco et al. Study, which is published by in the Nature Medicine 2018, almost 16,000 ICU patients across 3 ICUs. So what they look into it, here the reinforcement learning was useful. Reinforcement learning, what we spoke about is, it will tell you how much fluid, when and what to give. So eventually it looked into the optimal IV fluids and the vasopressor therapy. And surprisingly, this happened in 2018. What it showed is the amount of fluid what we give as a clinician, the patient doesn't need that. It really gave almost 50% of what we gave. And then later, 2 years later, we had the SMART trials, and we had one more accurate trial which came in, which told us no patient needs, you have to move away from the liberal strategy of the fluid, have to do the restrictive strategy. So this is what AI is about. So 4 years before the actual trials came in, it told us no patient doesn't need that amount of the fluid is what we are giving. It also looks into the fluid management, the dynamic parameters. So it looks into the PPV, SPV. So as those get stabilized, it will tell you now stop the fluid. So we have a process. We give the boluses of the fluid. We continue the fluid management. We never stop it. This is where AI plays in. It says now patient is stabilized. You can stop giving the fluids. Continue with it. Again, the vasopressor optimization. There's something called as closed loop system is being practiced in the ICMR AIMS model. So there are infusions which are which are integrated with the monitor. As per the target BP, it will vary the dose of your vasopressors and inotropes, and your pressures will move in. And what it has shown is in 95% of the patient, the MAP was maintained as more than what we required it. And of course, the incidence of hypotension was 15% less. So now we look into the organ support management. I'll go faster in this slide because I have too much to cover. So mechanical lung ventilation, we all have been practicing IntelliView. I mean, if you have it, Intel ASV, you just put it on the mode. It will calculate the FiO2, it will look into the driving pressure, it will look into the peak pressures. Eventually, it will come down. It's a very interesting tool. So when I first installed in my institute, the first call I got in the night was, sir, meko pata nahi chal raha mode kya hai, FiO2 set karne nahi de raha hai. You don't have to do that. You just put the machine on. That's it. It will decide which mode, what FiO2, how much tidal volume, how much RR, depending on the integrated values of PCO2, ATCO2, whatever comes in. So you just have to put the machine on. This is how it works. Then kidney, depending on the trajectories, if you do the biomarkers, it will tell you whether the patient has the AKI risk or not. Same is true with the brain, with the continuous EEG monitoring. It will indicate and tells you what is happening, and of course with the heart as well. It's very important. Looking at the just ECG parameter, it will tell you whether the patient is landing up into septic cardiomyopathy or not. But of course, when you do the 2D echo, you don't need an expert over there. With just a good window, that is also guided by the AI. They will tell you move left, move right. Accordingly, once the best window is being created, it will tell you the TAPC, EF, whatever readings you want. So this is the important slide what we're looking into, the most important in the whole of the talk. So when we look into the landmark evidences, what AI is looking into. So when we go through the drug trials, it's always phase 1, phase 2, phase 3. So AI is, you come up with an idea, integrate that idea with all the models around, and see whether the prediction is right or not. So one is when they come with the idea, one is area under curve, which is more than 0.7 is considered to be good. Then after comes the positive predictive value, which allow us to come in the system. Then we don't work on the phase 3 and phase 4 trial. This is where we are failing. And this is where the epic sepsis model audit, I'll tell you what exactly happened over there. So the first We spoke about the Komosky, which is very well used by the fluid and the vasopressors. We spoke on it. Then the TRUES by the John Hopkins, which helps us in reducing the antibiotic timing by the 1.87. Then the composer closed loop system, which is being practiced by the ICMR in the AIMS model, where they adjust the vasopressor doses, and the Insight sepsis model by the sepsis. So this is the critical lesson what I was looking into, the importantly EPIC sepsis model audit. So we had the promise that the EPIC sepsis model came in, and the controversy which, so it was deployed in 170 plus hospital across the US, and machine learning adopted from sepsis and vital, and it promised early warning up to 12 hours before the onset. But the reality is it was installed across the nation. It was reinforcement learning. It was prompting, and they were practicing it. Wong et al. In 2021 published, audited it. So it went, this is what we call as the phase 3 trial of the drug. Once you're in the system, it should go with a further trial. So this is the prospective study after it was installed. It was approximately studied in 25,000 patients, and the sensitivity was only 63%. That means every one patient in 3 sepsis was missed. So we missed the cases. This was reinforcement learning. That means the prompt was given and everyone was following it. There's no intervention of the clinician over here. So we missed 1 out of the 3 sepsis patient. Positive predictive value was 13%. That is 6 in 7 alerts were false positive alerts. It leads to very high alert fatigue as well, caused by the excessive fatigue alarm. So what it teaches us, we need an internal validation. It cannot be just one model which comes in and we have the positive predictive value, I install and I say it's working. We have the external prospective validation as well, which is non-negotiable. And PP and AURC is not what we are looking into. We are also looking into the prospective trials, and there always should be the clinician override pathways, which must be built in within the system. It cannot be the reinforcement learning always. There has to be the clinician override model. So the real world implementation, what we look into it, as we spoke about, one data needs to be coming, and data has to go on, has to be the model interference, then alert generation, we have to check it, and again the clinical responses we have to look into. So the success factors should be the champion physicians in each unit. AI cannot work alone. Nurse education needs to be done because, as I told you, it has to be a fatigue alert. IT and clinical design has to come in, and we have to do the regular model qualification. So challenges what we fall into the AI, we look into the algorithm bias. As we spoke about, in India, it's a varied city. So when you talk about the sepsis, always it's tachycardia, hypertension. But if you take the tropical disease, dengue, you will never have a tachycardia. It's always heart rate is 70. Maybe in the typhoid, heart rate will be 60. So they will not detect those patterns. So we need to have the India specific pattern. Black box warning, always we have it. The garbage in, garbage out is what we are talking about. So whenever the information is not adequate, you will not have the adequate output as well. Alert fatigue will always come in. So this is why you need to alarm, segregate your alarms into red, orange and green. Which one needs to be high alert alarm and the average alert alarm and the low alert alarm. There has to be a distribution phase which happened before the COVID shift. Before the COVID shift, we did not understand about the heterogeneity. But since the COVID is coming, the heterogeneity, the phenotype is being worked very well, and what we are looking into this. So all these needs to be integrated and have a good ethical models as well. Eventually, in the end, maybe 5 years down the line, we have the explainable AI in the ICU. So as of now, how we are working is, AI comes in, it tells you your patient needs fluids, patient needs vasopressors. This patient might be sepsis, this patient might not be sepsis. The probability of patient having sepsis is 83%. I don't need that. What I want is, when AI says the patient has a probability of having a septic shock, 83%, I need the contributing factors. Why it said so? Because maybe the patient has a temperature. Patient had heart rate of more than 80. Patient has WBC more than this, lactates are high. You would not put. This is the kind of information what you're looking into. If AI tells me this patient has a septic shock or probably sepsis, then it should also give me on what parameters it is indicating me, and this is where my pattern will recognize. And if you mind you, if this pattern comes in, this will be the best textbook for the juniors as well. They will not read the textbook. They will always come from this probability, and they will learn from this why this is sepsis, why this is not a sepsis. And the shape is the one of the feature important scores for each patient, which is most widely adopted in the ICU, which always done this. There are many attention maps also which are coming through over this. So AI in sepsis, Indian perspective, we spoke about. We have the tropical disease, we have high AMI burden. If you look into the Mosher's resistance pattern, if the patient comes in septic shock, they will always, the AI model over there will tell you empirical choice of antibiotics, ceftriaxone. We cannot be using ceftriaxone empirical antibiotic someone who's in a septic shock. So it has to be the varied model across the corner. We need to understand our patterns. We need to understand our genomics of the organism, and this is where the public infrastructure has to be built in. But we have a very big advantage over here. India being a populous country, we are around 1.4 billion population, which has high infection disease diversity, and this is where the national registry and the leadership role across the various bodies, Ayushman or the ICCM has to pitch in, and we have to have the national sepsis registry and work up with the IITs across the nations, across the corners, and build up a model which is helpful for our country. IICCM was the first time it's conducted the first ever datathon in the recent Chennai conference, and all IITians had come. They were so impressed with the system being around. So this is the kind of indication what we need, and the leadership has to come in along, lies with the government, have to build up the centric model. We cannot have the mimic model guiding us from the US. We cannot have the EHR data from the UK guiding us, because totally it's a varied information. So transparency is clue over here. Transparency is not only for the patient, transparency for the clinicians as well. Because as I told you, when AI says this is probability is 80%, on what basis is telling me, I should also know. So transparency also for the clinicians. Accountability, we all know the government is working on it along with the CITSCO. As of now, we have no regulations. But if you talk about the FDA, any AI model is being considered as an instrument, and they have the accountability. Same is true in the Europe. Non-maleficence AI also has errors. Who will take the responsibility of it? We have to look into it. And intensist role is irrepressible. You cannot loop intensist or clinician out of the AI. It has to be the model which needs to be intervened, and we have to get into this. So this is the intelligent ICU of 2030. Continuous digital twin. This is reality. This continuous digital twin clone pattern is in practice today in AIIMS Delhi. The government of India ICMR is working on this. So what happens is, whenever the patient comes in, out of the 30 million simulation what you have conducted, as per your patient, they will generate a simulated twin of the clone of the patient, and depending on that clone, they would advise you what you should be doing. You should give more fluids, less fluid, this vasopressor, this antibiotic. This has been practiced as we're talking about, or as I'm giving this talk. So this is the reality which is available. Genomic AI integration, depending on what kind of organism is coming, it will guide you what therapy should be given, and has to be the human AI collaboration. It cannot be the AI alone. As I told you, clinician cannot be lured out of the thing. AI is always the thing which is going to help you, and has to come with a global sepsis intelligence as well. So 5 things to take you back to your ICU. AI detects sepsis early, we all know, but validation is very important. We need to have the prospective studies as well. Human never leaves the loop. So don't worry about it. It's always there to help us. We are not out of the loop. Antibiotic stewardship, fluid decision should give it to the AI. We should not be bothering much about it, because what is true now might be not true an hour later, and AI is the best thing to do it. Indian ICU needs Indian specific data, and the question is no longer if, but how well we should be doing it. So if you look into this, the last thing what I was telling you is, whenever we talk of the intelligent ICU, the intelligent ICU is not a threat to the intelligent intensives. It is the most powerful tool we have ever been given. The question is whether we'll use it to our advantage wisely or not. So this is what we have to learn. So intelligent ICU are in place. We have to adopt it and to learn to use it wisely. Thank you.
Thank you, Dr. Bharat, for the lucid and wonderful presentation. So the thing is very clear that AI may not replace intensivist in future, but the intensivist,
It will not.
it will not. But the intensivist who is not using AI may be replaced, definitely. So the house is open for discussion.
So AI will not replace intensivists. Intensivists not using AI will be replaced. Yes. I mean, there also there's no may.
Sir, any AI module you are using in your ICU?
If you ask me AI model, I have the IntelliVent ventilator with me, which is by the Hamilton. So that is an ASP where you just put the button on. It has the ETCO2 and SPO2 which is integrated, and as per the parameters, it changes its circulation. That is one. Second is this True's model 2 years back was validated in my ICU. As of now, we don't have.
थैंक यू डॉक्टर जिज्ञासी सर। टॉक इतना अच्छा था, अगर 5 मिनट और ज्यादा भी ले लेते तो हमें पता नहीं चलता। थैंक यू वेरी मच सर। Dear friends, they say behind every successful convention there is lot of caffeine. But behind the Criticare Convention, there is only one man, Dr. Deepak Jiswani. He is the only person I know who can diagnose a patient, mentor a doctor, crack a joke with the staff, and organize a national conference, all the while when his phone is ringing every 30 seconds. Now it's time to introduce the man who has more energy than a 24-hour pharmacy and a sharper eye than an ICU monitor.
Very true, Monica. As we all know, he started from humble beginning, but opened his own hospital, Criticare, in 2008, and within 5 years moved to a bigger setup. Dr. Jaswani didn't just build a hospital; he executed a vision of high standard ICU, and that served as a gold standard for entire region.
So some would think the main strength of his ICU is all the advanced machinery, equipments he has, like upgraded ventilators, CRT machine, the ECMO and whatnot. But his true strength is his compassion, his drive, his mentorship, and his absolute determination to do the best for the patient. And dear friends, this was not luck. This was intense hard work, strong dedication, a sharp team, and let's not forget, an extremely supportive wife. Truly, Shweta, sometimes it feels like he dreams and she executes.
कामयाबी भी उनके दर से डर के रहती है, कामयाबी भी उनके दर से डर के रहती कि कहीं सर और एक कन्वेंशन ना शुरू कर दे। हुनर तो उनकी मुट्ठी में कैद है मोनिका, बस डर इस बात का है कि हमें भी डिसिप्लिन ना कर।
Dear friends, we give you Dr. Deepak Jeswani, sir.
Good morning, all dear teachers, seniors and friends. Once again, I welcome you all for this convention. I welcome our senior faculties, Dr. Soman sir, who is kind enough to give his precious time to us time and again for this convention, and we really love to listen to him, along with Dr. Geetu Cho, Dr. Parikshit Prayag, Dr. Nitin and Ashwini from our own city. Thank you very much for accepting this invite. Thank you all chairpersons. The most important driving force which is always there with us is Dr. Nikhil, our mentor. Time and again, we are doing such successful conventions every year. It is because of him. He is a mastermind behind all this planning, execution, and every minor thing what is going on here. So I thank Nikhil sir, I thank Deepti, I thank all organizing team, Dilip, Rahul, Shailesh for this convention, and I thank all the delegates for coming in such a large number for this convention. Thank you very much.
Thank you, Deepak sir, from the bottom of our hearts.
Often said that us what you want to hear, but tell what you want to what you need to hear.
Dear friends, it's a privilege to introduce someone who truly embodies the true spirit of a mentor and a guide, Dr. Nikhil Balanke sir, who has always been a pillar, post, axis, fulcrum, or whatever name we can call, the ultimate support at every stage of our endeavors.
Sir needs very little introduction in the field of medicine, and his achievements are innumerous, but they deserve a massive one from us. Sir, every milestone of this convention bears a mark on you.
सर वो कहते हैं ना, सुना है उनके बोलने से फूल झड़ते हैं, सुना है उनके बोलने से फूल झड़ते हैं। अगर ये बात है तो चलो बात करके देखते हैं।
Please join, yes sir. Please join us.
Join me in welcoming a visionary, a steadfast advocate, and a true mentor, Dr. Balanke sir.
Thank you, Monica. I'm still wondering, should I open a florist shop now? I'm not as extempore as Deepak is always, so I've come with small page. And as per Deepak's instruction, 3 minutes बाद mic बंद होने वाला है, तो I'll be fast. Good morning, senior teachers, the colleagues and ladies and gentlemen. This is truly a privilege to stand here for this very important conclave which we have been doing regularly for last 4 years. This one, all these conclaves have a theme, and this year it's a critical care ID interface, which we are going to discuss, where we have spectrum of intensivists, ID specialists, microbiologists, and all the allied colleagues who have come together with a shared purpose. And the purpose is to improve the care of our sick patients who are battling infections. Infectious diseases in ICU are always at the crossroad of urgency, crossroad of complexity, and crossroad of uncertainty, which is always there. And whenever we tell our patients something, they come they bounce back with something different in the front of us. Every day we confront patients with septic shock, severe pneumonias, tropical infections, MDRs, and challenging VAPs and device-related infections. We all the time make difficult decisions on antibiotics, source control, organ supports, and at times we have to even take decisions on end of the life support. And this all is to be done in limited time with very little information, and we have to still hit the target in the best possible manner. As we take those difficult decisions, each one of us should remember that this decision is ultimately related to the patient, to the very anxious relatives who are sitting outside all the time, believing in us, and also to the team which is supporting us around the bed. So we have to always to be judicious, practical, and brave in taking such decisions, which will surely make a meaningful difference in the outcome. So over the course of this meeting today, we will focus on some important things, how we will be able to take these important decisions bravely so as to make a very meaningful difference in the outcome. We have, fortunately, the elite faculties, Dr. Suman, Parikshit, Bharat, and so many others, local stalwarts, Nitin, Ashwini, and so many. And Geetu, of course, always the microbiologist behind us. So even if you're into the mobile, I can see you. So don't worry. You're always going to help us all the time. So all these faculty members have been there shaping the guidelines for us over the period of years. And also they were bringing us the rich real-time evidences from their busy ICUs. So they will surely guide us through the guidelines, but also guide us through those gray zones where guidelines may stop and clinical judgments will start. So I welcome you all again to listen to these experts, the panelists, and to make the difference in our attitude and our approach in ID critical care. Thank you very much.
Now, with the blessings of our mentors, seniors, dignified faculty, and the energy in this room, let us begin this journey of knowledge on a blessed note. We will now proceed with the Deep Prajwalan, for which I request Dr. Balanke sir, Dr. Deepak Jeswani sir, Dr. Deepti Jeswani ma'am, Dr. Rajiv Soman sir, Dr. Parikshit Prayag sir, Dr. Bharat Jagyasi sir, and Dr. Geetu Jo ma'am to please come on stage for Vidarbha chapter.
As this flame rises, let us take a moment to realize that we are not just the practitioner of science, but keepers of sacred trust. In ICU, we often witness the thin veil between the known and the unknown. This lamp represents that spark of life we strive on to protect every single day. We request our dignitaries to please grace the seats, carrying this warmth with them. Ladies and gentlemen, let's light the fourth Criticare Convention and guide us towards the day of true enlightenment.
Before proceeding, we would like to present our token of gratitude to Dr. Balanke sir, Dr. Tanuja Manohar ma'am, who is President Association of Physicians of India, Dr. Ashwini Taido ma'am, Secretary Association of Physicians of India Vidarbha chapter, and Dr. Sanjay Deshpande sir, who is also our MMC observer today for today's convention, who has recently been elected as member of MMC. We are deeply grateful to Dr. Tanuja ma'am and Dr. Ashwini ma'am for their unconditional support in this endeavor. As we gather here to discuss the complexities of sustaining life and battling mortality in the ICU, let us pause for a moment to acknowledge the date. Today is 10th May, Mother's Day. In this room, we have doctors who fight to give patients a second chance at life. But today we honor the woman who gave us our first chance. There is a beautiful concept in biology known as microchimerism, where cells from a mother stay within the child for decades and vice versa. Even as we stand here today as independent experts and clinicians, we are quite literally carrying our mothers with us at a cellular level. Whether they are with us today or watching over us from above, I think the prayers of a mother are the strongest antibiotic against the hardships of life. Happy Mother's Day to you all.
Let's continue on our academic extravaganza by inviting the experts of panel for next two sessions. I invite Dr. Mahesh Sada sir, Dr. Ashish Gandre sir, and Dr. Durgesh Deshmukh. Sir, please. Chairperson, please. For this session, I invite Dr. Parikshit Prayak sir for the approach of carbapenem-resistant Pseudomonas and Acinetobacter infection. Dr. Parikshit Prayak is a consultant transplant infectious disease at KM Hospital, Pune and Dinanath Mangeshkar Hospital, Pune. His areas of experience are transplant, fungal infection and gram-negative infections. Over to you, sir.
Good morning, everyone, and thank you for inviting me. It's the second time I'm coming to this lovely convention. I'm going to be talking about approach to carbapenem-resistant Pseudomonas and Acinetobacter infections. I'm sure you see a lot of this, especially when it comes to Acinetobacter. You know, almost 90% of the Acinetobacter nationally in India is carbapenem-resistant. So let us start with a little bit of the basics. If you look at a gram-negative organism, you know, there are several ways in which it can develop resistance to beta-lactam antibiotics. So normally what happens is all our beta-lactam antibiotics, including the penicillins, carbapenems, cephalosporins, as well as aztreonam, they enter through this porin channel and then they bind to the penicillin binding proteins. So along this path, resistance could be seen at various steps. So there you can see that there is a modified porin channel there, which will not allow our beta-lactams to enter. That could be one. Or you see those little scavengers there with the beta-lactamases. Those are enzymes which are going to hydrolyze our beta-lactam antibiotics. or you could see efflux pumps there, which are going to kick out our antibiotics or the beta-lactams in the opposite direction. Or last but not the least, you could have a final target modification. So the penicillin binding proteins could be mutated, and hence the beta-lactam antibiotics may not act. So let us look at, in the context of Pseudomonas and Acinetobacter, how do these resistance mechanisms apply? So if you look at Pseudomonas, there are certain enzymes which are important. So if you talk about Klebsiella or Enterobacteriaceae, and if I ask you which are the important enzymes, the answer would be something like CTXM, which is an ESBL, or an OXA48, or an NDM, or rarely in our settings KPC, which are all carbapenemases. If you look at Pseudomonas, then again the enzymology or the enzyme spectrum of Pseudomonas is a little different. So you could have KPCs, which is inhibited by Avibactam, but KPCs are rare in our settings. We have very rarely found a Pseudomonas which is a KPC producer. We have plenty of class B enzymes. So these are our metallobeta-lactamases, NDM, VIM and IMP. And VIM and IMP are also extremely important in the face of Pseudomonal infections. We have our fair share of GESs. We usually see about 3 to 4 GES producing Pseudomonas, at least in our ICUs every year. And then there are certain ESBLs of Pseudomonas like PER and Webb, which are a little different. And Pseudomonas could have inducible AMPCs. So these are very, very different from the enzymes that you see for Klebsiella and E. coli. And that has a bearing on the clinical management or the therapeutic choices that we make for Pseudomonas. So if you look at all these enzymes, then unlike, Klebsiella and E. coli, not all are inhibited properly by Avibactam. So if you look at the spectrum of Avibactam here, then it's going to inhibit KPC, but which is very, very rare in our settings. It's going to inhibit GES to a certain extent, but there are certain subtypes which can be problematic, as I'll show you later. And AMPC is going to be inhibited. But importantly, class B enzymes of Pseudomonas, as well as some class A ESBLs like PER and Webb, remain a problem. In fact, there are reports to suggest that Relibactam actually may be a better BLI against some of the class A ESBLs of Pseudomonas than Avibactam. And that's not the only way in which ceftazidime avibactam can become resistant. So if I ask you, what is the commonest way by which the antibiotic ceftazidime avibactam becomes resistant as far as Pseudomonas is concerned, the answer is going to be NDM or efflux. But there are many mechanisms beyond NDM and efflux which could lead to the resistance for ceftazidime avibactam as far as Pseudomonas is concerned. So like I said, PER and Webb, these are often not noticed properly because, very few of the genotypic tests that we do will be detecting these. So let's call them the CTXMs of Pseudomonas. So they are the ESBL equivalents of Pseudomonas, and they are a little different. So Avibactam doesn't quite inhibit them as well as some of the other BLIs. Most BLIs are disappointing. Relibactam to a certain extent is slightly better. Then you could have certain GESs. The study there shows that certain GESs could be also refractory to the inhibition of Avibactam. There could be certain modifications in other enzymes. So there could be modifications in other enzymes like OXA10, or there could be rarely mutated KPCs, there could be mutated PDCs or AMPCs or pseudomonal derived cephalosporinases. So all this can lead to very complicated resistance patterns as far as Pseudomonas is concerned. But that's about the enzymology. So if you had to summarize the enzymology, PER and Webb are important ESBLs. They are not well inhibited by Avibactam. We have plenty of class B enzymes. Of course, they are not inhibited at all by Avibactam. You could have an inducible AMP-C. Rarely you could have other enzymes like GES, which is a class A carbapenemase for the most part. You could have the other enzymes like OXA10 and so on. But more importantly, or as importantly, I would say, is the non-enzymatic resistance for Pseudomonas. So there you have a lot of efflux. So in our settings, AMP-C, class B enzymes, efflux, and then things like GES or the class A ESBLs like PER and Webb. These are important resistance considerations as far as Pseudomonas is concerned. So how does all this play into clinical practice? And then you have mutated porin channels. So rarely if you have a Pseudomonas which is having raised MICs for the carbapenems, but which is actually susceptible to, let's say, a piperacillin tazobactam or a cefepime or a ceftazidime, you could be smelling a mutated porin channel there. So what do our options include, if you have a carbapenem resistant Pseudomonas? So again, the enzyme pattern doesn't quite tell us the therapeutic choices immediately, which means that basing these choices for pseudomonal therapy just on the basis of a sepsis flow or a PCR test or an enzyme test may not give you the complete picture, because like I said, there are resistance mechanisms beyond the enzyme. So what do our options include? One is our good old Cas-Avi plus Astonam, or now as we have it, Astonam, Avibactam.
Then you could have polymyxin based combinations. Now the problem here is which combination to use as far as Pseudomonas is concerned, because a lot of the drugs that we use for Enterobacteriaceae or for Acinetobacter as combination therapy have inherent resistance. So all the tetracyclines, tigecycline, minocycline or Bactrim or all these drugs, chloramphenicol, they are not going to be your choices for Pseudomonas. So that is where the problem lies. So polymyxin based combination therapy is easier said than done. And then if you look at the newer agents, then ceftazidime and cefepime zidibactam would perhaps be the most useful when it comes to Pseudomonas. So a lot has been said about Aztreonam avibactam for Pseudomonas, and if you look at some of the global studies, then they are disappointing, but I wouldn't quite discard Aztreonam avibactam as a therapy for Pseudomonas. In our own settings, about 20% of our carbapenem resistant Pseudomonas still remains susceptible now that we have the e-test. And especially even if you have MICs of up to 8 or 16 in renally impaired patients, there are ways in which you can overcome these type of MICs by using the combination of Aztreonam and avibactam. As it is, the choices there are polymyxin based combination therapy. So something like a polymyxin plus phosphomycin, which is not an ideal combination for Pseudomonas. So while we are struggling with polymyxin based combinations, I don't think it's quite time to close the door on Aztreonam avibactam. We have had plenty of, I wouldn't say plenty, but we have had our fair share of patients who have done well with this combination. But the caveat is that you would like to know the MICs before I treat him. So if I just know that there is a carbapenem resistant Pseudomonas, I wouldn't rush to start this patient on Aztreonam avibactam. You would want to get your MICs, you would, if you're not getting access to the strip or the test for Aztreonam avibactam, you would want to know the synergy as well. And you could play around with the synergy, use different concentrations that you can in the synergy and get at least a rough idea of the MICs that you're dealing with. What about ceftazidime? We started by saying that class B enzymes and efflux are a major problem in India. And then you also have AMCs, you also have certain GESs, you also have certain class A PERs and webs. Now ceftazidime looks wonderful because two of these are really not problems for ceftazidime at all. So class B enzymes as well as efflux, ceftazidime is quite immune to resistance by these mechanisms. But if you look at the data, then for Enterobacteriaceae, the data that has evolved subsequently isn't looking very great. So if you look at this large study, which included more than 80,000 isolates, ceftazidime non-susceptible or non-susceptibility rates were relatively low for Pseudomonas, but they were fairly high for Enterobacteriaceae. Look at NDM producing Enterobacteriaceae, almost close to 39% or more than 40 or close to 45% for NDM producing Acinetobacter. So this could be a useful drug in the face of pseudomonal infections, but again, having access to testing and having access to the drug itself remain challenging in our settings. And there are ways in which ceftazidime can also become resistant. So you could have siderophore receptor mutations, or you could have certain PDCs or pseudomonal cephalosporinases. You could have PBP mutations that can affect ceftazidime. So all these, there are reports of mutated NDMs, which have against which ceftazidime has not done well. So there are challenges there, but overall the challenges for ceftazidime seem to be less than the challenges for ceftazidime in the face of carbapenem resistant Enterobacteriaceae, especially NDM producing Enterobacteriaceae. Now if you look at cefepime zidibactam, and we would probably have access to cefepime zidibactam later this year. Now what is cefepime zidibactam? So this is a combination of cefepime and zidibactam, but zidibactam there is not just a beta-lactamase inhibitor, it's also acting as an enhancer. So the reason is that it has different sites of activity as against cefepime. So if you look at cefepime, then it binds potently to PBP3, whereas zidibactam is related to PBP2. So a lot of the resistance mechanisms are actually overcome, and this is a BLI. So remember, a beta-lactamase cannot hydrolyze a BLI, and that is what works in its favor. So it's an antibiotic enhancer. It is also relatively unaffected by enzymatic production because it itself is not a beta-lactam drug. So there are two important things here. This is a large study of close to 25,000 isolates, and look at the ceftazidime avibactam non-susceptible Pseudomonas and ceftolozane tazobactam non-susceptible Pseudomonas. So what does it tell you? That it is a good drug in the face of NDM production, because both these essentially are affected by NDM production. So if you have a ceftazidime avibactam resistant Pseudomonas, high chance that it has NDM or efflux, and if you have a ceftolozane tazobactam resistant Pseudomonas, high chance that it has NDM. So against both these types, it is retaining a high amount of sensitivity. Also, efflux production doesn't seem to affect it as much as some of the other antimicrobials. So look at this, even in those isolates in which efflux was raised, or efflux was highly raised, you can see that the MIC 90 values are quite acceptable. So that's why this is going to be a good drug when it comes to Pseudomonas infections going forward. So right now our options remain test and treat as far as Astronam avibactam is concerned. Again, you can push it even for slightly higher MICs, but that really depends on the renal parameters and how well you really optimize your pharmacodynamics. Polymyxin plus fosfomycin is a regimen that we've been using now for the last few years for our carbapenem resistant Pseudomonas, especially when they fail the synergy test. And like I said, other agents like cefepime, zidibactam and cefderichol. So I'll quickly go through this case. This was a patient, and I'll skip to the important part. So this was basically a patient with hairy cell leukemia in the interest of time, who was shifted to the ICU with a large lobar consolidation and increasing hypoxia, was started on meropenem and teicoplanin, intubated, started requiring inotropes, and then look what the BAL biofire panel is showing. It's showing Pseudomonas, but it's not saying any of the markers detected. Now that's a problem there because we have many non-enzymatic mechanisms of resistance, and we also have many enzymes that are not a part of this panel. So the teicoplanin was stopped, and the sepsis flow which was sent is actually showing Pseudomonas and just identified. But even at this point, can we really change him to something like ceftazidime avibactam? No, not really, because there are certain GES types which may not be completely inhibited by avibactam. So that's why we had put him on polymyxin fosfomycin, and then after confirming the phenotype, we had switched him to ceftazidime avibactam. So in the interest of time, I had to rush through it, but it just shows that when it comes to the genotypic tests, it really doesn't reveal all the picture as far as Pseudomonas is concerned. So that's why it can rule in resistance, but it can't really rule out resistance for a lot of the antibiotics that we use. Now let's quickly go over to Acinetobacter in the last 5 or 7 minutes. Very often we see cultures like this which are carbapenem resistant. Like I said, in our own ICUs, the carbapenem resistance rate for Acineto is more than 90%. Now Acineto has different carbapenemases. We talked about Pseudomonas and we said that JES, PERWeb, NDMs, AMPCs, certain oxatens, those were the problems. When it comes to Acinetobacter, the bulk of the resistance is because of either class B enzymes or the oxa enzymes, and their weightage is almost 50-50. So this is a study that we published a few years back, and there is a fair amount of NDM in our settings as well. Almost 46% of the isolates in our settings were NDM producers, and NDM plus oxa 23 it seems to be a very common pattern for carbapenem resistant Acinetobacter in our settings. Add to this the fact that avibactam doesn't inhibit any of these important carbapenemases of Acinetobacter. Add to this the fact that Astronam is a poor anti-Acinetobacter drug. And add to this the fact that many of the other drugs that we use, including fluoroquinolones or aminoglycosides, have very high resistance rates when it comes to Acineto. So that makes treating Acinetobacter quite challenging in our settings. So let us try to answer 2 or 3 important questions about Acinetobacter therapy when it comes to carbapenem resistant Acinetobacter. So monotherapy or combination therapy, something that was debated at least 7-8 years back, but now IDSA, the last guidance statement, remember these are not guidelines, but this is a guidance statement, but the last IDSA guidance statement says that combination therapy should be favored, and it is completely reasonable because there is very little literature to really support monotherapy even in the face of a susceptible drug. And we often use polymyxins as backbones. So we all know how challenging it is to use polymyxins. If you look at large studies on carbapenem resistant Acinetobacter, the mortality rate with polymyxin usage is very, very high. So with monotherapy, with all the PKPD problems, poor activity when it comes to pulmonary infections, unpredictable levels, very little difference between what is a good level and what is a toxic level. So last 20-25 patients in whom I have done polymyxin B levels, the results have been very, very erratic. Some patients would have very low levels, some patients would have high levels. So it is very, very difficult to predict polymyxin levels even if you use good dosing strategies for these type of infections. So we are now fairly clear that we need combination therapy for carbapenem resistant Acinetobacter. The question is that which drug will you use as a combination agent? So just as we have started moving or have moved away from a polymero combination for our Enterobacteriaceae, there are 2 large studies which suggest that adding meropenem to polymyxins doesn't really do much for our carbapenem resistant Acinetobacter. So on one hand, we are saying that we need combination therapy. A lot of times we'll use polymyxin as the backbone in our settings, but we are also saying that the combination of polymyxin plus meropenem is not going to do much for our carbapenem resistant Acinetobacter. So both these studies showed that the combination of polymyxins plus meropenem really didn't give us any great benefit over polymyxin monotherapy. And that's why what are our options for combination therapy? So again, we are looking at a situation in which we are saying yes for combination therapy, but what are our options for combination therapy? As I showed you our own data, OXA23 plus NDM is an important genotype of our Acinetobacter. So a lot of our isolates produce this combination of OXA23 plus NDM. This study showed that the combination of minocycline plus sulbactam was actually a good strategy for OXA23 plus NDM producers. So that's one thing that you can look at. So anytime you have a carbapenem resistant Acinetobacter, if you're going to choose polymyxin as your backbone, one important thing to look at would be the minocycline MICs as well as the tigecycline MICs. So you can't extrapolate one from the other. There are different resistance mechanisms. So TET-B and TET-X are different resistance mechanisms. So you can't extrapolate the MICs of minocycline from tigecycline and vice versa. So one good strategy to employ would be to look at these MICs, ask the lab to give you both, especially if you're not dealing with a bloodstream infection. Now, sulbactam MICs, ideally, the broth microdilution for sulbactam from scratch or manually is a difficult test to perform. There are Eastern Asian studies which suggest that sulbactam MICs can be high in our settings. So, we do certain surrogate ways of looking at it. So, for example, looking at the ampicillin sulbactam zones or looking at the cephalosporin sulbactam zones, but these are not methods which are standardized to look at sulbactam MICs. So while if you get a decent zone, it can give you some hope that there is some sulbactam activity, because when there is NDM or oxas, the cephalosporin or ampicillin shouldn't be helping at all. But this is not a great way of looking at it. So one thing would be to look at the minocycline and tigecycline MICs when you're choosing a combination drug. If you can have one of them as sensitive, that's a very good situation. If those are also resistant, then you often have to go to triple combination regimens like polymyxin plus sulbactam plus tetracyclines like tigecycline or minocycline, depending on the relative MICs and very importantly depending on the site of infection. So if you look at large studies, then the triple combinations, although not really magical, have shown some benefit. And last but not the least, the time is almost up. Last but not the least is the sulbactam dosing that you use for your Acinetobacters. So you use almost 9 to 12 grams of a total daily dose, and this is how you would renally adjust. So if you have a patient, let's say who is on CRRT, then you would give a 3 grams every 8 to 12 hourly. So this is important because this is the sulbactam dose, and we have the luxury of having plain sulbactam with us, unlike the Western world in which, they have to use ampicillin along with it. And lastly, just a couple of words on sulbactam durlobactam. So we said that none of the Acinetobacter oxas 23, 24, 51 or 58 are really inhibited by avibactam. For the first time, we'll have a BLI, durlobactam, which will inhibit the Acinetobacter oxas. So that will solve a part of the problem. It has been combined with imipenem in studies in which it has done well, especially for oxa producing carbapenem resistant acinetos. Almost done. But our problem, like I said, at least 50% of our problem is the NDM producing Acinetobacter. So there it is going to be a problem. So in studies in which they looked at pure NDM producing isolates with oxa, of course, and combined sulbactam durlobactam with imipenem, there wasn't much of a reduction in the MICs. Maybe the log kill curves looked slightly better, but really there wasn't any noticeable difference in the MIC reduction. So that's going to be still our problem going forward. So I'll summarize by saying that carbapenem resistant Pseudomonas has many complex enzymatic as well as non-enzymatic mechanisms. So KPCs in the Western world, as well as JES, which can be a class A carbapenemase, PER and Web, which can be class A ESBLs, or class B metallo-beta-lactamases, of course, AMPCs and certain class C enzymes, certain oxas like OXA10. These are all important enzymes for Pseudomonas, enzymes that we don't normally talk about because we use usually panels which detect the enterobacterial enzymes. And there are non-enzymatic mechanisms like efflux and porin mutations. Astronam avibactam, I would say that, like I said, the door should not be closed on it. Definitely there is a huge place in our settings, but it needs to be tested before using it. Polymyxin and phosphomycin is currently an option that we've been using, but that's not to say that that's really a magical therapy for Pseudomonas. Cefepime zidibactam and cefderichol are promising drugs, especially cefepime zidibactam in the space of Pseudomonal infection looks promising. And for carbapenem resistant Acineto, again, the enzymes are different. So you have NDM as well as the Acinetobacter oxas. In India, NDM is also a significant problem. Almost half of our acinators also produce NDM, the carbapenem resistant ones that is. We should consider combination therapies. Perhaps in our settings, we would be using polymyxin as a backbone. The second drug, the best way to look at it would be to look at the minocycline, tigecycline MICs, ask the lab to test for these both. If they are also resistant, going to drugs like sulbactam, and hopefully, in trying to set up the broth microdilution for sulbactam in our labs. I think because even with sulbactam and durlobactam, our problem with NDMs is not going to be solved. So polymyxin plus meropenem, when it comes to the combinations, polymyxin plus meropenem likely offers no advantage over polymonotherapy. Combination regimens containing polymyxins plus sulbactam and or minocycline can be considered, but always ask your lab to test for both, because the resistance for mino doesn't predict resistance for tigecycline and vice versa. And though sulbactam durlobactam is promising, its use in our settings is going to be limited by NDM production. So I'll stop here. Thank you for the patient listening. If there are any questions, I'll be happy to take.
Thanks, Parikshit, for your informative lecture. As we know that CRP and CRBJ are always very difficult to treat, and they are really the nightmare for any critical care physician. So here we can take some questions from audience if they have. Sonal sir.
Yes, even certain power variants also.
But not recently, but we had one patient whose whole genome sequencing showed Web, and I had, before that data only, I had tried Astronam plus PIP test, along with source control and various other things.
Right.
And that seemed to work, but I could not find any reference.
Yes, I am not aware of any reference wherein tazobactam can work for Web, sir, but perhaps one explanation is different efflux pumps there along with Webs. So that there are certain efflux pumps which may have affected the piperacillin tazobactam less. So it perhaps would have been there in enough of a concentration, but that's just a hypothetical situation. But if you just look at in vitro studies, then tazobactam is a poor drug against Web. Okay. Right. It would have been interesting had we had relibactam in our settings, to look at then Astronam plus imipenem relibactam in that sort of a setting, because that's supposed to be a better BLI for Web. So that the difference would have probably given us some idea about how significant Web is in that isolate.
So we had NDM in all the expert carba and whatever tests we did, but whole genome sequencing did not show NDM. That is also something which is very fun.
Right.
So I think it's very difficult to really treat some of these patients. Although we have so much of data and so many tests,
Right.
how reliable are the tests?
Absolutely.
And do you think whole genome sequencing trumps all the other tests or not? That also, I'm not so sure.
I don't think so, sir. Especially in in Pseudomonas, there are so many things that a genotype for Pseudomonas can sometimes actually confuse you as far as therapeutics is concerned, more than guide you.
Thankfully, the genotyping came much later.
Thank you, sir. Your wonderful presentation. What is the role of, sir, imipenem or meropenem extended infusion in the treatment of CRAB?
So not really, if you look at so the problem, like I said, is that we have a lot of NDMs and even the oxas of acinator, especially oxa 23 is a very powerful oxa. So you will often see very high MICs with that. And like I showed you, there are two large studies which have shown that the addition of carbapenems doesn't seem to make any difference. So even optimizing the pharmacodynamics of carbapenems, they are so up against it in that situation that I don't think it's going to really matter. So so we should be moving towards non-poly plus meropenem combinations for acinetobacter.
And what is the permissible highest dose can be given as a ampicillin sulbactam in a CRAB patient, sir?
So the doses recommended are about 9 to 12 grams for patients with a normal creatinine. These would be split into 3 to 4 doses during the day. So those are the doses which have been studied. If you look at the IDSA guidance statement, again, that takes into account ampicillin as well. So those numbers are different. But if you look at just plain sulbactam, then around 9 to 12 is what has been studied. And these are largely in vitro studies.
Yes, sir. What's your experience about the cefdicol use and the side effect if you have any observed?
So cefdicol for Pseudomonas, like I said, theoretically is a good drug because the class B mediated resistance, metallo-beta-lactamases as well as efflux is largely circumvented. And in studies also, the Pseudomonas numbers look good. Enterobacteria has been disappointing. When ceftazidime was launched, or when ceftazidime started making the news a few years back, there was a lot of enthusiasm, and subsequently the enterobacterial enthusiasm has dampened significantly. But in Pseudomonas, still definitely there is a place. The problem again is access to ceftazidime. But once we get cefepime, zidibactam, we expect that in our settings to be a better choice. If not worse, definitely on par or better.
Yeah, thank you, sir. Yeah.
Thank you.
Good morning, sir. Sir, as a lab person, there are no CLSI guidelines for tigecycline for Acinetobacter. So what is your call for this using tigecycline in Acinetobacter infections?
So, regardless of whether there are guidelines and whether this is Acinetobacter or not, I think the most important factor for using tigecycline is the site of infection. Because what you get in the bloodstream is very different from what you get, let's say, in the biliary tract. So you would get really, few hundred times the levels that you get in the blood in something like a biliary tract. So if I have, let's say, a cholangitis and this patient has an MIC of even 1 or 2, I would be happy to use tigecycline as a part of the combination regimen. If it's a bacteremia, then things are different. But having said that, I mean, there are also case reports of tigecycline being used for enterococcal endocarditis. So that's not to say that tigecycline should never be used in the face of bacteremia, but I think more than the breakpoints, what is really important is the site of infection there. So certain sites of infection like the GI tract, skin and soft tissue to a certain extent, those are much better sites to use tigecycline. So you would look at tigecycline in the context of what the MIC is, what the site of infection is, and what kind of dose can I give to my patients, which means that what is their hepatic status, what dose can I give them, and so on.
So, but then Vitek has masked MICs for tigecycline. So, what can we do in this setting? Like this question may be more relevant to GP.
Yes.
You can enter that into your machine.
Correct.
So, Vitek, the biomarker applies CLSI. For tigecycline specifically, you can upload the US FDA breakpoints 248 into your machine. So, it gets interpreted accordingly. Biometric people do not support, maybe we're quite reluctant to do that. And we had that feedback. Okay, I'll talk to them.
I think that applies to any antibiotic rather than just looking at what the CLSI defines the breakpoint as, looking at the patient and where the infection is and how can I really utilize my MIC to the best possible extent. I think that's far more important than whether this would be labeled as a sensitive isolate or a resistant isolate by CLSI. That applies to a lot of the antibiotics that we use.
Okay. Thank you so much, sir. Thank you.
Dr. Parikshit, for giving kryptonite we need for these superbugs. Now I request Dr. Deepak Jaswani sir to felicitate Dr. Parikshit. In ICU, we have a bit of love and hate relationship with our equipment. We love what they do, but we hate the uninvited hitchhikers they bring along. These device-related infections are essentially the tax we pay for high-tech life support. So I request Dr. Rajiv Soman to come on stage for the device-related infection. Over to you, sir.
Thank you once again. So we use devices because they support structure as well as function. But sometimes having a device, surgery for the device is like entering an unknown cave because you don't know what is lurking inside. The most important danger which is lurking inside is infection. And once you have a device related infection, it's a big problem because cure is seldom possible without device removal. And all this centers around this infamous, we have a wonderful famous Nagpur center point, but Unfortunately, the biofilm, which is also a center point of all these device related infections, is notorious. The initial adhesion of all the bacteria to the device is by physical forces, electrostatic, hydrophobic, and all that. However, some organisms, especially Staph aureus, have certain receptors which really make them home onto the device very easily. And then what happens further is the formation of this biofilm. So the biofilm organisms attach to the substratum as well as to one another and are embedded in a matrix which is a barrier both for WBCs as well as for the drugs. Not only that, the existence of this biofilm blunts the inflammatory response, and therefore even diagnosis becomes a problem, and of course treatment becomes even more of a problem. Now all the phagocytes are sort of hyper excited and are trying to get rid of the bacteria, but they cannot, because they cannot easily penetrate the biofilm. What the whole thing lands up in is to produce all the lytic enzymes by the WBCs, which only destroy the surrounding tissue. For example, it will lyse the osteocytes and all the bone tissue, thus producing implant loosening and so on. Similarly, the biofilm can also get disrupted if it is intravascular, like in a device related infection, on prosthetic valve endocarditis and so on, and you will get embolization in various tissues. Friends, it's very simplistic to think of this biofilm as just being a barrier, the barrier to the WBCs and to the drugs. However, there is much more to it than this. The gene expression of the organisms which are inside the biofilm is altered. So now the phenotype changes to a very non-aggressive but highly resistant form. And the MICs of the organisms within the biofilms can be many thousand times more than what we measure in the laboratory, which is of the planktonic organisms. So obviously, if you want a drug which is going to work against the biofilm organisms, then that drug has to be bactericidal. It should be able to penetrate the biofilm. It should work against stationary phase. Remember, when bacteria are not even multiplying, the cell wall active agents or the machinery that's required, which you can paralyze, that's going to be of no use, because they are in a very, very slowly multiplying phase and shouldn't have an inoculum effect. Now, needless to say, we do not have any such antibiotic, and therefore it means that the device has to come out. So cure is seldom possible without device removal. And how many devices do we keep implanting? And the number is growing every week. For example, here we have a CSF shunt, we have a ureteric catheter. You have this ureteric catheter which is infected with fungi. As you can see, these fungal balls are being produced. You have the spinal implant which was infected with NTM, and it had all got loosened when it was easily plucked out from the body. You have central venous catheters, including perm cats, which are used for dialysis in various types of centers all over our country. Needless to say, we have a lot of these kind of infections. And sometimes in the orthopedic oncosurgery, they have to use mega prostheses, which are really huge ones. And if they are infected, obviously it is going to be a disaster. I have organized my talk around two cases, which are somewhat contrasting with each other, and let's see what do we make out of them. So here we have a patient who had a PTCA at bead and then had chest pain. There was a total occlusion of the stent, and as you can see, the stent is actually protruding out from the artery. So there is actually a mycotic aneurysm and the stent is already protruding out. The findings were confirmed at CT coronary angiography. The PET showed a high uptake, no other lesion was found, the blood cultures were negative, multiple cultures were negative, and with that the patient was referred for an ID opinion. Oops. So in this setting, which organisms can be suspected? What empiric treatment can be given to him? When should surgery be performed? And how can treatment be modified based on the smear, PCR panel, culture, and DST? These are the questions in front of the ID physician. So 3 or 4 important organisms spring to our mind. One is NTM. Remember bead, remember PTCA. We see large number of patients with NTM coming from that particular center. Pseudomonas, another important device related, stent related infection, Staphylococcus aureus, including coagulase negative, all of them can be there, and Candida also can be there. So can I fashion some empiric treatment? So I thought of using amikacin, linezolid, and tigecycline, at least in the beginning after the cultures had already been drawn. So some of these could be covered in this manner. But even before further details came, the patient started getting more and more angina and acute coronary syndrome. So the patient had to be taken up for surgery immediately, 2 days later. And there was an inadvertent rupture of the ventricle, and therefore braided Teflon sutures were used for the LV perforation. Okay, now that produces further problem with the device, because now you have removed one device but you have put a new one. So at surgery, what do we see? So there were organisms seen on smear. So you have GNB, GPC, and also a yeast. All of them were seen on the smear, which tells you that can be any contaminants or anything. They have to be in large numbers, and that's why they are seen. This has been obtained from a sterile site by a sterile procedure. And remember, 2 previous instrumentations in this patient had been done, and these are vasculotropic organisms. So I have to give a lot of importance to these. So the PCR panel also was done from that tissue, and what it showed was NTM was negative, but the JI panel, the PCR panel which was done, obviously this is a repurposed use of the JI panel for this kind of a specimen, and that showed Pseudomonas with no resistance markers. But Parikshit has just told us that don't make a big issue of it. No resistance may not mean anything. So this may or may not have resistance. The JI panel was negative, although the gram-positive cocci were seen. So very likely this is SOSA. Now SOSA is the new name for CONS. So now it is CONS, means coagulase negative staph was the old name. Now the preferred name is Staphylococci other than Staph aureus. Okay, so maybe this is there because this organism is not present in the JI panel. Now whether it is MS, means susceptible to methicillin, or resistant, we don't know. The JI panel also picked up the Candida albicans, and we know from prior knowledge that 10% of even albicans can be resistant to fluconazole. So be a little wary about that. So predicted resistance, we cannot be certain about this. Okay, so the need to cover as well as have biofilm activity, because you have removed one device but put a new one. So ceftazidime can be used perhaps, because stent related Pseudomonas somehow are often susceptible to ceftazidime. But this is not it's not a verifiable fact. Plus maybe ciprofloxacin. Then daptomycin may be better than linezolid for its better anti-biofilm activity possibly. And maybe micafungin may be preferred to fluconazole before you have further data. Again, because micafungin would work for biofilm related organisms. And then these were the 2 organisms which grew out in culture. So you have Pseudomonas and you have this MR SOSA. Interestingly, here is Astionem was found to be resistant, and that could have been due to efflux, as there is no ES-bale seen on the panel. So after seeing this culture in DST, it was found to be susceptible to ceftazidime and fluoroquinolones, but there could be additional non-enzymatic resistance such as efflux and porins. And sometimes I would say that MIC actually gives you more knowledge or information than just the resistance mechanism. Then MR SOSA was susceptible to daptomycin, so continued that. So initial treatment which was given was somewhat modified at the time of discharge. The patient received all this treatment for about 8 weeks, and this really resulted in cure. All future further cultures were negative, and the patient is absolutely well 9 months during follow-up. The second case is not so fortunate. So she's an elderly lady, hypertensive diabetic. Her TKR was done elsewhere. She developed a prosthetic joint infection, and this was a report from outside. This is a very old case of 2014. And if you see, this report is actually uninterpretable. So it's reported as resistant to linezolid but susceptible to vancomycin, as well as to oxacillin and so on. So can't really make head or tail of this report. Anyway, the patient underwent multiple debridements with retention of the prosthesis. Now, this is a strategy which is unlikely to work after 3 months of all this, and received multiple antibiotics over 1 year. So, linezolid, trimethoprim sulfa, and every other antibiotic was used over the course of 1 year. I am sure you have seen patients like this coming to you. So on presentation, that time I was at Hinduja in 2014, the patient underwent resection and removal of the hardware, finally. And during this, Acinetobacter was seen, although the original, whatever staph was there, was no longer seen. So maybe this was an organism which was acquired during the multiple lavage procedures which were done earlier. So the patient was treated 2014, remember, with colistin and daptomycin. The PET scan showed that the proximal bone was not that much involved. So, but now the removal of only this much part of both the femur as well as tibia would make shortening so much that walking would be impossible. So in this situation, you have a problem. So although you can get rid of the infection by this kind of very major resection, the limb shortening will be unacceptable. Now why did it come to this? Because of all the inappropriate early management which led to this particular predicament of the patient. So patient had to undergo a abounding amputation for this. So if the infection is extremely difficult to control, carries a huge morbidity, life-threatening, or it is mechanically unsound, as in this particular case, you have to recourse only to amputation. And therefore, it's very important to get it right the first time. In other words, to prevent this infection. And even if it occurs, don't take it personally, but try and, take the adequate strategy in order to treat it. So these two cases, the first one was a high complexity case. The second was a relatively less complexity. The conventional microbiology inputs such as smear, culture, and drug susceptibility test was excellent inputs, and we could base the treatment based on that. On the other hand, in the second case, the microbiology itself was completely unreliable and suboptimal. Now, PCR panel, it was used in this first case along with very careful interpretation, and also what may not be there on the panel, that also has to be thought of, and accordingly treatment has to be planned. That was not applicable in 2014. The ID involvement was early in the first case, but it was late in the second case. Surgery early and appropriate, and late and inappropriate, and outcome was favorable and really unfavorable in the second case. So really it tells us how it is very important to have all these things right on board in the beginning. So some of the special problems with devices in India is like this, that we have poor infection control as well as surveillance of SSI. We always see most orthopedic and other surgeons saying that I never have any surgical site infection. Nobody comes. If there is no news, it's good news. That means the patient is all right. Nothing could be farther from truth. Improper prophylaxis for clean surgery as well as implant surgery, inappropriate initial procedures and antibiotics. And there is so much of a psychological barrier to acceptance of the diagnosis of implant related infection. They take it personally. Remember, it's not a personal failure. It's a failure of the whole system. And if you take an adequate action right at the right time, many things can be salvaged. So threshold for acceptance of the diagnosis, exclusion of surgical site infections from the differential diagnosis. Think of typhoid, malaria, urinary tract infection, but don't think of implant related infection. This is how we think. Isn't it true here too? Yeah. And viewing it as a personal failure, it's nothing personal. Okay, but it's a lost opportunity for the patient, as you saw in the second patient. So microbiological diagnosis is frightfully important because empiric treatment is impossible without having that diagnosis, and multiplex PCR tests probably hold good promise. Now the problem in India is we don't have only these SOSA or CONS, but we have MDR GNBs, we have MRSA, we have MDR enterococcus, fungal, and even NTA. Now antibiotics are often used preoperatively, but empiric choice is difficult and actually hampers with the getting of the culture being positive. So antibiotics being used as the sole strategy, but remember, no antibiotic works efficiently in biofilm. If there is a high inoculum, we allowed the infection to linger on for some time, and stationary phase organisms. So I'll close by saying that you must have a high index of suspicion. Somebody who has a device inside, always first keep that in your differential diagnosis. You have to stack evidence for and against the diagnosis. Remember, all the tests will not point and the clinical findings will not point in the same direction. Often there is a tussle between the physician and the surgeon. So, he is not very sure of the infection. Nobody can be so sure. So takes quite an effort to stack the evidence for and against. But identification of the organism is absolutely needed. As I said, device removal can be a drastic but ultimately necessary step in many cases. And a patient faces multiple surgeries, great expense, prolonged hospitalization, renewed disability, and even death. And therefore, synergy of a multidisciplinary team is all very, very paramount. So why do I, in this team, I have microbiologists, we have ID physicians, we have some orthopedic surgeons who are very much into this infection related stuff. We have cardiac surgeons, we have nephrologists. So all of us can function as a team only if you have not just good working relationship, but because we trust, respect, and care for one another too. So your opinion is valued by the other team member and vice versa. So only if you have that kind of a working environment, it becomes good to treat this type of difficult infections like device related. With this, I'll stop and thank you for your attention.
Thank you, sir. Thank you very much. Anyone wants to ask some questions?
Everybody's
Thank you, sir. Thank you very much.
Thank you, Dr. Soman. It's sobering reminder that our beds devices can also be our biggest challenge if we don't stay vigilant. Now I request Dr. Deepti ma'am to felicitate our eminent chairperson, Dr. Mahesh Sada sir, Dr. Ashish Gandre sir, and Dr. Durgesh Deshmukh sir.
Marching on to our next two sessions, we would like to invite our next team of expert panelists to chair the next two sessions. Dr. Ajay Sakhre, who is a critical care medicine and intensive care specialist at Viveka Hospital, Nagpur. Dr. Utkarsh Shah, physician and critical care specialist at Arihant Hospital, Nagpur. And Dr. Madhvi Deshmukh, consultant microbiologist at Dhruv Pathology, Nagpur.
Chairperson, please.
Next up, we are diving into the sacred art of microbiology divination. We have all been there. Is it a contaminant? Is it a colonizer? Or is it the true villain of the piece? To help us stop guessing and start interpreting, please welcome Dr. Geetu Jo, who is a consultant microbiologist at Jupiter Hospital, Pune. Over to you, ma'am.
Hello, good morning, everyone. Thanks, Deepak sir, Deepti ma'am. It's my second time here at this brilliant conference. So how should the clinician read the microbiology report? This is the topic given to me. So we'll start off with a few subheadings or sections. I've divided my talk as, let's talk about the specimen. From the report, can we make out whether the specimen is optimal, suboptimal, or contaminated? So we all know, as the speaker who spoke about AI, he mentioned garbage in, garbage out. So if you receive a good quality specimen, then definitely the quality of the report would be much better. So is it a right specimen? Is the volume adequate? What about the quality of the sample? Let us take a few examples. If we have a swab from an open wound, Swabs are less preferred by microbiologists and by laboratories. The microbiologists here will agree with me. One is because it collects the extraneous microbes. We are really not sure whether they are the contaminants or the flora of the skin from where they are collected from. Extremely small volumes are picked up in the swab. It's difficult to get away the organisms from the swab fibers. They get stuck to those fibers, and the inoculum, when you're spreading the swab over the culture media, the inoculum is not very uniform. So two such examples. This was a bed sore wound near the sacral region. E. coli and enterococcus, are we sure could they be perennial flora organisms? This is a left cheek swab collected from within strep mitis oralis. So this could be oral flora again. So we are really not sure when the sample is a swab. The guide to utilization of microbiology laboratory by IDSA. So a general rule of thumb is given by them where you can always go for a swab from a nose, nasopharynx when you're performing viral PCRs, respiratory PCRs. Sometimes reluctantly you should use a swab and correlate clinically when you're collecting it from open wounds. Never to use a swab when you are performing any fungal acid fast, looking for acid fast bacilli. Anaerobes are suspected. When you have an intraoperative fluid and exudate and a swab is dipped into that and then submitted to the lab. What about sputum? A very brief case, a 72-year-old patient had a bad X-ray, the sputum LRTI, I'll read this out for you, showed CT exam, Klebsiella pneumoniae and Pseudomonas, 10⁵ bin copies, not very bad. But do you need some additional information before choosing to treat this biofire? So you should actually look for the gram stain on the report. Sometimes there's a mention of a Bartlett score. So this shows a scoring of 0. So anything below 0 or below that is considered as a contaminated sample. It can be salivary contamination. Apart from that, if you do not want to remember the scoring, look at the pus cells, look at the epithelial cells. So the number of epithelial cells is way above that of the pus cells, indicating a salivary contamination. There is candida also, which also hints the same. So the same patient whose sputum showed 2 organisms, the primary team were tempted to treat, bronchoscopy was done, bronchoscopy turned out to be negative and they found an alternative explanation. Actually, it was a connective tissue disorder. So the message that I want to give here is first always check the quality of the sample. Another quick case, a 59-year-old male patient, there was a family clustering, dry cough, fever, rapidly worsening breathlessness. Budding yeast cells were reported in the sputum smear, upon which you can see Forcan was started immediately. So later on, he was tested for flu. So flu PCR was positive. This was actually influenza. So your reports may have a mention that candida may represent colonizers. So actually, it could be a salivary contamination which is showing candida in the smear. Now, what about blood cultures? We in the lab get a lot of coagulase negative staphylococci, like sir mentioned. Now it is renamed as SOSA, diphtheroids, bacillus. So do we need to report them, or we are not good enough? I don't feel we are good enough to, decide that in the lab. This could be a contaminant, just discard it, report it as no growth, may not be very safe. So does your report mention anything like gram-positive bacilli grown, isolated from how many bottles? Does it have any comments of raise an order for Malditov? Because routinely we use Vitek for automated ID. That is good enough to identify your staphylococci, may not be good enough to identify gram-positive bacilli. It will not say what diphtheroid it is. It will not identify, if you call it bacillus, you call it in the terms of the morphology. Sometimes we may not be very sure. So always look for the comment that requires any additional workup and fully work it up if you consider it clinically indicated. This was another patient where corns grew. MR SOSA grew only from 1 bottle. So most likely it was a skin flora contamination. Whereas this was a patient where on dialysis his right perm cath, 2 bottles grew gram-positive bacilli. Though I had reported as bacillus species, usually environmental contaminant, correlate clinically, this patient was worked up by sir, where he actually had coronary stents in place, and this necessitated the removal of the perm cath. So this information was actually very important. What about smear in a culture negative report? Sometimes your smear may say something, but the culture may be reported as no pathogen isolated, no growth. So this was a real scenario where the CSF sample actually grew GPB suggestive of diphtheroids, and the lab discarded the culture media in view of contamination. It was actually listeria. So listeria also resembles diphtheroids. So being aware of the patient profile is of utmost importance. So a good coordination with your lab will be very, very helpful. When should you get suspicious about the ID and susceptibility testing mentioned in the report? So this was a 51-year-old male patient. Blood cultures were sent by a cardiologist, had intermittent fever for 5 to 6 months. Enterococcus fecalis was reported in blood. It was susceptible to aztreonam and ceftriaxone. So this is where we got doubtful, because enterococcus in vitro, it may show susceptibility to cephalosporins, aminoglycosides, clindamycin, cotrimoxazole, but they are not effective clinically, should be reported as resistant, and they are intrinsically resistant to aztreonam, polymyxin, colistin, and L-adixic acid. Patients' blood cultures were repeated, and what we got to know, this was actually a case of mitral valve endocarditis caused by strep gallolyticus. So probably there wasn't a machine identification performed, because they resemble in a few culture characteristics to enterococcus. It was assumed it was enterococcus and it was reported. So it was actually ceftriaxone susceptible. The same was published by our then fellow Dr. Partha as a delayed diagnosis of infective endocarditis in the form of a case report. Another quick case, a 60-year-old male patient had neck pain, fever, leukocytosis, upper limb weakness, and this was a prevertebral abscess, and there was a blood culture report which we received from outside stating MRSA. There was no mention of oxacillin, no mention of cefoxitin screen. So the outside lab was kind enough to share the Vitek report with us, where I just want you to note that cefoxitin screen and oxacillin, these are the two things that you need in your report. Cefoxitin screen was positive, but oxacillin MIC was sensitive. So to identify a Staph aureus as MRSA, you require the cefoxitin disc diffusion, you need a cefoxitin and an oxacillin MIC. So Vitek has something known as an advanced expert system. So this is an automatic software tool. It interprets MICs. So what happens, say your broth is contaminated, it may change the interpretation. So this green color coding, this is yellow here. If it is green, it is consistent. If there is some change done by the machine, it turns yellow. So it's consistent with correction. If it is orange, then it is inconsistent. So you have to actually review all those results before releasing the report. So for this patient, for a confirmation, aspiration of the prevertebral abscess was subjected to JI biofire because he was already on vancomycin for quite a long, and it did not grow in cultures. It didn't show any resistance marker. So same was published by Dr. Tejas, currently is an ID consultant in Aurangabad, that this case report actually highlights the importance of identification of and susceptibility of Staph aureus. Another report here says MRSA, methicillin resistance is not detected. It says it's intermediate to amoxiclav, susceptible to cephalosporins. So overall, what I want to convey is that if it is MSSA, you need to remember that it will be susceptible to your amoxiclav and your cephalosporins. In the report, you need to look for cefoxitin screen. It should be negative. Your oxacillin MIC should be susceptible. If it is an MRSA, then your screen becomes positive, it is resistant, your oxacillin MIC is resistant. At least these things need to be looked for. It may also follow with a note saying that you need to exclude endocarditis, rule out any implanted prosthesis, and check for your follow-up negative cultures. Now, as we are talking on gram positives, let us finish strep pneumo also. So this was a CSF sample. By lumbar puncture, CSF was withdrawn, and he had a clinical profile of meningitis. Penicillin 0.25 was reported as resistant. So why do you need to know the breakpoints? Penicillin for meningitis less than 0.06 is sensitive. but less than 2 is sensitive when it is non-meningitis. So the same patient's blood cultures were sent to us because we knew that this patient had meningitis. We could report it as per the meningitis breakpoints. If not, say CSF culture wasn't performed, this would have gone as a penicillin susceptible isolate, which ideally is not. This was already mentioned in our panel in the morning. Sir made his comments. So in a spontaneous osteomyelitis in an adult patient, no surgery or intervention done, Acinetobacter in the report, that is colistin resistant. So here is something you should begin doubting, because polymyxins resistant usually occurs in gram positives, Proteus, Serratia, Morganella, Burkholderia, Salmonella, and percentage of colistin resistant in Acinetobacter as per the recent ICMR is less than 1%. And a community acquired spontaneous osteomyelitis, this was again discussed, Staph aureus, Salmonella, Pseudomalley should come to our minds. I've taken a slide from Camilla ma'am's recent presentation where no distribution criteria exist. MICs need to be performed. When is it a must? In cases of colistin for Enterobacterials or Acinetobacter, vancomycin and daptomycin for Staph aureus, penicillin and ampicillin for viridans group streptococci, particularly isolated from sterile sites like blood, bone and CSF. This is a report of Salmonella. You need to keep in mind that aminoglycosides and first and second generation cephalosporins, they may appear in vitro susceptible. Like the Vitek may give MICs of less than 1, etc. So it shouldn't be converted and interpreted as susceptible. You need to remember that these will not work for this particular isolate. What not to choose when you go through a report. So this was a urine culture report for complicated UTI, and the patient was given tigecycline because it was the only susceptible option in the report. So avoid use even when reported. You need to know certain specimen and site-based restrictions. In blood, already discussed, tigecycline doesn't achieve good serum concentrations. CSF, colistin, first, second generation cephalosporins. In lungs, daptomycin. In urine, macrolides, tigecycline, etc. There needs to be specific reporting, like Dr. Prayag also mentioned that tigecycline is a must for skin and soft tissue infections, nitrofurantoin in lower UTI, phosphomycin in lower UTI, particularly for E. coli and Enterococcus faecalis. Now, the gram-negative resistance was already discussed in the previous lecture. So, there are a group of beta-lactamases known as AMCs. What you need to remember is certain organisms, Citrobacter frundi, Enterobacter cloacae, Klebsiella aerogenes have moderate to high levels of AMC risk. So, they may initially test susceptible to your cephalosporins, but within a few days after initiation of therapy, they turn resistant. So it may follow with a comment saying that carbapenems are the preferred options, though your cephalosporins have been reported as resistant. Now moving on to molecular reports. A quick case, this was already discussed earlier. A 36-year-old male patient presented to our hospital with GTCS. He had a history of head injury, and MRI showed a subdural hematoma. HRCT showed nodules. He also had a history of fever for the last 15 to 20 days. Blood cultures were ordered. Blood culture flagged positive for GNBs. Patient was from the community, not exposed to any antibiotics. There was a suspicion of salmonella, but this couldn't explain the rest of the clinical features. To hasten the process of identification, a BCID was ordered. BCID turned out to be negative. So, before revealing this to you, I want to ask the audience, what could this be? So this patient was a diabetic, he was a chronic alcoholic, he hailed from Konkan region, he visited when there was heavy rains, he performed some agricultural activities, he was from the community, history of fever for 15 to 20 days. It was actually a seatbelt injury, a very minor injury. HRCT showing nodules, abscesses. So these are the off-panel organisms of BCID. Any guesses? I think I've already revealed it in my slides. So yeah, it was Burkholderia pseudomalley, and this is just to mention that off-panel organisms should be considered. Even a negative BCID report could actually be helpful, will help you pursue further. So this was indeed Burkholderia pseudomalley. And another post-transplant pediatric liver transplant patient, BCID was done, it showed Enterobacterials, but no organism, no resistance marker. So we need to keep in mind that if such a scenario happens, it could be Enterobacteriaceae, but it is not Enterobacter cloacae, not E. coli, not Klebsiella, not Serratia, not Proteus. So this was Citrobacter frundi. And Citrobacter frundi again is intrinsically resistant to amoxiclavin first, second generation cephalosporins because it is a strong AMC producer. Carbapenem is the preferred treatment option. This was a case 2 days back where we had a piloneedle abscess, incision and drainage was done, and it showed gram-positive bacilli. So we phenotypically reported it as Corynebacterium species and AST in process because for Corynebacterium species at least we can extrapolate from the Staphylococcus and give the MICs, and then we asked them to raise an order for mild DID. Mild DID came out to be as Actinomyces urogenitalis. So it is even known in the literature that Actinomyces species, when they are aerobic Actinomyces and they are growing on culture, they can resemble diphtheroid-like GPBs, and this could be mistaken as Corynebacterium species, which actually happened with us, and many of which are considered to be normal skin flora, for which we need to resort to techniques like MALDI. This is already discussed. Just to mention that the quality of sample is important. So this sputum, which would likely be a saliva, was subjected to LRTI and we got all these low bin copies, multiple bacteria. Testing and reporting of carbapenem resistance. A short case, a 55-year-old male patient, chronic liver disease, received many antibiotics earlier, developed bacteremia. So CR E. coli was reported, carba-R or expert carba was asked for. You can see it showed only OXA48. By this, we could avoid Astionam, which is again hepatotoxic, and only Cazavi alone could be given to this patient. So now we have a cheaper alternative of a lateral flow device showing the resistance genes, which is actually helpful. The same is published by Balaji sir from CMC, that it actually works well when you compare it with the PCR. They tested for more than 100 isolates. So how do you test for the synergy of Cazavi Astionam? CLSI mentions the broad disc illusion method. It is only mentioned for Enterobacterials and Stenotophomonas. Why is this synergy testing important? Again, based on the CMC studies, Astionam avibactam could be susceptible only in 72% of the E. coli population. About 99% of Klebsiellas are sensitive. I'll just show you two synergy reports. So this is a Klebsiella CRE when MIC strip for synergy is being asked for. The advantage, as already mentioned by the previous speakers, is we get to know the actual MIC. So Cas-Avi was 64 micrograms resistant, Astionam is resistant, and the E strip of Astionam avibactam is susceptible with an MIC of 0.38. So, though CLSI mentions BMD, we do not get the actual MIC, it's a laborious technique. So again, Balaji sir made a study to show that it has good essential and categorical agreement with your broad disc illusion. And a broad disc illusion, again, it just mentions whether it is not susceptible or susceptible. So this is synergy susceptible. Would like to conclude by saying that microscopy should be given consideration when you're interpreting all the results. Read the report thoroughly to identify what method of testing, any additional comments, anything missing. Always interpret in the clinical context. What is the site, host, the bug and the drug, and collaboration with microbiologists will definitely help you all. Thank you.
Thank you, Vitri, madam, for explaining very nicely. The first thing, as a clinician, all the reports should be, before putting the patient on higher antibiotics, we should always discuss the patient profile with the microbiologist. Accident happens if a patient is stable, patient eating in the ICU, and you are feeling the multiple resistant drug. So I think clinical profile of the patient and the report should be treated equally. The patient is very bad and the report is very negative. This very commonly happen. So discussion with the microbiologist is very important before starting the patient on higher antibiotics.
very lucid presentation regarding the interpretation of microbiology reports, Gitu. And you have equally highly pointed regarding the quality of specimens and the adequate amount of samples to be processed for microbiological reports. And again, as Sakre sir has just said, that communication between the microbiologists and the clinicians are very, very crucial for the interpretation of the correct microbiology reports. Are there any questions from the audience? We can definitely discuss them later on. Thank you, Gitu.
Thank you so much.
Thank you, Dr. Gitu. I request Dr. Deepti ma'am to felicitate Dr. Gitu with a token of love and appreciation.
If there was a reality show called Survivor, the ICU, Enterococcus would probably win the $1 million. It's hardy, it's adaptable, and incredibly patient. So clear the fog on the bug. Joining us is Dr. Parikshit Prayag. Please join me in welcoming Dr. Prayag.
So good morning once again. I'll be dealing now with enterococcal infections in the ICU. The last talk was about gram-negative. So let's switch gear and talk about enterococcal infections in the ICU. Especially those of you who are dealing with surgical patients, transplant recipients, especially liver transplants, I'm sure we'll be seeing a lot of resistant enterococci these days in the ICUs. So let's start with a study which shows the magnitude of the problem. So this is a 20-year-long study. And what it shows is that the incidence of VRE in India is increasing. So what was about 5% about 20 years back is now easily around 15 to 20% in many of the centers. Again, it will depend on the patient population. So for example, in our liver transplant recipients, we have a close to 30 to 35% incidence of VREs in our center. So in the first 3 or 4 minutes, let's look at the various options that we have before we go and see reports of these kind of patients with enterococcal infections and look at what therapeutic strategies we can have. So if you look at an enterococcal report, the first thing to look at would be the beta-lactam. So the first thing to look at would be something like an ampicillin. Now here, ampicillin resistance is mediated by penicillin binding protein mutation. So especially PBP5 is important there. So if you have a mutated PBP5, then it's going to be predictive of resistance to most beta-lactams. Of course, excluding the 5th generation cephalosporins like ceftaroline, but it's going to be predictive of resistance to your penicillins as well as carbapenems. So that's why escalation to carbapenems is not a strategy that we use for enterococci. Now, if you look at PBP4 mutations, they affect ampicillin less than they affect the carbapenems, which means that you could funnily get a situation. It's not funnily, but we are so used to thinking of carbapenems as higher antibiotics that you could get situations in which the ampicillin MICs are actually good, but the carbapenem MICs are high. And this, when this happens, you are smelling PBP4 mediated resistance. Less important for enterococci is beta-lactamase production. So while we looked at gram-negative infections, we talked about the various enzymes. And here, don't worry, I'm going to spare you the headache of enzymes because the enzymes are less important when it comes to enterococci. There is some low-level constitutive beta-lactamase production in these enterococci, and these beta-lactamases are similar to those which are produced in staph, but the magnitude of this problem is much lower. So that's why the normal isolates that you get in the lab, very rarely do you see clinically significant beta-lactamase production. So if you're dealing with high burden infections, then you could do tests like nitrocephin. We've been trying to get this for a long time, but still hasn't happened. You could get tests like the nitrocephin tests in our lab, that is. So you could get these kind of tests to look at high inoculum conditions which produce beta-lactamases, because there you might want to add an additional BLI with ampicillin. But most of the BLIs will work against this, so really you don't need to go to the higher BLIs for this kind of a picture. Enterococci, except the 5th generation cephalosporin, so ceftaroline, if you look at the 5th generation cephalosporin that's available in India, except the 5th generation cephalosporins are inherently resistant to enterococci. And you can see there PBP5 is an important PBP there, so it is inherently resistant to the cephalosporins. If you look at aminoglycosides, then you would never use aminoglycosides as monotherapy for enterococci. they are always used as a part of combination regimens for very severe infections or for infections like endocarditis, endovascular infections, and so on. So they are not to be used as monotherapy. So the lab will tell you something known as high level aminoglycoside resistance detected or not, which really means that can you use it as a part of combination regimen. So if you look at different aminoglycosides like gentamicin or streptomycin, you should read the report carefully and look at whether high level aminoglycoside resistance is present, which means that are the MICs in thousands, which means that you can't use them as a part of combination regimens. The next drug to look at is the vancomycin teicoplanin group. So if you look at vancomycin and teicoplanin, then these are two common ways by which vancomycin can become resistant. So what happens is that this DLR part is replaced by DLR-DLAC, and what happens there is that because of this the vancomycin can't bind and it loses its efficacy. So it could be a VAN-A mediated resistance or VAN-B, and now if you look at our PCR reports, then you will see VAN-A, VAN-B as a part of the menu card of these reports. So if you have VAN-A mediated resistance, then you will have high MICs for both vancomycin as well as teicoplanin. If you have VAN-B mediated resistance, then it is a little bit more forgiving when it comes to teicoplanin. But whether we can use teicoplanin in that kind of a setting is another question. I'll come to the answer of that. There are other VAN-A mediated resistances as well, and especially M and D are also quite problematic because there also you will see high MICs for teicoplanin. So in short, if you have a VAN-A mediated resistance, both vancomycin and teicoplanin will be resistant. If you have a VAN-B mediated resistance, in your culture report, you will see a situation in which I'll come to the therapeutics later on. You will see a situation in which it is vancomycin resistant but teicoplanin susceptible. Linezolid resistance is fairly rare in enterococci. So if you look at these kind of numbers, it is about 1 to 2% in a lot of studies. And then last but not the least is daptomycin, which has its own set of problems as far as culture reports are concerned. So if you look at daptomycin, then in 2019, daptomycin nomenclature was changed, and now we no longer call it as susceptible, we call it as susceptible dose dependent. So if the MIC is up to 4 for Fecium, then you call it as susceptible dose dependent, and 8 or higher you would call it as resistant. And this has a lot to do with the pharmacodynamic attainment of targets, which I'll come to later on. There are problems though with daptomycin MIC testing. So pharmacodynamics is one part of the reason why the nomenclature was changed. Just like polymyxins, one part of it was the fact that pharmacodynamic targets were difficult to achieve. But there are also problems with the testing method. So look at this study here, 40 isolates of Fecium were taken, and 15 isolates out of these had MICs interpreted as susceptible by some tests and non-susceptible by others. And if you look at this LIA-FSR mutation, so these are mutations, which affect membrane binding antibiotics like daptomycin. So if you look at these kind of mutations, then neither of these two tests could really properly correlate with those isolates which were harboring these kind of mutations, which means that there are a lot of isolates which harbored these kind of mutations yet had falsely low MICs on both these tests. So that's why there are issues with daptomycin testing, and there are issues also with achieving pharmacodynamic targets, and that's why the nomenclature now says susceptible dose dependent rather than just calling it susceptible. Another fun fact is that even if the lab gives TMP SMX as susceptible, it's not a drug to be used for enterococci because it can utilize the human folate. So even if it is in vitro sensitive, it's not a drug to be included for the therapeutic purposes. So with this background on resistance, let's look at some of these isolates or some of these cases. So this is a 43-year-old gentleman with refractory primary CNS lymphoma, has a line-related enterococcal infection. So this is a good report here. It's fecalis, it is ampicillin sensitive, it's also sensitive to vancomycin, teicoplanin, daptomycin, linezolid, and so on. Now, if you look at therapy for this, so for most non-severe cases, you would still use ampicillin as the therapeutic regimen there. When do you really go for screening? So with fecalis, endocarditis is described more than with Fecium. So there is this scoring system which you can utilize. It says the duration of symptoms, embolization. So basically, looking at the chances of endocarditis and then deciding. If you do have endocarditis with Enterococcus fecalis, for this type of an isolate, you would essentially have two options there, either to combine an ampicillin with an aminoglycoside or to combine an ampicillin with ceftriaxone because it's fecalis. But there, bottom of the report says high level aminoglycoside resistance detected. And that's why in this type of an isolate, you could combine ampicillin with ceftriaxone. Ceftriaxone on its own does not act against Enterococcus, but you could use it as a part of combination regimen. And this is the study which looked at, so this is, remember, a regimen for fecalis, not for fiction. So this study looked into this. So they found that both those regimens, ampicillin plus ceftriaxone or ampicillin plus gentamicin, were equally effective, and as expected, ampicillin plus gentamicin was a more toxic regimen. So if you have a fecalis in which a high level aminoglycoside resistance fails, and if you're looking at combination therapy for ampicillin sensitive fecalis, then ampicillin plus ceftriaxone can be a combination regimen. But you don't have that luxury in Fecium, because you also have a lot of ampicillin resistance, but this is not a regimen that is recommended for Fecium infections. Now look at, so we started out with a relatively forgiving report. Now the reports get murkier as we go along. Look at this patient. A 30-year-old male with AML who is post his induction chemotherapy now had, this was a patient that we dealt with about 3 months back, has Ephesium bacteremia and perianal abscess with Ephesium. So now look at this report here. It is ampicillin resistant. Even if you add a BLI to it, it is still resistant. So it shows that beta-lactamase production is not the main problem here. And all your beta-lactams there are resistant on this report. So you're left to choose between vancomycin, teicoplanin, linezolid and daptomycin. And the daptomycin MIC there is 2. So it says susceptible, dose dependent. So let's look at this now. So your backbone drugs in this type of a report would be one out of the 2, teicoplanin and vancomycin. So this study looked at the differences in outcomes between teicoplanin and vancomycin for VSE, vancomycin susceptible Ephesium bacteremia. And not much difference there. In fact, slightly better numbers there with teicoplanin. You will see that the mortality rates were slightly lower with teicoplanin. So teicoplanin is an acceptable alternative to, you will not see a lot of data on this because in a lot of the Western literature, there is no teicoplanin because of the fact that it's not there in the US. So if you look at vancomycin susceptible enterococcus, then they look pretty comparable. Again, it really depends on how well you are using your drug, how well you are dosing it. We find that often teicoplanin is underdosed. So for example, for the last almost 25 odd patients in whom we've done teicoplanin levels, at least 8 to 10 of them have had really subtherapeutic teicoplanin levels. If you just stick to the conventional dose of 6 milligrams per kg BD for the first 3 doses and then OD from the next dose. What about daptomycin? So this was an interesting study. This looked at this is a retrospective study which looked at vancomycin. It should be not VRE, it should be vancomycin susceptible bacteremia. And when there was vancomycin susceptible bacteremia, even if you gave a good dose of daptomycin, daptomycin didn't fare as well. So if you have vancomycin susceptible enterococcus, you would usually stick to one out of vancomycin or teicoplanin. Of course, if you had endocarditis or a really bad infection there, then you would look at whether gentamicin can be combined based on whether high-level aminoglycoside resistance is detected. Again, vanco plus ceftriaxone is not a regimen that we use for our enterococcal infections. Now look at this Ephesium in blood cultures. It is ampicillin resistant. HLA-R is detected. It is vancomycin resistant but teicoplanin susceptible. And daptomycin MIC is 4, which is susceptible dose dependent, and linezolid is susceptible. So now there is a discrepancy between vancomycin and teicoplanin. So here you're suspecting something like a VAN B mediated resistance because teicoplanin is susceptible but vancomycin is resistant. Now can you use teicoplanin? That's for the most part, yes, you can use teicoplanin, but you have to be careful about the resistance developing while on teicoplanin therapy. So look at this study here. There were 18 patients with this VAN B phenotype and they were treated with teicoplanin. Resistance on therapy emerged in about 4 out of these 18 patients. So what happens there is that there is this VAN RS system. So S senses the antibiotic and R actually produces the changes which are required for resistance to this antibiotic. So this sensing system that could undergo mutations, and then you could have a situation in which on therapy, teicoplanin resistance is developing. So if you have a vancomycin resistant enterococcus bacteremia, which is teicoplanin susceptible and has the VAN B phenotype, you would really be advised to dose teicoplanin properly, make sure that you're really monitoring the patient properly and looking out for this phenomenon of development of resistance on teicoplanin. Look at this patient here, 54-year-old male, day 10 post a living donor liver transplant with Ephesium bacteremia. Now ampicillin is resistant, so is vancomycin, so is teicoplanin. So we are probably dealing with the VAN A phenotype here. Both vancomycin and teicoplanin are resistant. So your choices here are linezolid is sensitive and daptomycin is susceptible dose dependent at an MIC of 2. So not terrible. So, you know, as long as it's up to 2, it's not a terrible MIC. 3 and 4, we start to get worried about it, and above 4, of course, is a very worrisome situation. So now this is a difficult question to answer, that in terms of literature, that is, that which one would you pick out of daptomycin and linezolid? The answer really is, how well do you utilize daptomycin when you are treating this type of an enterococcal infection? So look at these 3 studies here, large studies, you know, systematic reviews and meta-analysis, which were published about 10 years back. So the first study, mortality was higher in patients receiving daptomycin. Second study, also patients treated with daptomycin had significantly higher mortality. And the third study also, there was a trend towards increased survival with linezolid. So the older literature, if you see about 10-12 years back, looked better for linezolid as against daptomycin in this type of a situation. But there were large limitations with these type of meta-analysis. One is that, you know, there was no dosing regimen which was standardized. So you talk about high dose daptomycin doing significantly better. So there are very few of these studies really give accurate information about because these are meta-analysis, so there is a lot of heterogeneity. There is not a lot of standardization with regimens and so on. So there are several biases, several problems with these type of studies. In the last few years, what has become clearer is that it really depends on how well you utilize daptomycin in this kind of a setting here. So look at this study there. Daptomycin performed better than linezolid. And I think the 2018 study is really a very good study, because they had 108 patients who were prospectively enrolled for a VRE bacteremia, and high dose daptomycin, more than 9 milligrams per kg, and linezolid were associated with more rapid bacterial clearance. So that's really the key, how well you're utilizing daptomycin, and the answer lies in this. So if you look at the AUC MICs of daptomycin, if you really want to attain your target, if you have MICs which are up to 0.5 or even 1, you're okay. You know, if you give 6, 8, 10 or 12, all these 4 type of regimens, you have a high chance of attaining your pharmacodynamic target. Usually you would want to have a minimum of 25 to 30 as your AUC MIC. The problem starts when you start going above 1. So look at the MIC of 2, your chances of achieving the pharmacodynamic target are really very low with a regimen of 6 milligrams per kg. They are also not more than 60% for a regimen of 8 milligrams per kg. And so really you would have to go to regimens like 10 to 12 milligrams per kg. And if you go towards 3 or 4, then really with 6 or 8 milligrams per kg, you have very miserable chances of attaining your pharmacodynamic target. So that's why dosing daptomycin is an important part here. Now let's see these 2 situations. Here you have linezolid resistance. You have perhaps the VAN A phenotype, because vancomycin and teicoplanin are both resistant. So you are preparing yourself to use daptomycin, and there is this one patient who has a daptomycin MIC of 2 versus this one patient who has a daptomycin MIC of 4. The rest of the susceptibility reports are similar. So what do you do in these kind of situations? So like we said, you know, this patient who has, so for both you would utilize high doses of daptomycin, because like I said, the moment you start going above 1, your chances with 6 to 8 milligrams per kg really start reducing drastically. So there is no doubt that I'm going to be using 10 to 12 milligrams per kg here. The question is that am I going to be using daptomycin monotherapy or combination therapy? So look at this high dose daptomycin therapy failed in neutropenic patients. Jose Munita, who was my senior in residency, published this. So you know, this is a patient in whom there was daptomycin failure at an MIC of 3. And Bhavar Chukla, who was also in our batch, so he published this showing that, you know, if you have enterococcus MICs of 3 to 4, then you have higher chances of failure even with high dose daptomycin regimen. So when will I go for daptomycin combinations? If the MIC is above 2, definitely I'll go for high dose, combination regimens. But there are certain situations like endocarditis or endovascular infections, really severe enterococcal infections, inadequate source control, transplant patients, prior daptomycin usage, neutropenic patients. So these are the kind of patients in whom you would be well advised to use combination therapy. Let's say I have an MIC of daptomycin of 2, otherwise stable patient, line-related enterococcus, then I would be happy, you know, giving high doses of daptomycin and monitoring the patient. Like I said, both require high doses. The question is, when are you using combination? And last but not the least, which is the combination regimen that you would recommend? So there are several options there. So there are studies which have looked into this, combining daptomycin with beta-lactams. So look at this, daptomycin when combined with ceftaroline led to a significant reduction in the MICs. Ampicillin, again, almost regardless of its MICs, would also be a good drug to combine. Tigecycline, again, even though we think of it as a drug that doesn't really give you good levels in the blood, there are case reports of even endocarditis patients being cured with a daptomycin tigecycline regimen. And fosfomycin. So there is this study in which they looked at fosfomycin MICs, and MICs of up to 64 showed that daptomycin plus fosfomycin was actually a good regimen. So these are usually your 4 or 5 frontline choices to combine with daptomycin when you have this type of a situation. So high daptomycin MICs, no other options, and a sick patient, you definitely, these are the options that you would have. Just the last couple of minutes, a recent living donor liver transplant, he developed a fever, blood cultures grew faecium resistant to vancomycin, teicoplanin, ampicillin, tigecycline, and daptomycin, sensitive to linezolid. Platelet count was 88,000. This is early post-transplant. Was started on linezolid. Trough levels were obtained on day 4, and the trough levels came out to be around 14. So this is one of the places where you could utilize linezolid TDM. A lot of the linezolid TDM literature actually looks into minimizing toxicity, and levels less than 7 are associated with lesser myelotoxicity. So here it's an important drug that I want to conserve in this type of a patient. I don't want to let go of my linezolid. So these are recommendations, based on your therapeutic drug monitoring or the results of your TDM, you could adjust linezolid doses. And last but not the least, sometimes you see these kind of patients, 34-year-old male, this was last month, status post, again a living donor liver transplant. You can see from these cases how much of a problem we have with VRAs in our liver transplant setting. Faecium in blood cultures, cholangitic abscesses, this was early in the post-transplant period, lots of other complications that I won't go into the details of for the lack of time. But here you have an ampicillin resistant, vancomycin resistant, tico, dapto, linezolid, everything is resistant. So again, what do you do in this type of a patient? This is early post-liver transplant. Tigecycline is again with its hepatotoxicity, not something that the transplant teams would be absolutely comfortable using. But in these type of situations, the first thing is that you look at the MICs of all these drugs. So looking at the MICs of dapto, so let's say dapto was 8 versus a dapto of 256. There's a world of a difference there. So look at the daptomycin MICs, look at the MICs of other drugs, ask your lab to give you other MICs. So for example, dalbavancin. Some of these situations we've had a dalbavancin MIC which has been on the lower side. Recently we had a patient who was resistant to dapto, tico, vancomycin, and dalba MIC was 0.25. So you could ask your lab to test dalbavancin, you could ask your lab to test tigecycline, you could ask your lab to give you the accurate MICs, and then come up with it. So let's say up to 4 or 8, you could use something like a high dose of daptomycin with another agent like a ceftaroline or an ampicillin or a tigecycline. Look at fosfomycin MICs as well, not for the fact that we are going to be using it as monotherapy, but to see, how much of a benefit we'll get by using combination regimen. So these kind of patients are the patients in whom you will have to really go very thoroughly through the culture report. So I'll summarize by saying that ampicillin resistance usually predicts resistance to penicillins and carbapenems for the most part. Enterococci are inherently resistant to cephalosporins, except the 5th generation cephalosporins such as ceftaroline. VAN A phenotype usually is both tico and vanco resistant. VAN B can spare teicoplanin, but whether to use teicoplanin, you really need to monitor your patient carefully, use good doses, look out for development of resistance while on teicoplanin. Again, not very common, but something to be kept in mind. Daptomycin should be carefully dosed. Throughout the talk, I showed you various studies in which, the dapto dosing really determined the outcomes of these patients. So as soon as you start going above MICs of 0.5 or 1, you would have to start thinking of high doses of daptomycin. And combination therapy with daptomycin, simple rule, it's not as simple, but if I can summarize it in one sentence, MICs of 3 or 4 or sick patients. These are the kind of patients in whom I would go for daptomycin combinations. And which drugs as combinations? So you have options in terms of ceftaroline, ampicillin, tigecycline, fosfomycin. These would be your front runners. Linezolid therapeutic drug monitoring. So dapto TDM is not as established for preventing the toxicity, but linezolid TDM, there is a fair amount of robust literature. Now we've started doing linezolid TDMs regularly, especially in these type of situations. So linezolid TDM may be useful from a toxicity standpoint. So I think I'll stop here again. Thank you for inviting me. If there are any questions, I'll be happy to take.
Thank you, sir. Very nice presentation. Many a times we encounter enterococcus, and that is actually a troublemaker in the ICU. So very well explained how to tackle enterococcus infection. Sir, one question to you. Many a times in a polymicrobial culture, enterococcus is sometimes a colonizer rather than a true pathogen. So what clinical and microbiological cues do you take to treat the pathogen aggressively versus to just wait and watch?
The clues are more clinical. It's the setting in which, the infection has developed, the setting in which the cultures have been sent. So again, if it's an intra-abdominal infection and this is a patient who has had previous surgeries, instrumentation, and you are likely to deal with a polymicrobial infection, the enterococcus would be significant. But enterococcus from a lot of sites, including, pus swabs that have been sent, drain cultures that have been sent, respiratory samples that have been sent, all these are not very significant sites or significant, situations in which enterococcus should be treated. So really, whether to treat enterococcus or not, this decision has to be clinical. And just related to your question, even empiric enterococcal coverage is also a matter of debate. So not all intra-abdominal infections would really merit empiric enterococcal coverage. It again really, or empiric VRE coverage. It really depends on, the history of the patient, the presentation, what kind of antibiotics has been exposed to, instrumentation, the site of infection in the GI tract and so on. So these are the things that you would look into, while deciding empiric enterococcal coverage. So not every enterococcus in every culture is clinically significant.
Thank you, sir. Any questions from the audience?
Thank you.
Thank you so much, sir. One comment from lab side that we have just discussed VRE, which is like rising day by day. A small comment is that the lab should also practice infection control practices while reporting VRE, because contamination of normal saline is very common into the lab, and the routine saline sterility check is very important, especially when we are observing if there are many MRSAs, VRE is getting isolated from the lab, then lab should also do sterility check very often. This is very important rather than announcing pseudo outbreaks in the ICU. Thank you, sir.
Thank you.
Thank you, Dr. Parikshit. Now I think we will leave this hall today. Our brain is more sensitive even for VRE. Thank you, sir. Now I request Dr. Dilip Shivsagar, sir, to felicitate our eminent chairperson, Dr. Madhvi, Dr. Ajay Sakre, sir, and Dr. Utkarsh.
In infectious disease, the history is the hint, the labs are the clues, but the diagnosis is a masterpiece. Please welcome Dr. Rajiv Soman himself, who is going to conduct an ID quiz for us. Dr. Soman is going to challenge our intuition, sharpen our logic, and perhaps humble us just a little bit. So sharpen your wits and get ready with your diagnostic hats on. The podium is yours, Dr. Soman.
Okay, you're all welcome to agree, disagree, and all that. This is all a little fun sort of thing, but I hopefully can convey some messages to you. So I've also subtitled it as ID rounds in the ICU. As ID physicians, we have this habit of poking our nose into everybody else's business, and that is not to anybody's advantage. You can guess who is the guy who's been turned red. Okay, so this is a 45-year-old lady. She was treated elsewhere for dyspnea, fever, chest pain, high count, high PCT, treated with piptazo, but there was worsening status, and so was changed to colistin next day. So there was no improvement. This was the CT appearance. The chest physician suspected that this could be BOOP and started on steroids. Further worsening occurred, so then they did a PET scan, and it's here for you to review. So with this, they referred for an ID opinion. So on inquiry, the patient had a left tooth abscess 15 days before and was treated with Cipro. Also, tenderness on the left side of the neck was found, and you can see the splenic images. And so what do you think is most likely here? Is it Lemierre syndrome? Is it aspergillosis, actinomycosis, infective endocarditis? Any quick thoughts? Say it out, no problem. Lemierre's, what about you? Lemierre's. No one wants any other diagnosis. Actinomycosis, another thought. Okay. No takers for endocarditis. They don't look like emboli. Anyway, that's the right answer. So aspergillus lesions, yes, you can also see these peripheral, triangular pleural based lesions, but usually that would be in an immunocompromised patient and can't really explain why there is neck tenderness. So you have to explain each and everything that is going on there. Actino can definitely follow a dental infection, but it produces a localized jaw infection which is indolent. It is woody hard. You can't explain all the other features there. Remember here, this tooth problem was treated with ciprofloxacin. That's not really a good drug for the oral anaerobic flora. And when the patient worsened, what did they do? Piptazo was probably the right answer, but right drug to use, but worsened in one day, so change to colistin. So again, this is another thing where colistin is not going to work. Okay, so this is the lateral parapharyngeal space syndrome or Lemierre syndrome, and it's all mainly due to this organism called Fusobacterium necrophorum. Okay, let's move on to this case. This is a 55-year-old male. He is a driver by occupation. He has been driving all over Maharashtra. On 27/7/23, lower limb weakness was noticed, slurred speech and disorientation occurred. So this was diagnosed as stroke by the neurophysician. As you can see, there are some lesions seen there, and started on antiplatelet agents. But thankfully, somebody noticed that he also had fever, and so was started with ceftriaxone and teicoplanin, again favorite drugs with the neurophysicians. No response, hence referred for an ID opinion. Now the history says that the illness had started with myalgia, and this kind of a vasculitic rash was noticed. You can see it in many places, or on the trunk, on the palms of the hands, as well as you can see something on the ear over here. Small spot there. He also had spatial disorientation, difficulty in recognizing even familiar faces. And as you see, I think there's some problem. Okay. And if you review the PET scan, the MRI, you find lesions in different locations on both sides and in different circulations. Okay, so you have something in the temporal on the right side, you have something in the brainstem on this side. Okay, so both posterior circulation as well as middle cerebral, everything is getting involved, telling you that they are in different vascular territories. They are less likely to be atherosclerotic related infarcts. In short, it is more likely to be vasculitic infarcts. The patient had been started on ceftriaxone and teicoplanin, but without any response. So now what do you think is the most likely cause? A small gram-negative bacillus, a corkscrew shaped organism. Remember, if the driver is driving all over and so on, a gram-negative diplococcus or a virus. Yes, no eye contact with me. Make some guesses, you are 25% right. Diplococcus. GNB, what? Sorry? Syphilis, so corkscrew shaped organism. Okay. So you can have leptospira as well as syphilis. Now they can give you some of these features, but all are not fitting in very well. Gonococcal arthritis and all that also can be thought of, but that is also not fitting into very well. Virus such as HIV with a seroconversion illness can give you pharyngitis, lymph nodes, rash, and so on. But the thing which best fits is rickettsia. His WBC 12,000, platelets and all that transaminases. And if you see the wild Felix reaction, it is only 1 in 20. So ideally you need a PCR for the spotted fever group. See, when you see rash on the palms and soles, think of at least 3 important things: rickettsia, drug induced, and syphilis. Okay. So this test was done 10 to 12 days later, and the wild Felix has now become strongly positive, with OX19 and 2 being strongly positive. So again telling you that this is a spotted fever group of rickettsia. So although we don't have, I mean now PCR is available, or pan rickettsial PCR is also available. I have noticed that in Pune, in fact, scrub typhus is less common than spotted fever. So Ashwini, you must have seen lots of scrub typhus in Chennai, but here it is more, in Nagpur also, spotted fever is more common, correct? Okay. Now this patient is a diabetic, hypertensive, he has a hiatus hernia and a seizure disorder. On 14/7/25, he had hematemesis. 2 days later, the patient developed severe back pain, dyspnea, and was admitted to the ICU. A chest CT was also done, and empyema was found, and this is the empyema fluid which has been drained. Cells 15,000, 96% neutrophils, LDH high, much higher than the serum, of course. Expert MTB ultra and JI panel and culture of that fluid was done. He was as usual on meropenem teicoplanin, and with this the patient was referred for an ID opinion. So this is the JI panel, JI panel which has been used on the pleural fluid. And what do we find there? So we are finding Feingoldea, Parvi, no, it's not Feingoldea, Parvimonas, Enterococcus faecium, Strep species, Haemophilus influenzae, Candida and Candida albicans. Okay, so this is what has been found there. With this, the patient was referred to fine-tune antibiotics. So what do you think? How do you analyze this case? This must be post-pneumonic empyema, or it might be tuberculous empyema, but expert was negative, or it could be A or B, or it could be none of them. So what are your thoughts?
Post-pneumonic.
So audience, if not the expert panel seated on the front row. Correct. Yes. Post-pneumonic. Everyone likes that? Okay. Let's see. See, post-pneumonic empyema, pneumonic will generally not be polymicrobial like this. Okay, you will get one organism there. So this is somewhat against it. Underlying TB, again, pleural fluid characteristics are completely against it. You know, it's a proper this thing. So none of them. So what you are finding here is actually salivary organism. Okay, all that Parvimonas, Streptococcus, what else was there? All of, yeah. So all of them are salivary organisms. So can this have been because of a esophageal perforation? Now, two important reasons. One can be a tumor, but that would be a long-standing thing. The patient will have cachexia and all these things, swallowing difficulties for a long time, which he did not have. Hence, an acute esophageal perforation with mediastinitis can actually explain these findings better. Hence, we need to revisit the history and also review the CT scan. So there was retching. See, we were told originally only about hematemesis, but remember, patient had a hiatus hernia also, and there was retching, which was an important part of the history, which was not there in the ICU record. All this had preceded the onset of these symptoms, and on review of the CT scan by the infectious disease physician, what is found? Pneumomediastinum. Okay, so this was not reported by the radiologist. So all this led to the diagnosis of a esophageal perforation giving you mediastinitis and empyema. So thoracotomy was done. Mortality rises to more than 60% with delay in surgery. You can see that large perforation there. So the messages is from the case are clinicians have often been lampooned for having lost all clinical acumen and being over reliant only on investigations. But careful attention to history and radiological findings is essential. The type of flora that is detected by high-tech tests can point to the source and the actual scenario, although this is by a circuitous route. You know, this history of retching and all that should have been the clue to the whole picture rather than only finding salivary organisms. So as a ID physician or as any physician, this sort of combination of organisms must tell us that they are all coming from saliva. Delay leading to less satisfactory treatment and outcomes is bound to happen because of that. Okay, we have a 50-year-old male patient with fever, dyspnea, received antibiotics on and off. The old case at Hinduja, and you can see here these are painful lesions on the soles as well as palms. Referred for an ID opinion. End diastolic murmur was found, wide pulse pressure, suspected endocarditis, multiple blood cultures positive, rapidly deteriorating congestive heart failure. No secret that this is endocarditis, and this is Staph aureus, and as you can see, cefoxitin screen is negative. It is a MSSA. So the patient was started on flucloxacillin without gentamicin. So sometimes there is an option of giving both of these drugs for first 2 weeks, but this was given without gentamicin. He underwent an emergency AVR, aortic valve replacement. The valve culture also showed MSSA. The patient was planned to continue flucloxacillin for 6 weeks. Further, he was clinically stable. There was good urine output, and this is the histology of the valve, which shows you plenty of gram-positive colonies. Clinically stable, good urine output, but rapidly worsening azotemia. Now, what do you think is the most likely reason for this? Could it be renal embolism, rapidly worsening azotemia, or immune complex glomerular disease due to the endocarditis, or drug-related nephritis, or none of the above? Immune complex. See, the problem with immune complex and embolization is that the output will also drop. So this is something, output is not dropping, azotemia is worsening. So where is the site of lesion? It is in the interstitium. Correct. Yes. So it is flucloxacillin related interstitial nephritis. Okay, that is something which we need to keep in mind, and this is eosinophils in the urine are in plenty, which gives you the diagnosis. Okay, for 45-year-old past history of pulmonary TB, there are chronic cavities. There were chronic cavities with recurrent hemoptysis. So the patient underwent coiling. As you can see, this is the coiling to occlude the branches of the bronchial arteries, I think, or whatever. But hemoptysis continued. Have a good look at the axial film of his scan also. So left upper lobectomy was done for this procedure, and that showed growth of this organism. So septate, branching, fungal hyphae, something is globose and radiating phyllites and all that. I can't read it, but look at all this. Finally, bottom line is Aspergillus niger has been isolated from the lung tissue. Referred for ID opinion. So ask for a histopathology review, and this is the histopathology. This is, I think, is which stain is this? HNE, I think, and this is the GMS stain. So look at the histopathology, and what are your thoughts? Treat with amphotericin B, or voriconazole, or posaconazole, or treat with an echinocandin, or need coffee or lunch or whatever. बोलो यार. See, most important histopathology में क्यों बता रहा हूँ? I know they look good pictures, but there is some reason. There is no tissue invasion. See, there is no fungus inside the tissue. This black thing that you are seeing here, or this light pink, is the fungus, and this is the tissue. And इसमें nothing is there. There is no tissue invasion. That's why the clue is here. Look at this. This is a fungal ball with a cavity. Now, recurrent hemoptysis is the presentation. So actually you don't need any treatment. Although this fungus looks black and ghastly, doesn't mean that we should treat it, because there is no tissue invasion. That lobe is also removed. Okay. Also remember, this organism is Aspergillus niger. It is not even fumigators, flavors and all of them. Areas. So this is often a sapro. And the reason is that I think the spores are big. That's why they get deposited in the nose only. They don't go into the lungs. So that is one more clue that this is only a saprobic growth. So it is just a fungal ball without tissue invasion. Does not invade lung tissue, which was confirmed by not finding hyphae and oxalate crystals that often is seen along with Aspergillus niger. It's known to be a secondary invader only in a year. So the focus of ID rounds in the ICU is try and find out if it is a colonization. Okay, what is the business of the ID physician? Most of the time to stop the treatment, rather than come out with, because all of you guys know all the drugs. So there is nothing more which I can come and give sometimes, except rarely when enterococcus gives you that much trouble, then you come and add one or two more drugs to daptomycin. But otherwise, by and large, it is not. So we want to see to it that we are not treating a colonizer. We are not treating a non-infectious disease or a self-limited infection. Also ensure that a correct specimen is required. And what is a correct specimen was discussed in the previous lecture. And also try and interpret the microbiology reports. Remember, they are not at all easy to interpret. And also read what is written below the report. Comments by the microbiologist. Okay. Then frame or sort of frame your treatment based on the syndrome. Also the guidelines, but very importantly also local epidemiology. Okay, so just looking at IDSA or any other society guidance is not going to be that helpful. Then source control, PKPD indices, interactions, adverse drug reactions, and de-escalation and termination. I rarely have any opportunity to escalate treatment. It is almost always to de-escalate or terminate. And then all these other things, surveillance, antimicrobial stewardship, infection control, and this is something in our favor, Nitin and Ashwini, and of course Parikshit. Involvement of the ID team improved the appropriateness of antibiotics and made a difference to survival. Okay, at least some study has shown that we deserve to be around in the ICU, and sometimes we do make a decisive change in the treatment and management of the patient. So with that, I'll stop here. Thanks.
Thank you, Dr. Soman sir. For
You always keep us reminding again and again that beyond every patient, beyond every culture report and every monitor, there is a keen physician and a curious mind of a ID consultant. You have given us more incredible clinical poll. Ladies and gentlemen, please give a big round of applause for Dr. Rajiv Soman sir.
We have now reached the segment of the day where textbooks are closed and the real world clinical war room begins. To navigate the minefield of multi-drug resistant infections, we have a panel that can only be described as the ID Dream Team. Guiding the ship as our moderators are Dr. Ashwini Taide and Dr. Nitin Shinde. And to provide the heavy-duty expertise, we are joined by Dr. Rajiv Soman, Dr. Parikshit Prayag, and Dr. Geetu Jo. I did say कि Soman sir was going to teach us a little bit of humility.
Thank you, Deepak sir. And we have, I think I have 2 cases and Ashwini also has 2 cases. So we'll try to finish. I think all of you, many of you must have heard this song, same but different. This is a famous Thai or Cambodian song. It's a very famous idiom, a very famous movie on this also. So if you see, you can see 2 types of vial. So on one side, the blue colored you can see distilled water vial, and there's a similar same vial on the other side. What it is, we will just try to tell you through this case. So this is 46-year-old female patient who had CKD and was maintenance dialysis, and she received inadvertent administration of Bacillus clausii, the vial of enterogermina, post suspension after a routine session of hemodiafiltration. And after 6 hours, she had a very high-grade fever, and labs were done, like CRP was 25 and WBC is 18,950, and her blood cultures instantly grew Bacillus clausii within 24 hours. So she had a history of renal transplant in Hinduja Hospital 10 years ago, had a Buck-Carey syndrome with IVC stent, and pulmonary tuberculosis just in remission, and now she was actually getting scheduling for a second renal transplant in upcoming month. And during all these things, this disaster happened. However, she became asymptomatic after 72 hours, and there was no subsequent spikes, and the counts were normal, and the CRP was falling. However, a completely asymptomatic patient continued to grow Bacillus clausii with sequential cultures, and however the growth was getting delayed. So initially 24 hours, then after 48 hours, then after 72 hours. So but cultures were never negative, and she was on thrice a week hemodiafiltration. So vancomycin was administered post hemodiafiltration with pre-dialysis monitoring of vanc levels. So the question here came to any treating team's mind is, how do you choose antimicrobial therapy in this type of situation where AST is uncertain or you cannot really predict AST routinely, like this bacterium is Bacillus clausii. So how do you decide therapies based on this?
The AST for Bacillus can very well be done. Only we do not get a speciation. We can very well identify it morphologically. You have to put up the gram-positive card and extrapolate it using Staphylococcus breakpoints. That's mentioned in CLSI.
Correct. That's what we have done.
Yeah.
But sometimes in a lot of other setups, people will really get confused if they get this type of pathogen. So, okay. So this bacilli was, we've done the same thing, and it is quite sensitive: ciprofloxacin, meropenem, vancomycin, doxycycline. This is sensitive lot of antibiotics. So we continue her on vancomycin after hemodiafiltration, and these are the trough levels we monitored, because this is a unique situation where you have a patient who's actually a sick profile, have no symptoms, but continuously having bacteremia. So these are the trough levels we monitored. So, but you are still at the point where you persistent culture positive, you are giving right therapy, and you have such a patient with a lot of morbidity. So, what do you do? What is the next step? So, what can be the next possible step we can do with this patient?
Nitin, can you go back to the previous slide of vancomycin trough levels? So the blue graph there is the day, right? So that's
Yeah, it's the day.
So that has gone on till day 42 or 51.
I didn't get you.
Day.
Yeah, it's a day, day 2, day 9, 14. So these are the days where trough levels were done.
But this has been going on for almost 2 months now.
Yes. I'll continue the story.
Achha.
Vascular hardware in place.
There was no hardware.
Dialysis is going on, no?
Fistula.
With bacillus, I would also probably get an eye examination done, look at things like endophthalmitis, endocarditis, also get, this is a dialysis patient, but you would also get peak levels. Just going on the troughs, although most of the troughs are on the higher side. So main concern with troughs really is toxicity. And even with 15 to 20 is associated with more nephrotoxicity rather than underdosing. But this is a patient in whom, I would really like, what were the MICs? I would like to get the accurate AUCs. Usually I would get both trough and peak levels, look at foci of dissemination. So maybe think of an echo, eye examination, all these kind of things, and also look at the MICs.
Is this measuring trough level is really correct method of predicting the vancomycin levels?
Yeah, so now they have moved. So if you look at the 2009 guidelines versus the 2020, and a lot of societies came together to do that. So SIDP, which is the Society of Infectious Disease Pharmacists, and IDSA, and all those societies came together and gave and sort of compiled this. So 2009, clearly the focus was just on trough levels. But then there is a lot of literature later on that trough levels actually can overestimate the AUCs. So what you really want to know is the AUC MIC ratio there, for which using both the trough and the peak levels, and then using Bayesian models. Even something like Sanford has simple calculators wherein they'll tell you that, what time was the dose given, what was the trough, what was the peak, and then compile the AUCs and then also suggest dosing recommendations. So that is what I do in my clinical practice.
Okay. So you're doing trough, or you're doing
See, as I understand, this Bayesian analysis and having recourse to all that peak and trough and AUC basically is to have an efficacy without toxicity. But here we are battling with the problem of lack of efficacy. So if you have these troughs, they seem to be more than adequate.
Right. So that's what I said.
So
Here
that
it
is
less relevant.
not relevant in this situation. So in fact, you could, what it means is you could do with even lower troughs.
Okay.
But still it is baffling, like why is it going on for such a long time?
Yes. So, but when we saw the literature, there are 17 cases reported in the literature, and most of the cases the same thing has happened for a long time. So this bacteremia went on for 90 days, 80 days, and same situation has happened. So, and this is basically a CKD patient on is mistaken as a distilled water boy. So the problem here is the patient on dialysis.
So many vials of that enterogermina doing there.
Because it was prescribed to the patient's relative, and the patient relative put it just adjacent to distilled water, and the nurse mistook it. So there are a couple of options whether to, continue just going on, so continue to say antimicrobial to double coverage or triple coverage, or just leave it, continue to give vancomycin and wait for the clearance of the bacteria, or cycle the antimicrobials. So apart from the vancomycin, we started giving other antibiotics, because patient did not want to give intravenous antibiotic every day. So after 3 weeks of antibiotic therapy and persistent positive cultures, we did a PET CT and we did all eye surveillance and other surveillance to see if there's any occult source. And there was no occult source, and patient wanted to go home, did not want to take any IV anti, so we switched on oral ciprofloxacin and continue IV vancomycin post dialysis. So, and she developed adverse effect with antibiotics like diarrhea, neuropathy, and gastritis. And all these days, the cultures were continuously positive.
Are you sure that the relative is still not giving her introgermina every day?
Yeah, because the patient only reported just administration of 5 to 10 minutes. Patient only reported that this has been given. So the problem then, she had an emergency room visit and she has a acute coronary syndrome, and they've done angiography, and she has a critical TVD sitting in her heart, and the cardiovascular surgeon wanted an urgent fitness to operate on her. So there's another problem. She said you have to really operate her as fast as possible, give her fitness, clear the bacteria. So is there an alternative antimicrobial agent in this case which we can use to fasten up bacteremia? Any thoughts on this?
Fortunately, I have not seen such a case, but I have no idea what to do.
Well, as far as Bacillus is concerned, the alternative literature is there for linezolid and drugs like this. But do you have the MICs?
I forgot.
So what do you remember? What the MICs?
It was good. I think it must be 1 or less than 1. It was good. It was
For
very good.
vancomycin.
Yes. It was very good. So we thought of giving a dalbamycin. Dalbamycin was just there in the market. So we gave. I remember that I discussed that case with you at one time, 1.5 to 2 years ago. So 2 doses of dalbamycin, 1000 milligram, 500 milligram were administered intravenously with the interval of 10 days, and it is basically currently indicated for acute bacterial skin and skin structure infections. But real life clinical practice, it has already been used off label in all other infections. The beautiful thing about dalbamycin is that its half-life is ranging from 149 to 250 hours in most of the human subjects, which allows a weekly dose. So very long half-hour, and most of the literature is around treatment of MRSA and MR cons, and it's been compared, the bacteria are compared in dalbamycin along with vancomycin, and there's nice literature on this, but nobody has used in other gram-positive pathogen. It is being off-label, but there are not much of studies. So after using dalbamycin, subsequent blood culture after 4 days and 2 weeks of completing of 2 doses, the culture did not show growth of Bacillus clausii even after prolonged incubation. So this is the levels of dalbamycin. If you see single dose regimen 1500, first dose and the second dose. So bactericidal concentration for dalbamycin for Staph aureus is continuously high. This is a temporal trend of blood culture. So if you see, the blood cultures become negative on around 47th day, 51st day. We had a first negative blood culture in this case. In most of all 17 cases, the blood culture negativity has come after 75 days. 75. So this is the first case probably where the blood culture has come down within 60 days. We also published this case in CIDS journal last issue. Can I stop here? Any other questions we can discuss? Any thoughts, sir? Patient had a CABG. Patient had a CABG.
So this was an interesting case, Nitin. From a rare interesting case to common scenario, what we face in day-to-day practice, what we have just discussed actually. So this lady is a mother-in-law of an orthopedician to start with. And recently we had seen this lady. So she is a 68-year female. She is diabetic, hypertensive, ischemic heart disease, and in addition, she has autoimmune hepatitis and autoimmune hemolytic anemia. Is on azathioprine for the same. She underwent recently. She underwent she underwent PTCA last year, 2 years back, and now recently she had chest pain for which she underwent PTCA. There were two circumflex stent was done. Post procedure, she had critical thrombus in the femoral artery, which was completely occluding the lumen. So she underwent end arterectomy and venous patch for the same with embolectomy, and this was in March actually. There was a hematoma at the femoral side, so they tried to cover it with a sheath material as such. And the culture outside was Pseudomonas. She was not in Nagpur that time. So this Pseudomonas was a manual MIC. I had asked for further MICs and workup, but that was not available. So we asked her to take colistin-based therapy. She did not tolerate. She had kind of labyrinthitis symptoms, tinnitus, neurotoxicity, and they stopped it. So with this background, she came to us. She got admitted, and the workup showed yes, there was hematoma, there was collection there. So she underwent right upper thigh bone debridement and back. The infected tissue was removed. In addition, there was a clip. So this is a ChatGPT image. I just put the surgical notes in ChatGPT, and ChatGPT gave me these images actually. So the clip was also removed. Interesting. Yeah. So the clip was also removed. The hematoma was removed. Wound was debrided. And the culture histopath is basically chronic inflammation. And we did workup for atypical mycobacterium, all workup. So it was gram-negative bacillus, and again it grew Pseudomonas. So this is a Pseudomonas with a colistin MIC of 2. We have a lady who underwent embolectomy post-procedure. There was a graft there. So how should we manage this? Is it just the antibiotic therapy, or we need to think beyond this? And what should be the antibiotic choice with this? And do we need further investigations before planning something?
Pseudomonas is not blood culture, no? It is wound culture.
We did blood culture. Blood culture is negative. There is no evidence of septic embolia anywhere. It is just a localized disease. But this is Pseudomonas with prior history of neurotoxicity, and a lady who is diabetic, 68-year female.
See, at least in Jupiter Hospital, 50% or even a little more than 50% of them are susceptible to Cas-Avi Astronym. Okay, so can't tell you that to do here because I don't know that, but at least there I would definitely look at it and see whether that option is available. If that option is available, certainly I'd like to use it.
She was put on Cas-Avi Astro.
But
because
without
history of colistin neurotoxicity.
No, but was it demonstrated to be effective or not?
We do have BioFire which shows it is NDM and WIM.
WIM, okay.
And the illusion was negative. Synergy was negative.
Was negative.
Negative. So what are the treatment options now? Can we continue Cas-Avi Astro despite of synergy being negative?
No, so I think, as sir is saying, from Cas-Avi Astronym, just the synergy being negative would only be one part of it. Because again, if you look at the way most synergy methods are standardized, it will just give you a concentration of 644. So really, if this is a patient in whom I would like to know the accurate MIC. So one thing to do would be, doing something like an Astronym Avibactam E strip. then changing around the concentration so that we get at least something like 644 and then 15, 10, 10. So at least I know that the MIC is somewhere between 6 and 50, because up to 8, 12, with especially in patients who have some renal compromise, it may be possible to optimize, especially now with the Astronam avibactam dosing. Yeah, so all these things can be looked into. The other options, of course, here, plasmomycin, I wouldn't expect plasmomycin to work in this kind of a picture with CR Pseudomonas. Ceftazidime without MICs, again, if you look at, you showed that it was producing NDM and WIN. So for most NDM producing isolates, the resistance is anywhere between 5 to 10%. So ceftazidime without MICs, you have a 90% chance of it being sensitive, but again, that's a guess. Cefepime zidibactam is an option. Again, colistin neurotoxicity, she really didn't have a neuromuscular blockade or any such toxicity, probably had some tinnitus. So maybe worthwhile, switching to something like a polymyxin with a combination with phosphomycin. So these would be your options, but I think I'll first optimize the diagnostics of Cas-Avy-Astronam.
Okay, you just show the chat GPT related wound images. So was the actual wound similar to that?
Yeah, it was.
Can we go back to them? Okay. So why?
I specifically asked the
why-
plastic surgeon whether the graft is infected or not, and he was like, no, there is a good tissue in between, and he doesn't feel graft is infected.
All right. So why not give local neosporin powder? Neosporin contains a good amount of polymyxin, or if you don't want to do that, you can actually put colistin powder. Also, if it is amounting to a local therapy, one can do it, or colistin beads.
I've never tried
To
that.
fill that.
So up to 1 to 2 million units of colistin you can soak in a gauze and just let it reside there for the entire day. We treat a lot of skin or soft tissue infections in patients who are not able to tolerate systemic therapy or don't need systemic therapy, as long as there is no deep focus or like you said, osteomyelitis or these things have been ruled out.
So this lady, actually, we did give her poly-B and phosphomycin, and we gave it over 3-4 hours infusion. But the moment she started on this, she had perioral tingling, heaviness in tongue, mucosal swelling as such, and a severe headache to the extent neuro had to be involved. We did MRI, MRI was normal, so though nothing, we couldn't find anything. So probably it was poly-B or something else. And then husband said she had similar history to oral phosphomycin long back. So now poly-B and phospho both are out. And in addition, there is drop in hemoglobin. The steroid is escalated. We cannot give her transfusions because that is not available. So as I spoke to Wokat people, cefepime zidibactam was not available. It is yet to be imported. Cefiderocol, the MICs was not available. So practically, how should we go about it? I
What
spoke
was
to
the
Dr.
GFR?
Balaji.
What was the GFR?
GFR, the creatinine was normal. It's a normal creatinine. 0.7, 0.6, yeah.
And how old is this patient?
68-year female. Yeah, so we strongly felt this is poly-B and not phosphomycin, but then when a doctor husband said she had similar reaction to phosphomycin, we could use phosphomycin also. So she was continued on Cas-Avy-Astro as such. Subsequently, it was stopped. They decided to take her somewhere else. But then I happened to Dr. Balaji, and he said in time kill assays, plasmomycin, Astronam, all this has been studied. So a word about it. Combinations. Can we combine plasmomycin for Pseudomonas? Can we combine plasmomycin plus Astronam or phosphomycin plus Astronam something?
Plasmomycin plus phosphomycin, but that's more for the enterobacter, say that their data. So the other option here
Phosphomycin and
is
Astronam avibactam.
so or Cas-Avy Astronam plus phosphomycin has also been studied as a regimen for really refractory cases of Pseudomonas because there is some upregulation of the PBPs with phosphomycin. So, but again, as Sir said, it really depends on how aggressive of a systemic therapy you need for this patient. Otherwise, probably I will, if you really need that, I would probably give her local polymyxin plus or minus something like a Cas-Avy Astronam plus phospho systemically.
So this lady, subsequently everything was stopped and she is discharged, and as of now she is doing good. I guess it's been a month. She is doing good. Wound is fine. So probably just a superficial infection, but will we keep a possibility of a vascular injury or endovascular infection in mind?
Sufficient number has been done. Maybe you can also do an imaging to see whether any thrombophlebitis. This was an arterial patch or what was it? Venous patch?
Venous patch.
Venous patch. No? So thrombophlebitis can be ruled out by doing Dopplers and maybe keep a follow up on that. If it was only subcutaneous, maybe local therapy would be enough, or maybe nothing also would work.
Yeah. Would also probably monitor a CRP for whatever it's worth.
So I guess a word for practicing everyone is Casavi Estionum, we need MICs, we need e-stick, we need to use Estionum avibactam e-stick also rather than just Splend, especially for Pseudomonas.
Right.
Are we going to take next case? No, done. Okay. Yeah, thank you. Thank you, sir.
Moderators.
कारवा आगे बढ़ाते हुए we would now like to invite our fantastic team of expert panelists for the next two sessions. Dr. Makarand Dhopawkar sir, who is a senior orthopedic surgeon and director of Prasad Hospital, Nagpur. Dr. Sunita Gajbie, professor and HOD, Department of Microbiology, GMC, Nagpur. Dr. Sanjay Kriplani, consultant intensivist at Max Hospital, Nagpur.
Next topic is antimicrobial prophylaxis in surgical patient by Dr. Ashwini Taide ma'am. Surgical prophylaxis is the field filled with habit rather than evidence. We have all seen the just one more dose reflex. To help us but these myths and facts, we will invite Dr. Ashwini Taide ma'am.
Good afternoon all. I have been an odd man out in this gathering, being an orthopedic surgeon, listening to names of various unknown antibiotics and organisms for last 2 hours. And now comes something which is of some interest to me as an orthopedic surgeon, because surgical site infection continues to be one of the most dreadful complications in spite of all the advancements in OT protocols, OT room setups. In spite of that, this is a complication which can be very easily prevented using good antibiotic prophylaxis. So now I request Dr. Mrs. Ashwini Taide to give a talk on prevention of surgical site infections by antibiotic prophylaxis. Dr. Taide.
Thank you, sir. I would say not odd one out, actually easy to handle because orthopedicians are cool on antibiotic and they listen to the advice. And they are really afraid of their implants, so they don't play with the antibiotics much. So what we are taught is the very first requirement in a hospital or physician or surgeon is that we should do no harm, even if we are not benefiting someone. And finding a SSI in hospital, it's like this, because half of the time it's not reported. So if you ask SSI rate, probably SSI reported in a month can be 0 also. So we really have to dig it hard to find the SSI, and there should be zero tolerance for it because we know the comorbidity and complication associated with SSI is humongous. So, and it has a significant impact on antimicrobial stewardship, antibiotic prescribing. So hand hygiene compliance and aseptic protocol holds a big place when we talk about surgical prophylaxis or SSI. So SSI definitions are pretty clear. Basically, the time window is 30 days if there is no implant and 90 days if there is an implant. And there should be one of it, there should be a purulent drainage on the site. Organism should be identified aseptically from the aseptic specimen. The incision should be deliberately opened by the surgeon with the signs of infection or if there is any abscess to it. So how do we define SSI? Basically, it is superficial, deep incisional and organ space SSI. And the other important point is date of event. So how do we label date of event? Like I said, 30 days surveillance and 90 days surveillance. So basically, it should come within that window and it is involving the first incision. There is something called as pathos which is present at the time of surgery. So this should be classified. The wound must have purulent drainage, a positive culture, or be open at the exact time of operative procedure. And this is a clear-cut list wherein we have to do the surveillance for 30 days and 90 days. So 90 days the list is limited, but we should keep that in mind. So if you look at clean, the surgical prophylaxis basically is required for clean and clean contaminated. For contaminated and dirty wounds, it is therapy and it is not prophylaxis, because the risk of infection without prophylaxis, if you look at contaminated and dirty, it's way too high. So what we give is treatment and it is not prophylaxis. So what we are targeting when we talk about surgical prophylaxis is clean and clean contaminated. So clean injury without prophylaxis, the risk is 1 to 2%. So clean cases, you need prophylaxis only if it is high risk procedure. And clean contaminated, the risk of prophylaxis, without prophylaxis, the risk of SSI is 6 to 9%. And that's why we have to give surgical antibiotic prophylaxis here in clean contaminated cases. The principles for surgical prophylaxis are basically the antimicrobial prophylaxis should be administered if there is a risk of infection in absence of prophylactic agent. So like we have seen the risk. Clean procedure rarely require the prophylaxis unless high risk, and that high risk is basically implant. It can be a transplant patient, it can be elderly, someone who is immunocompromised. So these kind of patient, even if you are going for clean cases, we have to offer surgical prophylaxis. So 6 pillars of surgical antimicrobial prescribing is right indication. So basically clean and clean contaminated. Right antimicrobial, which targets the local pathogen, which is skin, bowel flora, considering the accessibility. Right route, which is IV. Right duration, it's just single shot, and we have to extend the surgical prophylaxis only if the surgery is extending beyond 3 hours, if there is blood loss more than 1500 ml. And right timing is critical pre-incision window, and dose is based on the antibiotic what we are choosing. So how long do we give the antimicrobial prophylaxis? And this is clearly WHO, all guidelines have clearly said that it is just single shot antibiotic which is required, and it should be, what should be the window when we have to give it? So there are studies wherein they have compared more than 120 minutes, they have compared 0 to 120 minutes and too late. So odds of getting SSI are way too high if we cross this window, and that's why it is within that window. So if you look at this, the golden window is basically within the incision. It is basically up to 60 minutes. The risk of SSI is way too lower. So here if we see the incision, beyond incision, the risk of SSI is way too high. And before the incision, up to 30 to 60 minutes, the risk of SSI is low. And that's why it is before the incision, because the prime intent of giving surgical prophylaxis is covering the transient bacteremia at the time of incision, and that's what we have to cover for. So basically we have to give it before 30 to 60 minutes. So whether it is 30 minutes or 60 minutes, so there was not much difference between 30 to 60 minutes. But for ease of administration, there are antibiotics which need prolonged infusion. So we have to give it within 1 hour before the incision, and that is what the dictum is. Stopping, as I said, we have to stop it single shot. All guidelines support it, be it international standard, WHO, JAMA articles, everyone supports single shot antibiotic. And we need to differentiate prophylaxis versus therapy, because all of us are comfortable continuing surgical prophylaxis beyond surgery till the drains are there, till catheter is there, and that should not be done, because, and especially for dirty and contaminated cases, as we have discussed, that is therapy and it is not prophylaxis. So there was a study by Indian Survey of Surgical Antimicrobial Prophylaxis, and what they found that timing compliance was high and dosing compliance was 75%. Only 68% of surgeons, however, they chose the correct targeted antibiotic, and only 63% adhered to correct duration guideline. Only 52% of them demonstrated 100% compliance, which is practically very difficult, because giving single shot antibiotic in that time window with a compliant antibiotic is hardly happening. So we need to do a lot when we think about the surgical prophylaxis. So choosing a right antibiotic, basically it should stick to the spectrum according to the local flora of surgical site. Majority of the site it is cefazolin, but then when we go below diaphragm, we have to know what bugs we are covering, and we have to change our antimicrobial prophylaxis based on that. So this is ICMR data, as I said, majority of this above diaphragm, what we target is coagulase negative staph or staph. These are the resident flora and we have to cover for that. So your cefazolin is good enough. But when we go below diaphragm, we have to cover for gram negatives, we have to cover for anaerobes, especially in urological procedure, we have to cover for the bugs which are there, which we normally neglect as asymptomatic bacteriuria. So guidelines are clear cut. This is again ICMR and it is available at ICMR and everyone says it is single shot. For genitourinary, again it is based on the culture based, we have to take a call. For abdominal surgeries, we have to keep in mind that proximal segment we have to cover for gram-positive bacteria, and for distal segment we have to cover for gram-positive, gram-negative and anaerobes, and that's why metronidazole is added. This is NHSN, so they don't have cover for ESBL, but when we have to cover for bowel, actually we have to cover for ESBL, so it can be piperacillin tazobactam, which covers your ESBL, it covers enterococcus, and it gives good anaerobic coverage. So if we have to plan a surgical prophylaxis for a GI surgery, I guess piperacillin tazobactam is a good choice for prophylaxis. We'll just keep urological procedure basic. There are 2-3 fundamentals we need to know. Asymptomatic bacteriuria should be treated only if there is mucosal barrier breach. Otherwise, we don't have to cover for asymptomatic bacteriuria. Rather, screening for asymptomatic bacteriuria or urine culture is not recommended for all urological procedures, and there are clear-cut guidelines including the prostatic biopsy, TORP, the ESWL, all these procedures wherein we need to cover or not, and we can go through these guidelines in detail. What about the cesarean sections? So postnatal infections are the prime focus when we talk about surgical prophylaxis in Caesar sections, and the targets, what we are targeting is Staphylococcus, Enterococci, anaerobes and ureoplasma or mycoplasma. These are the common bugs which leads to chorioamnionitis, and the risk is 3 to 8-fold higher if that is not covered at the time of Caesarean section. So the guideline says basically single shot surgical prophylaxis at the time of incision, not at the time of clamp, and that has reduced almost 60 to 70% reduction of postpartum endometriosis, and almost 30 to 65% reduction in wound infection was seen when the surgical prophylaxis was planned properly. So it says, the WHO guideline clearly says first generation cephalosporin is good enough for LSCS surgeries. What about orthosurgeries? So it is again just gram positive we have to cover, so cefazolin is good enough for orthosurgeries. And the important point is, when you have implant like prosthetic joint infection, how should we plan your surgical prophylaxis? So the guideline says, in cases in which prosthetic joint is diagnosed or suspected, a pathogen has yet to be identified, use of prophylactic antibiotic is dependent upon clinical judgment, because prior antibiotic can cut down your yield of culture for the prosthetic joint. So majority of the guideline previously used to say no antibiotic till you collect your sample. However, this update, they have kept it open and they have said it is up to clinical judgment. So even if you are giving it is single shot antibiotic before you open it. There are beyond antibiotic, there are bundle which needs to be followed, like glycemic bundle. The blood sugar has to be maintained below 200. Skin preparation, alcohol-based antisepsis has proven to cut down the SSI rate. Normothermia and maintaining oxygen at the time of surgery has proven to be helpful in cutting down the SSI. So basically, SSI, it remains a leading healthcare associated infection while highly preventable, and eradication, it needs rigorous system-wide adherence to evidence-based protocol. We have to have the bundles what I have showed, SSI bundle. A perfect execution relies on 6 rights of surgical antibiotic prophylaxis, and most critical of which is given your surgical prophylaxis within that 60-minute window. And the mandate, especially when we are in an era of drug-resistant bug, is single-shot antibiotic, and there should be zero tolerance for that single-shot antibiotic. And hand hygiene is proven to be one of the best, easiest, and cheapest tool to prevent all HAI device-associated infection and SSI also. So there should be zero tolerance for poor compliance with hand hygiene. So the ultimate protocol basically is, we have to classify, we have to select antibiotic based on the area what we are targeting.
infuse the antibiotic within the golden period, give full dose so that the intraoperative concentration is maintained, discontinue immediately, definitely not exceeding 24 hours, and maintain rest of the burden. Thank you for the patient listening.
Dr. Ashwini. I just wanted to know, you said cefazolin. We used to get Reflin before.
We do get cefazolin now also.
By what name?
The brand name I don't recollect.
It is not very easy. Reflin we used to get from Ranbaxy in the previous
It
day.
is available, so cefazolin is available and we use it.
Okay, because
There are two companies giving cefazolin
okay,
and it
okay.
is available.
And if not cefazolin, there were many allergies when we used to use cefazolin when it was available very routinely. There were few patients with allergies to cefazolin. So any second choice we are routinely using.
If there is cephalosporin allergy, then the surgical prophylaxis can be astronam, it can be clindamycin, so we have to get a detailed history.
Any questions from the audience?
Ashwini, I have a question. Say, they say clean surgery, single shot antibiotic. Now, if in bowel is being opened, say it's elective surgery, but yes, gallbladder कर रहे हैं हम. लेकिन आपका तो bile duct तो खुलता ही है ना, clip लगती है, लेकिन खुलता ही है, spill होता है. तो would you call it a clean surgery? से bowel open करके धो धा के close कर दिया. There is no other peritonitis or something is there. तो say vaginal surgery, vault तो open होता है. There are bugs in the vagina, right? So would you call it a clean surgery?
It is clean contaminated, it is not clean. And clean contaminated, you have to give surgical prophylaxis.
Can you continue the antibiotics after the surgery?
No, it is
the same antibiotics after the surgery.
It is single shot. If you are
Thank you.
Thank you, Dr. Ashwini.
Thank you, Ashwini. Very sharp and incredibly evidence-based.
Now I request Dr. Deepak Jaswani sir to please felicitate Dr. Ashwini Taide. Are
Fear which is it's a fear everywhere. Everywhere.
Managing an ICU without infection control is like trying to bail out the leaking boat with a teaspoon. To show us how to plug the leaks and manage a full-blown outbreak when it happens, please welcome Dr. Nitin on dais. Dr. Nitin, the dais is yours.
Thank you, sir. Thank you again. And I've just taken a little liberty on speaking on this subject. So, rather than ICU, I've just put a transplant ICU. The reason is that we have recently discussed these things with Indian Society of Organ Transplantation program a couple of days ago. So, I think many of us in intensive care and all of us know what are the routine things in infection control in ICU. So I thought I'll just discuss things related to transplant setting also. So if you see, we have now more and more patients in our ICUs who have immune dysfunction. So, and this immune dysfunction, the spectrum of immune dysfunction varies between a minimal marginal immune dysfunction to the severe immune dysfunction. So if you see patients who have advanced CKD, patients who are post solid organ transplant, and patients who have post hematopoietic stem cell transplants, they have profound immunodeficiency, and infection control becomes very, very important for these type of patients. And I think if you see any ICU, whether it's a small 30-bedded hospital or 50-bedded, 100, 300-bedded hospital, almost all the hospitals see these kind of patients for some or other medical reasons. So there's a 30% increased risk in immunosuppressed patient. I'm not just talking only about post-transplant. And there's increased vulnerability, and the impact is very high because the average length of stay of these patients is very high in ICU as well as in the hospital. So, and these are the infections you immediately see in many of the post-transplant patients. But these infections are now nowadays common in other immunosuppressed cadres also. So number one thing in hospitals, all the hospitals, hand hygiene has become a typical corner store, the golden rule, everything. So hand hygiene has seeped into all guidelines, accreditation, healthcare standards, and all of us know that it is very important that everybody is in gaga or hand hygiene. But one important thing everybody must understand that hand hygiene is not the only method where you try to prevent infections. Not all transmission routes are hand mediated. So you have airborne, droplet, direct contact with contaminated devices, surfaces, and they just can pass hand hygiene. So hand hygiene is basically focused on reduction of pathogen. Hand hygiene can never ever eradicate pathogens in the hospital. So sometimes it can be overrated that hammering only on hand hygiene and ignoring other things. Number two is isolation precautions. Most of the ICUs do not have isolation rooms in smaller setups. So isolation precaution is not only a physical enclosement, it is basically a behavior difference. So we must understand when to employ contact precautions, when to apply droplet precautions, and when to employ airborne precautions, because our ICUs will always have these type of patients who are going to be harmed if we do not use these precautions. So courting the patients to prevent these type of infections is very, very important, and everyone must know the proper donning of PPEs. So protective environment rooms, PE rooms, again, many small hospitals would not have PE rooms, and as thought earlier, making PE rooms is actually not that expensive. So you can create positive pressure rooms in your ICU, even if the building construction is already done. So a positive pressure environment had a mild, more positive pressure than the surroundings, and they're equipped with HEPA filters. So it is an efficiency of 99.99% efficiency for 0.3 micron particles, and minimum 12 air changes per hour, which is required in many of the transplant settings. And sealed rooms with minimal gaps around doors and windows, and most of the PE rooms require an anti-room adjacent to it. So I think every healthcare organization, small or large, should think of PE rooms in their ICU so that they can practice infection control in a better way. They can protect their patients. A continuous surveillance and screening for MDROs is also required. So comprehensive testing on admission, looking at the baseline risk assessment, and the patients who are having extended stays, you have to look for MDROs and screen them for MRSA, VREs, and try to understand the local epidemiologic pattern and try to understand how we can get rid of this. This needs identification and then addressing those issues. Then stewardship, so much is always talked about stewardship. So whether it's a transplant purview or non-transplant purviews, our patients are immunosuppressed. More antibiotic you prescribe, you are going to fuel more antimicrobial resistance. So it is very important. So do not use antibiotics as a reflex. You use it. Try to understand the difference between colonization, contamination, and a true pathogen, which is a difficult task. But however, you can really take use of all the instruments. You can use molecular assays, basic microbiology, your clinical acumen. You can differentiate between contamination, true pathogen, and colonization. So try to use antibiotics appropriately. The fifth is environmental cleaning and disinfection, and most of the times infection control is thought about only this, that there has to be cleaning. There's a lot of other things, but yes, environmental cleaning and disinfection is very, very important. And most of people do not know what type of disinfectant they are using in the hospital. So you must know the chemical composition of disinfectant, the contact time, and which disinfectant should be used in which particular area, how to disinfect medical equipments, how to disinfect high-touch surface protocol, how to monitor air quality, water quality, surface quality. So it is extremely important that in ICU we have all the processes in place where we can monitor the quality of all the surfaces and all the media. Then the management of careful management of invasive devices. So most of the patients are in some or other device. So whether the device is really necessary, so do an assessment every day whether it is required or not required using aseptic technique, and daily reevaluation whether if the device is not required, please get it out. So careful management of invasive devices is important. And then education of the family. So in transplant setting or non-transplant setting, because one of the common nosocomial transmission, the way how nosocomial transmissions happen in the hospital is actually I've noted that visitors bring more infections than the healthcare staff. So transmission of viral infection, transmission of food-related infections happens quite commonly through the visitors. So this is one of the example where patient education is important, and even after going home, so educating them regarding the antibiotics, basic hygiene, a lot of things are important, which needs to be taken care of the other people's routine. So and the most important is device-related infections, WAP, COTI, C, DEEP, CRB, SI. So I think there are already there is a guidance on this. So there's a very nice guidance which gets updated periodically. So everybody must go through these strategies, make a checklist, follow checklist, look at the compliance of checklist every month in the hospitals. So that way you can really prevent the infections in the devices. And the last but not least is management of outbreak. Outbreak management is a big topic in infection control, and it is not easy. And there are several examples of outbreaks. So the whole problem with outbreaks is most of the times they are not getting detected. You must have seen sometimes in a hospital you will continue to get burkholderia, you will continue to get Stenotrochomonas. Burkholderia is very common in many patients. Chronic liver disease patients, you'll get a series of burkholderia in burkholderia secretion in many patients. To really find out why, detect the outbreak, find out why it is happening. It really requires a CID work, and then do a root cause analysis and terminate that outbreak. So I remember one case, one outbreak investigated where all patients after CABG developed Pseudomonas. There's some species, I forgot the species. So there's Pseudomonas infections of the surgical site, and some patients have had bacteremias. So there are around 7 to 8 cases which happen in 3 months. And we were not understanding why this is happening. So we really investigated everything, and we found one Caesar which surgeons were used to cut something at the end of CABG. So we found that was the source of that particular infection. So after removing Caesar, we got rid of the infection. So, and there are several examples in neonatal ICUs. Again, you have always risk of seeing waterborne pathogens coming into the nursery and then just not going. Similarly, I've seen several examples where Ralstonia piccati will be coming into the dialysis water and causing outbreaks in many hospitals, and very, very difficult. You have to really change the entire pipeline, RO, and everything to look into everything. I mean, it is because of Ralstonia piccati we got to know after 3 months. And then we started working behind to, we realized. Then recently I have investigated one outbreak, not in Nagpur, somewhere else, and it is basically an NTM, a wound site infection. Around 50-60 patients in a series 3 months develop NTM wound infection, same pathogen, mycobacterium abscesses, and it is present everywhere in the hospital and very, very difficult to get rid of. So outbreaks are very common in the hospital. You have to always constantly keeping that mind. Detection is very difficult. Doing a root cause analysis is very difficult. You have to go back, do a CID work, find out, and then terminate it. So in certain cases, you have to really close that unit for some time, and then only you can get rid of it. So this is I think next this weekend I have a lot of cases on this. We can do case in next Criticare Convention, 5th Criticare Convention. It's very interesting how we found it in cath labs, in dialysis units, in neonatal nurseries. Very common. Let I just finish it off because time is running, and we have one more panel to go. Let's stop it.
Thank you for this wonderful presentation. It just reminds me that most important tool in ICU is not a costly ventilator, but the simple bottle of hand rub and the site protocols. Thank you, Doctor.
Excellent talk by Nitin.
Request Dr. Deepak to felicitate Dr. Nitin with the token of love and appreciation. I also request Chairperson to accompany Dr. Nitin and Dr. Shinde. अरे यार
as we are nearing the lunch hour and feeling lightheaded with thoughts of lunch, here comes the heaviest topic. In ICU, we don't always have the luxury of black and white. We live in gray. So the topic is dilemmas to decision. So delegates, let's pay some attention as we are having the finest navigators as our moderators, Dr. Nikhil Balanke sir and Dr. Deepak Jeswani sir. And they aren't alone. We have a formidable clinical jury of experts, Dr. Geetu Jo ma'am, Dr. Ashwini Taiba ma'am, and Dr. Nitin Shinde.
I've already heard words like hypoglycemia, hypoglycemia. It is the word keywords.
ये मोनिका बहुत भारी भारी स्टेटमेंट बोल के we will not make it heavy. We will still make it light. And we assure you, after on 11th minute we will be in the lunch hour. So like 10 minutes. But the thing is that we have some very important things to be discussed because what we have been trained few questions are every day in and day out we have this problem. So let us not go in details of it, but as we all know, like shock or refractory shock for that matter, septic shock, refractory shock are a nightmare for every intensivist managing their patients. And we all have been using vasopressors in different doses, adding few more vasopressors. Finally, we end up by the most debatable medicine called steroids. But though it is still debatable, it is still a decisive one. Most of us end up by using it. Now the questions are when, how much, why. So the questions are, anyone can take it. Geetu, you have you have an immunity for these questions. So, but you can answer if you feel so. So the current guidelines say that the use of steroids, they have a debatable thing. So, but the question is, when should we say that patient has refractory shock? Because we say use steroid in refractory shock. So when should we think of that this is a refractory shock?
So if patient is in double inotropes with maximum capacity and the blood pressure is not getting up 24 to 40 years, so that is the time when you say it is a refractory shock. But do you want to wait for that time?
Yes, that's what the next question would be like. We say double dose of vasopressor, and still you have not reached your goals. So then we say you add steroid. These are the guidelines. So the question to you is, should we wait for that time to come, or should we start it straight away when you have a patient who has a multi-organ dysfunction, shock, and you know this is going to be a refractory shock? So when would you like to start?
Because guidelines say only 30%, less than 30% of cases actually have a refractory shock. Do you agree to that?
No, more than that.
Only less than 30%. That's a statement in the guideline. Only less than 30% patients have a refractory shock. So when they develop a refractory shock, then you use the steroid. That's the statement. Do you agree to that?
No, I don't think anyone all agree early.
Yes. Yes, we should start early because I really believe in the terminology Sarkai. Corticosteroid insufficient, critically ill patients. Sarkai is the real thing. Sarkai is the real thing. I'm very happy that you don't have to really look into fasting and 4 p.m. cortisol level. You do random cortisol, you see that and you decide. So patients who are critically sick in the ICU, they are stressed and their cortisol level should be high. So if their cortisol levels are really low, they need. So I think if you have a patient in a shock, you can just do a random cortisol, see, and then initiate steroids.
True. So I think take-home message can be, if you have started the patient on vasopressors, in next 8 hours, if you don't see a positive change, and if your lactate continue to remain same, I don't think we should wait longer than that, or wait for the refractory shock and initiate steroid straight away. Even the guidelines, like as you said, we can do a cortisol level. Even that need not be done all the time, because all those hormones of fright and flight, cortisol, somatostatin, glucagon, whatever, epinephrine, norepinephrine, all of them are going to go up. So it's not all the time we'll find them going down. The second thing is, would we like to add fluorocortisone to these patients.
So I don't think if you give a broad spectrum steroid, you don't need a fluorocortisone.
Ashwini, you have something to say?
It's critical care, so I don't think I should.
So the answer is no. You need not add fluorocortisone to all the patients. Only thing is, if you start with steroid, like the defined dose is around 200 milligrams a day, it can be given in 2 doses. And if you find that still your lactates are not sort of improving, you can think of adding. There is no paper to say that adding fluorocortisone is making an increase in mortality, but it's not going to change the outcome as such. All the trials which have been, the adrenal, the apertures, all of them have shown that it doesn't make big change, but in few patients, you can take a call and you can still add.
Most of the fear about steroids is basically because of their adverse effect and their ability to suppress HPA axis. But there are enough study that a steroid which is 200 milligram per day, daily for 7 days, does not result in increased CRBSI or increased pneumonia or increased catheter-associated urinary tract infection. There are a lot of papers on that. So this much of steroid you can safely give without any risk of having a secondary infection.
At the same time, adrenal has shown that steroid has not even improved mortality benefits. So both ways. But apertures has shown that the only trial which has shown adding fluorocortisone is going to have a benefit. Take a call. I think it has to be. Most of the things have been.
Can I ask one query, sir?
Yes.
Will it cause ICU aspergillosis, IAPA, because the steroids?
No, less than 1 week.
Okay.
Less than 1 week. So
Not
if you
prolonged.
Most of the time,
your area par within 1 week.
by the time you reach that level, I think the patient takes his own decision. So Deepak,
And most of these trials on steroids with severe sepsis, they say that you have to add steroids when there is escalating dose of noradrenaline beyond 0.25 mics per kg per minute. And second, it improves your physiology, blood pressure map, but it doesn't improve your mortality. But at least we have that period tied up that blood pressure and hemodynamics improve.
only bedside thing which we can take a call to add steroid early is if you are moving from your first dose, the initiating dose of noradrenaline, and you're rising up to the next dose. After you increase the dose, within 1 hour, check the lactates. If increasing noradrenaline is improving lactates, stay well. If increasing norep is not improving lactates, I think you are not going to do well. So take a call straight away.
Next issue is procalcitonin, Ashwini, Nitin. We very often use procalcitonin as a biomarker. We all know it's a biomarker of sepsis. Now, when do you actually use procalcitonin for initiation of antibiotics or for any other diagnosis of sepsis? When do you take help of PCT?
Procalcitonin is been studied well for de-escalation, and it's been proven that it works really well when you use it for de-escalation. But doing sequential procalcitonin for de-escalation, it's really a costly affair, so probably we don't practice it so often. When we are stuck in a situation wherein it is difficult to establish whether the inoculum is very high and we need to stop antibiotic, probably in that situation, procalcitonin will help for de-escalation. For escalation, procalcitonin does help, especially to differentiate candida versus bacterial infection. But then that has to be taken with pinch of salt. So many times we see procalcitonin is normal. We feel this is candida, and day second, because you feel the source is probably some device associated infection and it's likely to be bacteria. You repeat the procalcitonin next day and you will find a very high procalcitonin. So that has to be taken with pinch of salt, and I guess the best judgment will be clinical judgment. You need to find out a source, then get a procalcitonin. For community acquired sepsis, yes, procalcitonin will be helpful to differentiate viral versus bacterial, and that will be a good antimicrobial stewardship tool to save antibiotics.
And most of the time we see that PCT levels are very high, and there is hardly any evidence of sepsis or not a severe sepsis. So any
False
reason for
positive
false
can be there,
positive?
renal failure, post-op,
Post-MI also, there are high PCTs reported. Post-procedure, your procalcitonin can be high.
And even in neutropenic patient also you might see very high.
Compromise. Even few malignancies can, like small cell carcinoma, you have very high PCT levels. So
Yeah, so there
trauma,
has to be a
burns.
word of caution for all these patients.
Sometimes even if you find the patient is improving, he is doing good, all the parameters are improving, and procalcitonin is
Very high, very high.
Like what?
These are the scenarios when PCT is very high, but patient is doing well on antibiotics. So what do you do in that
It
case?
takes times to fall. In the most catchier, procalcitonin is actually a very nice guy. In theory, it is one of the ideal biomarker in theory, but in practice it behaves very different. So it does not fall. Look at the renal dysfunction. Most of the times renal dysfunction is the problem. It does not fall. More than 100. After even 3 days of effective, appropriate antibiotic therapy, it will just not fall because of renal issues, number one. Number two issue is that there is always inflammation associated with infection. So even if there is a purely inflammation, it will just not fall. So there's a problem. So and false positive procalcitonin is also there. So many autoimmune conditions, your pancreatitis, your SIRS procalcitonin will be very, very high. So it's not that strict. And I always think that it's all kinetics of CRP and kinetics of procal. So procal will take 24 hours to fall, CRP will take 12 hours to fall. But ideally they say procalcitonin is first to fall. But if you see, CRP is first to fall. So because every patient is different, every patient has a GFR is different, the source of infection is different. So this does not happen in real world. So but if you compare the kinetics of CRP and procal together, you will have more information actually. The only useful thing about procalcitonin is that one is yes, bacterial infection, yes. Number two is that coming down, let's stop the antibiotics. I think these are only two important, consistent information which it delivers.
CRP is a better tool to take for clinical response when you know.
Sometimes you have PCT negative sepsis. You have in short.
Procalcitonin negative sepsis, one scenario I told wherein your procalcitonin is taking time to go up. So in the beginning of initial sepsis, probably you will have false negative procalcitonin. Candida is one thing wherein you will have negative PCT and your patient will be in sepsis.
Inflammation related to abscesses will get PCT negative.
Or if there is a concealed localized focus, then yes, you can have.
I think we can.
And do not use procalcitonin for thinking is a pneumonia is bacterial viral. It is a wrong way of using procalcitonin. So you are trying to strong procalcitonin, which is whether viral, atypical or bacterial pneumonia, it is not going to spike.
So dictum that it has got negative predictive value, it almost rules out bacterial infection if it is negative. Is it correct?
Initial stage of bacterial infection.
I will again say clinical acumen is very important. Yeah. So know this
Now the
syndrome.
question will be to the most happiest person on the dais, and let the two person who are answering, you can enjoy for 3 minutes. So Gitu, this is for you, or this is regarding the rapid diagnostic test in ICU. As we know, molecular panels, rapid blood culture panels, viral diagnostics. And so, just tell us in short about the utility of this rapid diagnostic in ICU.
Rapid diagnostics in ICU, one, it helps us to convert from our empiric therapy into targeted therapy as soon as possible. Once you know what is you already have an idea of the clinical syndrome, sir. You as intensivist would have started a empiric therapy broadly covering, but that broad coverage can be narrowed down. You will be able to target your therapy. And in several cases also, be it infection control in the ICU, you want to isolate the patient, those decisions also can be taken. If you're using, say, biofires, multiplex PCR panels, etc., etc. When it comes to therapy, a few cases we had shown in our presentations also, where you want to identify which is the carbapenem resistance genes that can be quickly performed. Based on that, you can switch Casavi-Astronam to only Casavi, maybe. Or sometimes even Astronam will be sufficient if you have ruled out all other resistance markers, for example. Certain POCT tests like urinary antigen tests, be it strep pneumo, Legionella, they also, though they have less sensitivity, specificity in certain scenarios again altered. But yeah, if you have a proper clinical syndrome, then you can narrow down further. So and henceforth, Ashwini ma'am, do you want?
Everyone.
Panels or blue panels again is, I guess.
Look, India.
Even tropical fever panels are now quite trending because it directly gives your dengue, chikungunya, lepto, malaria, any kind of tropical illnesses. Within 2 hours, you have the result if you are doing it in house. That is also of much help.
If the institute has access to all the rapid diagnostic tests, so when should an intensivist feel like which patients should we order these tests? Like you feel everyone who feel you are in septic should be ordered for these tests?
The one who can pay.
What should not be ordered is blood.
So the limited
preliminary
finance
blood
finances.
PCRs.
But in case if there is no no capping on finances, it would always be beneficial to identify the pathogen
Yes, what
as early as
should not
possible.
order, that also should be clear, because if we order like a blood PCR, we will end up getting a number of bugs which are not a true pathogen, and unnecessarily there will be antimicrobial misuse. So,
Basically, we should also go for FDA approved tests, not go for any fancy panels that way. In-house, we should have a check and say, even clinically, how ID physicians decide. There is clustering of illness, you are suspecting viral, then go for viral respiratory panels. That way, I think we can streamline which diagnostic to
when we
go.
get
based on
pathogens
clinical
from-
syndrome, basically we can plan. So if it is upper respiratory, probably a throat swab for upper respiratory panel, or your gene expert respiratory panel, that will help. If you have a pus pocket or something, secondary infection related to that, then we can send a PCR from that pus directly rather than sending just a blood PCR. Blood multiplex panel, when you have a flag bottle, on that definitely if we are doing BCID, then we can save 24-48 hours of misuse of antibiotics. So that way I guess we can plan and this.
We always believe that these tests give us the pathogen as early as you can imagine. Can you differentiate the colonizers also?
Sir, in respiratory, say, based on bin copies, maybe we can come to a bit of confusion can be solved. The higher the bin copies, the more the existence of that. But otherwise, if you're only detecting the bugs, then I think they have to be clinically correlated. We will not be able to completely
We will
rule
not
out.
be able to differentiate.
No,
so.
no.
Panel is a data, molecular rapid diagnostic data. You cannot just interpret one data center. You have to have all the information. You have to have stain, culture. Do not send just joint panel multiplex
BCI.
panel and just wait for the result and look at that result and decide. You have to have all the information. Gram, stain, culture. If it is joint histopathology, probably gene expert or. But everything you have to have everything. Even if it's a respiratory, then only you take a decision. Otherwise, you're lost in the.
Gitu, ma'am.
So one, I request Getu to comment on the blood multiplex PCR, because there are so many patients who are in sepsis, septic shock, cultures are negative, and people do send blood PCR because they feel they will get an answer. So please.
We have BioFire in-house, ma'am. So predominantly we go with BCID only, and we have lab functioning 24/7. The TAT is no. So BCID can be performed only on the blood positive bottle. Whereas coming to these panels that ma'am mentioned, our experience has not been very fruitful. In fact, we have seen that they grow all the common bugs, and that has not been picked up by the panels. Maybe Dr. Shweta also can add. With a limited experience, we have not been very favorable of these trending blood panels.
Yes, BCID panel, they detect more common pathogen, and we can only use this for acute infection, not for chronic infection. In chronic infection, those multiplex PCR, so many panels are available, like respiratory panel, then meningitis panel. Those panels are more useful.
Even when it is meningitis, if it is community acquired meningitis, yes, the ME panel. But again, if it is hospital acquired, patient has a EBD and all that, then ME panel is of no use. Then maybe your pathogens get covered in the joint infection panel or somewhat. And the advantage of joint infection biofire is you can perform it on the neat specimen. It requires only 0.2 ml of the specimen. In fact, we have used it for a lot of skin and soft tissue infections with very good results.
Gitu, ma'am, you have been using this rapid diagnostic test since long time. What is your experience about the outcome? Does it boils down to improvement in outcome of ICU patients when you use it more often. And what does the literature say?
Sir, coming to my ICU experience, getting the intensivist to de-escalate, or not only the intensivist, the primary team also. So they are ready to perform the test, but when it comes, negative results, now you have to stop the antibiotics. So we understand their fear. They are like, let us wait and watch for another 2 days, let the cultures completely come out. So that is been a challenge. I think the same results are quoted in the literature also, because performing all these high-tech tests, rapid tests, if the de-escalation is not done, then it is merely a waste.
One of the very important point which was raised in the surviving sepsis guidelines after RDTs, they say the outcome, the survival, the length of hospital stay decrease, survival improves if you communicate this test to the ID per consultant and get it modified as soon as possible. That improves outcome. So Ashwini and Nitin, for us, gear up for the same. Thank you.
So I think we have only one last question for the audience, but you have to answer only yes or no. Should we stop for lunch? So let us have other, because no one is saying no. So all the lecture video. Thank you very much, Deepak. Thank you all, Nitin, Geetu, and Ashwini. We had a wonderful interaction, and thank you, Deepak.
A huge round of applause for the panel. We will be breaking for lunch, but before that, the most important thing to do is to be thankful that today we got to witness something extraordinary. Because of the team Criticare's hard work and all of our presence and participation, whichever falls on the shoulders of the most silent, steadfast and extraordinary person, Dr. Deepti Jiswani. I call Deepti Jiswani ma'am to give a vote of thanks. वो कहते हैं ना, फूल यूं ही नहीं खिलते चमन में दोस्तों, फूल यूं ही नहीं खिलते चमन में दोस्तों, कुछ हमने खून जलाया है और कुछ आपने नवाजा है.
Very good afternoon, distinguished guests, esteemed speakers and colleagues. I am truly honored to deliver a vote of thanks as we conclude this 4th Criticare Convention. First, a sincere gratitude to all our faculties for an enlightening presentation. Your knowledge will provide us with a new perspective that will undoubtedly influence our future clinical perspectives. An event of this scale does not happen overnight. It is the result of tireless planning of our organizing committee, volunteers, hotel staff, pharma, Yash Audiovisual, event, and I'm sorry if I'm forgetting anybody. Finally, thank you to each and all of you in the audience. Because of your insightful questions, this session went very interactive, and we hope you leave with a wealth of knowledge. May I request Dr. Deepak to felicitate our organizing committee. Dr. Dilip Chisagar, sir. Dr. Monica Mandal, ma'am. Dr. Shweta Kavalkar, ma'am. Dr. Swapna Khanjade, ma'am. Dr. Anita Kapoor, Dr. Rahul Baghel, Dr. Shailesh Chokse, Now I request my backstage workers who work effortlessly. Sneha, Saima, Tanaya, Smita, Vishnu, Yogesh, Naresh, please come on the stage. I think so. Everybody will be hungry, and we are just extending this. But we are going to have a very good lunch. and hope you enjoy the menu. You all, thank you all. I invite you all for the lunch, please.
मैं आती हूँ घर पे और पहुँचाती हूँ।
काय अभी मैक्सिमम सैटरडे सर गए लगता है सुबह ही चले गए चले गए
हमारा कैसा हॉस्पिटल चल रहा है? उधर ही है ना? आने पड़ता है। कितना 10 बेड कितना बेड?
35
35 बेड है।
6 बेड